pH, if you read the latest ERS ESC guideline, around 1% of world population is getting affected. And with growing population, once you do an echo on a person who is 80-year-old, the incidence increases to 10%. However, how to treat that, still we are not sure. We are diagnosing more patients. And it causes significant mortality and morbidity because sometimes we overtreat or sometimes we undertreat these patients. And the major cause of mortality and morbidity is because of RV dysfunction. Many times symptoms are non-specific and it leads to delay in diagnosis. Most of the time in Western world, the data says that it takes 2 years. And in our country also, we see that patient goes to multiple team of doctors from cardiology, pulmonology, internist, ICU doctor before a final diagnosis is made. What I would like to say that PH is a syndrome and it's not a diagnosis. Our work starts from once we see that echo report or ultrasound in ICU. So some basic definition from ERS 2022, we know that pulmonary hypertension is characterized by elevated PA pressure of more than 20 measured by RSC, while previously it was mean pressure of more than 25. And why it changed from 25 to 20? Because when they did a large study on patients who are young, normal people, the mean pressure is around 14 plus minus 3 standard deviation. So the definition changed to upper normal limit of 20. And they also noticed that even between 20 to 25, each 1 millimeter increase in PA pressure leads to increase in mortality and morbidity. This is one of the most important slides of this presentation. This is the concept from Dr. Paul Wood. He gave this concept in early 1950s and 60s using Ohm's law. He said that to understand pulmonary circulation starting from RV to PA to pulmonary arteries, capillaries, and LA, you should think this as a single tube. And on upstream, you have PA pressure, and on downstream, you have LA pressure, and this tube is affected by vascular tone, surrounding pressure from outside. So he said that there are 3 important contributors which can lead to elevation in PA pressure.
Recording stop.
LA pressure directly, cardiac output, and PVR. So it becomes imperative that anything can lead to change in this PA pressure. And with this basic concept, whenever we see a patient in our critical care areas or in OPD, we try to find out what is the reason. And you can see there are factors which can lead to increase in PA pressure or lower down, and even LA pressure. And so this is the most important concept, that 3 things affect your PA pressure. If you bring your LA pressure down, your PA pressure comes down. If it increases, that is the concept of pulmonary venous pressure. So second most important thing is you have to measure these things accurately. And accurate measurement can happen only with RSC, not with echocardiogram. So we try to classify pH by 2 complementary pathways. First is hemodynamic classification, and for this, you need an RSC. So you do an RSC, you try to measure 3 important things: PA pressure, wedge pressure, and PVR. And you classify them on pre-capillary and post-capillary based on your wedge pressure. So there's some mistake here. In pre-capillary, your wedge pressure should be less than 2, and in post-capillary, your wedge pressure should be high. And these are the common causes of elevated post-capillary, while PAH, CTEPH, lung disease leads to pre-capillary hypertension measured by PA pressure of more than 20 and wedge pressure less than 15 and PVR more than 2. While post-capillary, you have PA pressure more than 20, wedge more than 15, and PVR less than 2. Long-standing patients who have long-standing heart failure or mitral valve, they develop combined where your wedge pressure also increases more than 15 and your PVR is more than 2 also. So that is hemodynamic classification. The next one is, as I said, we have to do both ways. The second is to understand what is the pathology of the disease. So we classify based on that in 5 clinical groups. Group 1 is IPAH, and there you have idiopathic heritable HIV. Group 2 is due to left heart disease. It is very common. Group 3 is due to lung disease, which is second most common. Group 4 is CTEPH, and group 5 is miscellaneous like sarcoid. Only group 1 and group 4 have directly related treatment options, while in group 2 and group 3, we have to give supportive therapy and we have to treat the underlying disease. So this is the global burden of pulmonary hypertension, which says that when you're evaluating a patient of pulmonary hypertension, there is a geographic variation. If you see North America, Europe, and Australia, around 50 to 55% patients of pulmonary hypertension are due to left heart disease. Subsequently, 40% from Middle East, Asia, they have lung disease. However, you also have to notice that in Middle East and in our Asian countries, we have a huge burden of sickle cell disease, as well as in Africa, you have sickle and HIV. So the pH etiology changes with the geography as it changes. So this slide, again from Lancet, it shows the global burden of pH. That was pH, this is PAH. And what it shows that if you see North America, Europe, and Australia, the most common cause in group 1 is idiopathic, 55%, quite matching with each other. But if you see Asia and Africa, they have a huge burden of infection related. South America has highest burden of schistosomiasis related, while in Africa you have HIV related, and in Asia and Middle East we have congenital heart disease also. So these are the things which you have to keep in mind when we are evaluating these patients. Now coming to from global to individual countries. So this pyramid from US tells us about the global burden of pH in US. So you can see that the largest group is group 2. 3 to 4 million people in US are affected with group 2. And if you go up, the second most common is group 3. And now in group 3, around 50% are due to COPD, and in advanced ILD, in 32 to 40%, you develop group 3. Group 4 is more commoner than group 1 and at least 5 times more common than group 1. Group 1 is the rarest among all these. So when we are seeing a patient, you should try to use this epidemiology so that we can reach the correct diagnosis. So do we have anything from India? Yes. This is the Pro Kerala registry, which was done under aegis of Shri Chitra. It was done before COVID. Or what they did is they evaluated 2,000 patients who had echo-derived PA pressure, and and they have used PSP slightly higher, 50 millimeters of mercury, instead of 40 what we are clinically taught in our day-to-day practice, so that they are able to see more sensitive diagnosis. So when they were evaluating these 2,000 patients, they noticed that the highest group is group 2 related with the mean age of 56. And in group 2, the most common was valvular heart disease, followed by 36% of ischemic heart disease. It was around 50-55%. Followed by group 1 in their registry, it is 317 patients out of 2,000, so that is roughly 17%. This is the second most common in their registry from Kerala, and 75% of them had idiopathic, followed by congenital heart disease. 16% in group 3, and the most common cause was COPD. I have a question mark why they don't have ILD patients. Maybe this whole registry data was collected from cardiology group and less involvement of pulmonology. And you can see that there's no CTEF in this group, very few patients. So some question mark, but still it is a remarkable work from Sri Chitra, and it is the real world data from India. Another group which is not described, but we see quite often in our day-to-day practice is hyperkinetic pulmonary hypertension. What it means is it is driven by high cardiac output. So if you bring this Paul Wood classification, you can see that high cardiac output also leads to high PA pressure. And most of the time, these patients, this disease is quite common, but not addressed or missed because we are not doing cath in our patients when they are in ICU. And the only way to pick these patients is when you do cath and you measure the mixed venous saturation, it will be quite high, 85%, and they present with high cardiac output. It is not so rare. The awareness is less in our country. Each year we see at least 4 to 5 patients in our, once in a year, 4 to 5 patients, and these are the different groups of the patients who present with high cardiac output. I think this is quite common group, renal failure patients. They have fistula, they present with high cardiac output. Now we are seeing patients who are getting evaluated for liver transplant. This is another group which presents with high output. And in our country, especially those who are living in villages and all, they present with thyrotoxicosis, anemia. All these things leads to high cardiac output. If you diagnose it correctly, it is easily treatable disease. So always keep in mind that high cardiac output. Another growing population is with a better survival in oncology as well as in hepatology. We are seeing patients who are given medications, chemotherapy, and they present with pulmonary hypertension. There are some definite etiologies like dasatinib. In US, they are having an epidemic of amphetamines, which is quite rampantly used for ADHD group. This is also used quite frequently by oncology, mitomycin. So these drugs causes pulmonary hypertension. Good thing is, if you diagnose it at right time, you stop this, this is reversible. So you have to pick this early. Even some drugs from hepatitis C treatment, as well as bortezomib, bevacizumab, all these are possible association. So keep in mind about drug-related pulmonary hypertension. Even serotonin related drugs can cause, so we have to be more vigilant. So we have discussed the basic epidemiology. Now the next question is, what is the prognosis of these patients across different groups? This is from Germany, from Hussein Gofrani group. They evaluated all the patients from over a period of 17 years by doing right heart cath, and the 5-year survival is worse in patients due to lung disease, 38%, while CTEF patients have better survival, reaching up to 67%, because they have a treatment option of PTE surgery. Even PH patients are doing better, 69%, as compared to patients who have lung disease. So among all 4 groups, the message which I want to point it out that lung disease patients, ILD, once they develop pulmonary hypertension or COPD, their long-term outcome is not good. Worst among all those things, because we don't have yet any proven therapies except inhaled treprostinil. This is our data from Narayana Health. We have evaluated from post-COVID 96 patients of group 1 PH, and we have given as abstract in ISPR 2026. It was done in AIMS. So out of 96 patients, around 46% people got RSC, 85 to 86% have CT, and our mean age population of group 1 PH is 35 years, at least 20 years younger what is reported from Western world, and 74% of these are female. So predominantly female gender is affected by PAH, and this is we have used different drug combination in our patients, and there was with contemporary PH medication treatment, there was an improvement of in their exercise capacity, and we also have tried to look the long-term outcome. The median follow-up is around 2.2 in our patient population, and you can see that after 2-3 years, because follow-up is not, there are lesser follow-ups, so it becomes wide confidence interval, but at 2 to 3 years, our patients are surviving, having a survival rate of 84-85%. So this data shows us that we are doing at par what is being reported by Western world. So this is the basic diagnostic algorithm. As I said that once with better availability of echo and ultrasound, we are able to suspect and diagnose echocardiography. And then the second most important tool after that is we do a thorough airway assessment, lung disease assessment by doing PFT, ABG, lung scan. Either CTP is the most commonly used. In some patients, we use VQ scan. And if still there is a doubt, then we do right heart cath. So my take-home message is PH is not a single disease, it is syndrome. And whenever we see a patient, we try to do hemodynamic classification as well as clinical classification. As we go around whole day, we will understand that there are limited treatment options available. Specifically, only treatment options are for group 1 in terms of pulmonary vasodilators. And for CTEPH, we have PTE surgery. And for majority of patients, especially in group 2 and group 3, the main cornerstone of treatment is treating the underlying disease. If we use pulmonary vasodilator therapies inappropriately, instead of benefit, we harm these patients. Thank you very much.
Thank you, Dr. Basha Khan, for this opening and foundational, deliberation on the pulmonary hypertension, on the basis of which few further discussions will be based on. So you have, from the era of, nihilistic approach when we used to see the patient with pulmonary vasculature problem, and when people were not talking about the disease, now we have classification, now newer definition, as well as the lot of treatment. And you have very rightly said about the outcomes of different types of pulmonary hypertension. The house is open for the questions and a discussion, if any. If there is no question, then I have just one question.
Sir.
Because I am a pulmonologist and work in,
Yes.
respiratory medicine department. So we face many a times the clinical discordance. You said you decide the patient's hemodynamic features are there to classify the pulmonary hypertension. And then there are certain patients where there is a discordance between the clinical and a hemodynamic. Then how do you decide what treatment are you going to offer and on what investigation are you going to rely? Because right heart catheterization, you said it is the last resort.
So that's why it is in our resources, it is to understand the epidemiology, what group of patients. So suppose I see a 30-year-old who comes with, and he has cyanosis, and still if the echo shows dilated RARV and he is symptomatic, he is desaturating, and first time, and if you do see clubbing and still echo is normal, then I would like to tell them, please look more carefully or probably do TE to make sure we are not missing a congenital heart disease. And we also try to look about how the LA size looks. So if your LA size is, not, especially in a younger population, is slim and trim, his BMI is okay, so and there is a good history that he has no COPD, asthma, you have done a CT scan, your lung parenchyma looks clean, there is no ILD or hyperinflation, you have done a simultaneously evaluation of pulmonary arteries, there is no clot. So ultimately you have ruled out group 2 by looking at TE, you have looked at LA size, you have ruled out congenital heart disease. So history taking, clinical examination and bedside things can help you to reach a diagnosis. Same way if I see a 70-year or 80-year-old, then it becomes more difficult. And in the real world, you are going to see patients who have mixed disease. So somebody who comes with a 70-year-old, his BMI is 35, his LA size is big, around 40, he's having atrial fibrillation with dilated RARV, with diastolic dysfunction, then most likely this is a group 2 related because the data shows that this group presents like this. And then we have certain scores like HFpEF score, so we utilize those things. So these are the things: good clinical history, thorough review of echocardiogram and CT. So these things are complementary to each other.
Other common clinical problem arises when there is a patient, when say patient is maybe fitting into group 2 or group 3. Majorly in a patient जो हम लोग देखते हैं
Yes, sir.
group 3. When are you going to take call on putting that say patient on group 1 regimen? Because that is somewhere it's not
Yes,
clear.
sir. So it's a bit controversy, but suppose you have a patient who is ILD and it is not connective tissue, is a UIP. So if you see across the registry data in the trials, if your FEV1 FVC is around 70%, above 60 they say. So, and if your FEV1 FVC is more than 60% and your pulmonary pressures are quite significantly high with dilated RARV, then this points you towards that this is driven by group 1. Another thing which we have to understand that there are hypoxia, hypercarbia is a major determinant of increasing PA pressure. So when they are getting admitted in intensive care unit with decompensation, we shouldn't, echo gives it, but it is giving other things which are leading to elevated PA pressure. So once they recover from their exacerbation, then we should try to do echo to see what is happening. So most of the time we rely on the echo which is done on day 1 or day 2 when they get admitted with acute exacerbation and all, and you see dramatic high PA pressure, RV overload. So there you have to do supportive therapy more, treat their anxiety, That also sympathetic stimulation increases. Treat hypoxia. We forget that hypoxia leads to increase in at least 9 studies have shown to 10 to 15 millimeter increase in PA pressure. So treat hypoxia, treat hypercarbia, and then do reassessment.
Thank you, Khan sir, for
Thank
such
you.
a nice discussion. So I would like to add something that in the day-to-day practice, we see in IPD and, as sir said, in IPD and ICU patients, they labeled as the previously labeled as severe pulmonary hypertension during the admission, and it was because of the stress. And on the baseline, they can have the mild to moderate hypertension. So follow-up echocardiography is important. In the 3 to 6 monthly echocardiography is important. And each and every patient of pulmonary hypertension should have the extensive workup from the blood investigation to the lung scans and the cardiac echo and right heart catheterization is last resort, as sir said. So we should have a high suspicion in the patients, and especially the COPD, ILD patient, and in the females, in the female population, that they have the multiple systemic sclerosis, and they have ANA positive, and they can have the pulmonary hypertension as far as the connective tissue disorder is and autoimmune disorder is concerned. Thank you, Khan sir. Thank you. Such a nice discussion, sir.
One thing I would like to highlight, it is rarely discussed, but hyperkinetic, like hyperdynamic circulation, we see if you don't, like we should, now I have brought this, now you, retrospectively you go and see when patients are admitted in critical care unit, how many of them have anemia, thyrotoxicosis, fistula, liver problems, and they are presenting with hyperkinetic, and we label them because never discussed, it is a rare, labeled as rare, it is not so rare, it is more common. We are going to see more patients of this hyperdynamic circulation. Thank you very much.
Thank you, sir. Thank you.
Thank you, respected speaker and chairpersons. I would like to request the speaker and chairpersons to kindly collect their mementos from the felicitation counter located outside. For the next session, we will be getting an international perspective on the current treatment landscape in pulmonary hypertension. To conduct this session, may I invite our esteemed chairpersons, Dr. Rajiv Garg sir, Professor, Department of Respiratory Medicine, King George's Medical University, Lucknow. Dr. Satish Kumar sir, Associate Professor, Department of Medicine, KGMU. Dr. Jyoti Bajpai ma'am, Associate Professor, Department of Respiratory Medicine, KGMU. And Dr. Amit Kumar sir, Assistant Professor, Department of Medicine, KGMU.
Good morning, everyone, and welcome to Professor Rajendra Prasad, sir, our own teacher and mentor. And सर टाइम से चल रहा है, एक लेक्चर ख़त्म भी हो गया है, just to in the interest of time, I'm not going to let Sandeep wait because he is in a different time zone, I believe, and it will be it will not be a justice to keep him, say, waiting for his very important lecture on, say, overview of pulmonary hypertension. I believe it's there. And just to Sandeep, just to introduce my co-chair, I'm Dr. Rajiv Garg. I'm professor in the Department of Respiratory Medicine. My co-chair is Satish, and Dr. Jyoti Bajpai is from the Department of Respiratory Medicine, and Dr. Amit from the Department of Medicine. So over to you, Sandeep, because in the interest of time, I'm not going to waste much of it, and we'll have a discussion later on. Over to you, Sandeep.
Sure.
Thank you so much. Sorry. It's my fault. I will request my co-chair to just introduce who is Sandeep.
So very good morning to all of you. So as we know that the pulmonary hypertension approach has been shifted from symptom-based approach to the risk-based approach. There are new therapeutic options in the armamentarium for the management of pulmonary hypertension. I think none other than Dr. Sandeep Sahai is the best person to talk on the very important topic of the treatment of the or management of the pulmonary hypertension. He is a part of the very, very important PH-ILD trials, and he is a very, very important investigator or PI in the phase 2, phase 3 pulmonary hypertension trials. So sir is a director of the pulmonary hypertension program, division of the pulmonary critical care sleep medicine, Houston Methodist Hospital, Houston, Texas. And sir is leading the PVRI as well as the pulmonary hypertension. He's a director of the pulmonary hypertension team of the Houston Methodist Hospital. So very renowned pulmonologist and critical care faculty with us from the internationally from the Houston. So welcome you, sir. I hope you should be there in India, but I am very privileged to listen you regarding the management of the pulmonary hypertension current perspective, because a lot of changes has been gone in the last 10-15 years in the management of the pulmonary hypertension. There are a lot of risk score has been from your US state has been developed, risk light and reveal score. So we are very eager to listen you, sir. Welcome you, sir.
Thank you so much. Thank you everyone for inviting me. And first of all, thank you for accommodating my request about the time of my lecture. I just landed back from Canada. We were out for a family vacation, and I think initial slot was early in the morning. So I really appreciate that. And thank you for giving me this opportunity. I'm sorry I could not be there in person, but hopefully next time. Let me start with sharing with my presentation here. I hope you are able to see my slides.
Yes, sir.
Can you? Okay. And if I'm running over time, please do interrupt me. Just interrupt me and just let me know. Give me like a 5 minutes notice, because once I'm on the slide, I'm not seeing any timer here, but I'll try to finish it in 20 minutes. I'm actually focusing mainly on PAH management because there are a lot of new developments and also all these medications which we have. I want to highlight how to best utilize them. I know we see a lot more group 3 pulmonary hypertension, specifically PH-ILD. Probably in the part of our discussions, I can answer your pertinent questions, but I think the presentation mainly will be on PAH, where most of the approved therapies are. These are my disclosures, nothing related to the talk today. I think previous speaker, Dr. Basha Khan, and everyone in the discussion was talking about the clinical classification, and I'm not going to go in detail, but as you may know, PH still is rare. We say that the incidence of idiopathic PAH is roughly around 10 to 20 patients per million per year, which still accounts for a rare disease. But keep that in mind, India is a very large country with a very biggest population in the world, so that number itself can be inflated. But the point I'm trying to make is that we should be looking for it, that it is probably not that rare, I would say, if we are aware of it. And plus the burden of congenital heart disease is large in India, so that's also contribute to PAH. We'll discuss briefly about the other entities, but I think Dr. Khan already went into those details, so I'm going to skip over that part. This is just a subgroup of group 1 PAH, idiopathic, long-term calcium channel responders, heritable, most commonly BMPR2 gene mutation, but there are 23 known genes now. Drug and toxin, I think in the previous talk, Dr. Khan mentioned about methamphetamine use. Actually in the US, it's initially it started in California, but now it's pretty much every state. And it's not just for the ADHD treatment, it's actually the drug abuse. Meth is very well abused as a recreational drug. in the United States, and that has become a big problem. And then other drugs like dasatinib and those drugs can contribute. Connective tissue disease, I think there was a brief discussion about scleroderma, but then there are other entities, lupus, mixed connective tissue disease. These are not very well studied. HIV infection, we are seeing a lot less now because HIV treatment has improved significantly, so the burden of PH has gone down. Portal hypertension, I think there was a good discussion about the hyperdynamic circulation in the previous talk and the stress on hyperdynamic circulation assessment. And liver patients, I do not know the exact burden of the liver disease in India, but I'm assuming it's pretty high. Alcohol and other cryptogenic or hepatitis and all these diseases contributing to, and this is the sickest group of all PH patients, portal hypertension associated pulmonary hypertension, and they need to be really monitored carefully, and they all present with invariably with hyperdynamic circulation and high cardiac output. And congenital heart disease, I guess I'm sure everyone in the room knows better than I do. Schistosomiasis, we don't see much here in the US, but in African countries or Latin American, in Brazil specifically, it's quite a bit of problem. Then PH with the rare phenotypes like PVOD and PCH, and again, they're very rare. If there is any specific question, I can answer. But general rule of thumb is that these drugs which we are talking, they're not really approved for these conditions, and most of them, as we commonly refer to them as vasodilators, these patients do worse when you start them on these PH medications. We do not know about sotatercept as of now. Whether it works on that, there are some studies going on that. And the rest of the groups, I'm not going into details of that just in the interest of time. I think previous speaker already talked about the definition. I'm just showing the hemodynamic changes over a period of time and the current definition. All the guidelines, evidence is generated based on the right heart cath. I think there was a brief discussion on the right heart cath, and I understand the resources are limited, and but the value of right heart cath is not just in the diagnosis also, but it is also important to prognosticate your patient and also to assess for the treatment response. So we do repeat right heart caths. I mean, I'm a pulmonologist and I do my own right heart caths for my patients. So I do repeatedly, and every time I'm making any treatment change, I do a right heart cath to assess what the response is. But I do understand the limitations, resource limitations, and practical limitations. But we can discuss that later in the details. So why do we need more therapies? This is from the REVEAL registry, which is kind of old now, over, I would say, 15-year-old data. The survival curves, you can see the first registry, which was NIH-sponsored. The bottom line, the blue bar, shows almost 7-year survival of 30%, which improved a little bit to around 66%, but still not there. Basically, what you are telling someone, if you look at overall survival in REVEAL registry was median survival of 50% at 7 years. You are telling someone who you diagnose at 20 years of age that by age of 28, half of those people may not be there to celebrate their 28th birthday. So that clearly indicates this disease, despite of our advancements, carries a large mortality and morbidity burden. So what exactly happens in this disease? And this is why I'm trying to show this figure, is because I'm going to talk a little bit about the sotatercept, which is the newer kid on the block. But this is kind of the central pathogenesis in the pulmonary vasculature. On the right side, you can see that how the endothelial dysfunction is triggered. And I'm trying to show only the anti-proliferative and pro-proliferative, focusing on the ALK and activins and BMPR2 pathways, but there are actually much more. I mean, this disease is very complex. We're just talking about these two balances of pro-proliferative and anti-proliferative pathways, because we have identified those and now we have therapeutic options for that. But in reality, there are way more complicated pathways involved. So as you can see, that it's first the endothelial dysfunction, which triggers the smooth muscle proliferation, and if you can see the life cycle of that, it increases the afterload for RV. Eventually, RV fails, cardiac output starts to drop, your PVR goes up, and the mean PAP slightly goes down at the end stage. Currently, there is no cure, and of course, despite of treatment, disease progresses. Management is complex. General measures, conventional therapies, supportive therapies, advanced therapies, and surgical intervention if transplant is not available with atrial septostomy. Now, in general management, we talk about diuretics, oxygen. Anticoagulation is generally not used nowadays. The other things, avoiding pregnancy is very important. We suggest guidelines still suggest do not recommend pregnancy or do absolute counseling of your female patient because this disease is still female predominant. Diuretics, we talked about calcium channel blocker. So this question keeps coming again and again, and I can go a little bit more in detail. The calcium channel blockers are actually recommended only for vasoreactive patient. Now, if you look at the first slide I showed, the whole group 1 PAH, there were like 5-6 different types of PAH. The only where the calcium channel blockers are recommended are the vasoreactive patients, and they are one of the phenotypes of idiopathic PH. So when I told you or mentioned about 10 to 20 people per million per year, which are idiopathic, I'm talking about roughly 10% of them may be vasoreactive. So that means if there are 10 people, so in a city like Houston, which has 3 million patient population, and we're looking at, let's say the higher number, 20 patients per year, 3 million means 60 people, and 60 people of idiopathic PH are being diagnosed every year in Houston area. And then I'm talking about 10% of those. So we're talking only for 6 people among all of those. So point I'm trying to highlight is that this is a very specific phenotype, and it is extremely rare. It's rare in the rare disease. That's where the calcium channel blockers are indicated. The advantage of that is if you use that, these patients do, if you correctly diagnose them and if you use it, the drug is very cheap and they do really well. You don't have to spend millions of dollars or rupees in treating with expensive medications, but they will just do fine. I mean, and that's where at the time of diagnosis, there is emphasis of identifying that particular phenotype. Now, again, I'm highlighting idiopathic PH, but patients with scleroderma, liver disease, HIV, they're very unlikely to be idiopathic PH. Drug and toxin, we believe that there is a secondary hit phenomena in these patients, so they might be vasoreactive. But those with underlying diseases like liver disease, scleroderma, HIV, congenital heart disease, they're very unlikely to be vasoreactive. So if you do not perform vasoreactivity testing in these patients, it's okay. You could just proceed with your regular treatment. But those who are idiopathic, I would strongly encourage, or have family history of PH, I would strongly encourage to perform vasoreactivity testing. So this was our older paradigm of treatment, and I'm not going to go into detail. We had 3 main pathways: endothelin pathway, prostacyclin pathway, nitric oxide pathway. And I, working with colleagues in India, I know that you have access to, I would say, quite a bit of these medications. I know ambrisentan, macitentan is available, selexipag is available, treprostinil is available with some difficulties, but can be made available. I think riociguat and sildenafil and tadalafil are available. So I'm sure you all have some experience dealing with these medications. Now, what happened in 2024, we had another pathway added to this. Now we have a 4th one, which is activin signaling inhibitor. It basically, activin signaling inhibitor is a ligand trap here. I'm going to show you here. So again, what I'm trying to highlight is this is the endothelial cell, and then you have a pro-proliferative signaling, means which increases the smooth muscle proliferation downstream, and then the anti-proliferative, BMP2. That's why in PAH we say there is a deficiency of BMP2, because BMP2 actually is an anti-proliferative pathway. So when this receptor gets downregulated, it triggers the smooth muscle proliferation, and this one gets upregulated. So what sotatercept does is it does the ligand trap for the pro-proliferative activin receptor, which decreases the signaling through the PSMAD2 and 3, and thus reduces the smooth muscle proliferation. That's how we believe that the drug works. Same concept which I just explained. It tries to rebalance the BMP and activins in the smooth muscles. So what happened in the clinical arena? This was the seminal trial, Stellar study, which I guess everyone in the room is very familiar with. This was a phase 3 trial, the primary endpoint of 6-minute walk distance, and it showed remarkable improvement. This is the background demographic of this patient population. Enrolled around 350 patients. Majority of them were on background therapy. As you can see at the bottom here, most of these patients, almost 65% of these patients were on 40% were on prostacyclin, and almost 60% were on triple therapy. So they clearly were heavily treated patient population. Median age was around 47, predominantly female, which is consistent with what we know about PAH. And this was the Kaplan-Meier showing you the 6-minute walk distance. Yellow bar is representative of sotatercept arm, and the gray one is the placebo. And you can clearly see that at 3 weeks interval, the curve started to separate pretty impressively. The drug showed overall 40 meters improvement. The study was not designed to assess for the morbidity or mortality even. However, it did show separation of curve in terms of that also. Now, keep one thing in mind, that the gray bar, which is your placebo bar, it's not that they were untreated. They were being treated with the standard of care treatment, whatever was available in their part of the world. So imagine if we didn't have sotatercept, this is how our patients are going to perform without sotatercept. The gray bar represent our standard of care as of today, when the trial was conducted 2-3 years ago. And the yellow bar was when sotatercept was added over that, how the improvement was noticed in these patients. Like everything else, this drug also carries some significant side effects and adverse effect burden. Bleeding is one of the big ones. Thrombocytopenia. The drug was originally being planned for myelodysplastic anemia, actually. As per the effect of the drug, it increases the hemoglobin level. But bleeding, initially, the nasal bleed, epistaxis was the most common. Then telangiectasias were also noticed in these patients. Now, there are some other reports which I will discuss shortly in the real world with this drug. Some more impact on the hemodynamics. One interesting thing which was noticed with this drug, which is very different from other PAH treatment, that this drug improved the mean pulmonary artery pressure pretty significantly. However, it also decreased the cardiac index, and this has been so far a sort of a mystery. We have different theories. There is a very nice paper by Dr. Reddy recently published in JACC trying to navigate through this and try to get some answers that why the cardiac output does not really improve in these patients. So this drug for some reason does not show improvement in cardiac output, but it does show improvement in mean pulmonary artery pressure and improvement in PVR. The echo parameters also improved, RV size, RV function, RV end diastolic pressure, volume, they all improved on the imaging as well. Soteria is a long-term study which showed that at long-term, patient who achieved the low risk stratification, that means those who were in the low risk at 24 weeks, at 1 year also they maintained their low risk status with the therapy on. Their NT-proBNP dropped significantly and stayed in that range at 1 year interval. This was the pooled analysis from Pulsar and Stellar studies, and this was mainly performed because when this observation came to limelight that the drug drops the cardiac index and cardiac output, which was sort of unexpected, so then people started thinking that maybe the drug is not effective. So then they basically performed this pooled analysis from 2 trials to see what happened to the important parameters which are relevant, like 6-minute walk distance, PVR, and NT-proBNP. And as you can see clearly, despite of not seeing the improvement in the cardiac index, patients did improve their 6-minute walk distance, PVR, and NT-proBNP. So that was sort of reassuring, that which we still get worried that why cardiac index drops, but this clearly showed that despite of that, patients did improve. Then the another important question came, okay, if this drug is so effective, should I start using this drug earlier? Why do I need to wait until the disease is very advanced? So this study was designed within first year of their diagnosis. Now, as expected, within first year of their diagnosis means these patients, majority of patients were on actually dual therapy in this trial. Some were on triple therapy, and then they were, I would say, a mix of intermediate or high risk. As you can see here, predominantly patients were on intermediate risk. They were within 1 year of their diagnosis, means they were started on the standard of care treatment or whatever maximal tolerated treatment, and then sotatercept was added. And here you can see they were still a significant population was in functional class 3. Majority of patients were on dual therapy, which is not surprising. And then a third were on triple therapy. Some patients were on prostacyclin also. And the interesting thing in this trial was you would see the age was slightly higher, 57, 55, which was very different from Stellar study, which was around 45, 47. So the just kind of highlights the epidemiological shift in PH diagnosis, that people are a little bit older at the time of diagnosis now. Plus, because of their age, they had more comorbidities also in this trial. This trial was not hemodynamic trial. It was a morbidity mortality trial, was terminated earlier because of overwhelming benefit. And at the same time, the Zenith trial results came out, so which showed benefit. So because of the clinical equipoise, the steering committee did not feel that patients should stay on placebo while in the trial, so they terminated the trial. But clearly, even at the earlier termination of the trial, you can see the overwhelming response to the therapy. This was in the high-risk patient population, those who are on advanced disease, who were listed for transplant, high risk for mortality. Their REVEAL light risk score was more than 9. And I will be real quick here just to show you the primary endpoint. Very strong response. Actually, in this trial, the number needed to treat was 3. I guess I have not come across anything like that in PH literature where a drug has shown such a strong benefit, and especially in the advanced disease patients who are on a lot of therapy and high risk of mortality. So overall, this is the summary of the drug on the left side, the benefits of the drug on the right side, what we have to watch for, increase in hemoglobin, thrombocytopenia, bleeding events, and telangiectasias. But at the same time, the drug has shown pretty much all-around improvement in the parameters. Now, moving on to the real world, we published this last year. We started noticing that we are seeing a lot more pericardial effusion, which was not making sense as patients' hemodynamics are improving, but they're developing pericardial effusion. As you may know, that pericardial effusion is a part of natural progression of the disease in advanced PAH, but it didn't make sense if the patient's hemodynamics is improving, then why they should be developing. So we talked to many of our colleagues in the US. This was a report from 6 center data showing that the pericardial effusion were largely related to the sotatercept therapy. However, we do believe that this is not just sotatercept effect, it's probably a class effect with other activin signaling inhibitors as well. Now, Now we have all these therapies. Now, how do we really try to implement that in our clinic when we are seeing these patients? So when I'm seeing my patients, and I would say these are the three sort of categories I would try to fit my patients into. Are they stable and satisfactory? They're stable but not satisfactory, or they're unstable and deteriorating. If they're last two, then I definitely proceed with doing some intervention. This is from the Seventh World Symposium, which came out. I think someone had mentioned about the risk stratification. That in itself can be a separate talk, just going over all the risk stratification tool. But for implementing into your clinical practice, I would just simply say pick one tool, whatever is easier for you and whatever you can easily implement in your clinic, and then use that, and then do it at baseline, do it at the follow-up evaluation, and then start treating your patients and assessing and treatment response. And that's how this, again, this actually we were looking at this graph on the left side, but the most of the information is actually in the box on the right side, which is very valuable. And I would suggest everyone to kind of go through this document. It's free online. You could easily go through in detail. Now, when we are performing, I'm just going to simplify this. We published this U.S. perspective in Blue Journal. They both papers came out pretty much at the same time. They are actually not very different, but in principle, they're very simple. And I'm going to just walk you through from this paper, which we published. So once you make a diagnosis of precapillary pulmonary hypertension in a patient, you calculate REVEAL risk or ESC-ERS at baseline. You could pick whatever calculator. We suggest you use REVEAL 2.0 at baseline or ESC-ERS. Now, if your patient is low risk, so current guideline is if your patient is low risk or intermediate risk at baseline, you start dual oral therapy, which is combination of ERA and PDE5. If your patient is high risk, there is no doubt you start dual combination and add the parenteral prostacyclin. However, if you see the orange box here, this one here, what that really means is that if your patient is technically intermediate risk but has bad hemodynamics, and the bad hemodynamics was defined in European guidelines as PVR of more than 12 Wood unit and cardiac index of 2 or lower. If you are seeing that, then you may probably still consider them as high risk and may consider parenteral prostacyclin in them to begin with. Now, after that, you reassess them at 3 months. Now, there are different possibilities at that time. If your patient is low risk and they are doing fine, their echo looks great, means normal RV function, you just continue the same. Now, if their echo is not normal, and I'm just focusing on the left side of the figure right now here, if their imaging is not normal and RV, you may consider adding other therapy in that. Now, this is a little bit more of a expert opinion. We do not have data backing this, and this is why I put over here that this as a consider. Now, intermediate, if your patient is clearly intermediate low risk, by any of the criteria you are following, or REVEAL Light 2 score of 6 or 7, or intermediate or high risk, then it's a shared decision making. You can look into your clinical practice, what drugs are easily available, which your patient can afford, what your patient profile is, what you think they may tolerate. You may add activin signaling inhibitor. You can use a non-parenteral prostacyclin, or you can replace PDE5 with soluble guanylyl cyclase stimulator, only if they are intermediate low. If they are intermediate high, I would suggest consider them as a high risk. You may consider parenteral prostacyclin, add activin signaling inhibitor if they are not already on. If your patient is already high risk, then there are 3 possibilities: that you effectively treated the patient, now they are low risk, you continue the same. They're intermediate risk, despite of the 3 therapies, you add activin signaling inhibition. Now they're still high risk, you will add activin signaling inhibitor and probably call your transplant colleagues and do a close monitoring in these patients. Now, this was one paper we published recently in the in the Lancet, and this was more of a conceptual change in the PAH treatment paradigm. Till now, we wanted to save people alive. We still want to save people alive, but we feel that now with the medication, specifically with sotatercept, it's possible that we can probably keep patients' disease at bay and maybe induce remission in them. And that's what we tried to explain in this paper, that these are the 5 different clinical responses which we can expect. But the question is, how do we define remission? And if you look at this paper, we have come up with some proposals in that, although they need to be validated with more data right now. So right now we do not have, but it is work in progress. We are working on this to provide, to come up with some strong evidence supporting each of these. I just wanted to mention this.
Dr. Sandeep,
Yeah.
just to remind you that 30 minutes are there, and you are just overshooting. You can just wrap it up in, say, 5 minutes or so.
I think I should be done.
Thank you for understanding us. Thank you for understanding us.
Absolutely, absolutely. This is just came out last week. Just wanted to highlight, this is ralinepag, which is oral prostacyclin receptor, PGI2 receptor agonist, and it's once a day therapy. I think you have used selexipag. It's just once a day now. It's kind of a different formulation targeting the same pathway. So this is something should be available soon. Met the primary endpoint of morbidity and mortality. The combination pill is now available for ERA PD5 combination. I'm not sure if it is available in India or not, but at least in the US, just for the better compliance. Some of these newer therapies, the seralutinib just completed their phase 3 trials. It is with FDA for approval. Let's see what happens with them. In the phase 2, it showed to improve the PVR, but phase 3, there were some challenges with the data, but let's see what the FDA decides on that. I think someone had asked me to put a couple of slides on some future drugs in pipeline. HTEC modulation is an epigenetic modulation, and I'm not going to go into detail, but how your gene expression can be altered. This is a trial which is just starting in the US. Hopefully in the next 4 or 5 years, we may have some positive results with that. Then there is another trial coming out hopefully soon, macitentan 75 milligrams, which is a phase 3. It's completed. It's waiting for it last patient to complete the study. I think those were the salient observations in the last few years, new developments which I wanted to highlight. Spend some time on the treatment algorithm, which appears complex, but if you keep doing it regularly in your clinical practice, it may not be. And thank you for your time and attention, and I'm happy to take any questions. Thank you so much.
Very good morning, sir. I am Dr. Satish Kumar, Associate Professor here in Medicine Department here at KGMU. I welcome you on behalf of KGMU, and sir, this is my great pleasure and privilege to welcome you. Sir, just one question to ask you, sir. How to decide when to escalate from the dual oral therapy to parenteral therapy?
Okay, can I go back to my slide? I think that'll be easier if that's okay with you. Just will quickly show you. Okay, here. So, can you see my cursor on the screen? Or can you guys see my cursor moving or no?
Yes, yes.
Okay.
Your cursor is visible.
Okay, so you were asking me when to add the third agent when your patient is already on dual therapy. So what our current understanding is, and what our guidelines and evidence suggest us, that once you have started someone on dual therapy, they were probably low risk or intermediate risk at baseline. Now they're coming back for follow-up. You do their risk assessment again. You can pick whatever risk model, Reveal Light 2, or ESC, ERS, or even French. If you feel that they're not low risk, then you need to consider adding further therapies. Now, I'm trying to emphasize on the risk stratification because that's what the guidelines and our understanding is. But keep one thing in mind. In the real world, risk scores may not fit well in your patient. For example, if you have a 65-year-old woman who has, let's say, scleroderma. Now, that patient walked, first time you did a right heart cath, PVR, let's say 7-8 Wood unit, you started dual therapy on her. Now she comes back for follow-up, and the first time she was in function class 3, walked 350 meters, she improved to 375 meters. Okay, so she improved 25 meters. She feels good. She's able to do day-to-day activity. NT-proBNP improved. But you calculated her risk. She is still in intermediate risk because her NT-proBNP probably not normalish, or she never improved to 440 meters. For a patient to become low risk, you have to, as per what data we have, that they need to walk at least 440 meters, and she never walked 440 meters, and she probably will never walk because she's 65-year-old, she has bad knee, she has scleroderma. So in that case, how would you decide? So there will be a little bit of discordance between your clinical assessment and what your risk score is telling you. So we generally rely on the RV imaging in those cases. I suggest that we do an echo. If the RV has normalized, despite of them are being in intermediate risk, I would probably not overdo treatment, as opposed to RV is still looking bad, or RV function, NT-proBNP is high, there are some other parameters, RA is still dilated, I would probably advance treatment. But sticking to the guidelines, if your patient is in intermediate low risk or intermediate high risk, you advance treatment. Does that answer your question?
Yes, sir.
Okay, thank you.
Can I ask one question?
Very good discussion.
Yeah, of course.
Thank you, Dr. Sandeep and Basha, for your wonderful presentation. My question is in regards to walk test. While if you see our Indian population, we are staying around, especially male and female, around 5'5", while a Caucasian who is 6'5". So how come we interpretation of walk test comes with this height disturbance, and they are more fit and all. So probably we should have a better parameters for our population. This is whether this number of 440.
You are absolutely right. We actually published recently in Respiratory Medicine from our center data. This is exactly what I was trying to answer. And you could read this paper, came out probably last year, that we highlighted that how age impacts, and your point is very well taken, that 440 is not a magic number which every patient will be able to achieve all the time. It's absolutely not. And if you look at the ATS guidelines, they actually say it should be individualized. It's so a person like me may be walking 500 meters all the time. So for me, my normal is 500 meters. I have patients who walk 600 meters all the time. For them, that is normal. And if they drop to 550, that's bad for them. So it's an individualized, but unfortunately, what we are relying on is the registry-based data. And we just do not have more age-adjusted and individualized sort of phenotype-adjusted walk distance data in PH. We just don't have that data. So that's why these scores are stuck to it. But the paper we published last year clearly actually was highlighting the same issue which you are trying to say. What we showed that at their first follow-up, patients who improved their RV function and normalized, they were not able to improve the older patient. I think we made a cutoff at age of 55. We looked at patients who were younger than 55 and more than 55, and those who were older than 55, despite of improving their RV function and NT-proBNP, they were never able to achieve 440 meters. So yes, that is just a limitation of what we have.
Yes, sir. Very good discussion, sir. Sir, myself, Dr. Amit, from Department of Medicine. Actually, sir, I generally encounter the patients in ICU, sir. Is there any role of nitroglycerin in nebulization in acute patients, in intubated patients on mechanical ventilation, sir, in ICU setup?
You mean nitric oxide or nitroglycerin?
Nitroglycerin nebulization, sir.
I have not even heard of that. I have not. Nitroglycerin is used for coronary artery disease,
Yes, sir, yes, sir.
right?
Sir, we
That's-
usually use this and we found a very good response also, sir. In acute patients who are intubated, suffering from LRTI, hypoxic, and when we do 2D echo, there is increased PA pressure, and when we nebulize 6 hourly to 8 hourly, there is a good response with nitroglycerin nebulization, sir.
Now, let me answer this question. I think this was in the previous session also. This comment came up about the echo pressure elevation in ICU setting and hypoxemia. Now, just sort of, I'm sure you all know this, but hypoxemia increases the afterload for RV. And the ICU patients, ventilated patients, pneumonia patient, anything which affects the VQ mismatching in the lung will increase the RV afterload. And that can give rise to increase in PA pressure. So I think someone in the previous session had mentioned very wisely that repeat an echo at 3 to 6 months at certain period of time. Yes, once this condition is optimized. So if I'm seeing a patient in ICU who I get consulted for elevated PA pressure, for example, the first thing I go and look at what their lungs are looking like. Do they have pulmonary edema? Do they have pneumonia? Do they have hypoxemia, atelectasis, all those kind of things? So first thing is to fix all those issues, then we will talk about. Now, certainly there is a small phenotype of patients where you may have true precapillary disease playing a role, but the true precapillary disease will cause you to have more hemodynamic issues than really hypoxemic issue until or unless your lung parenchyma is damaged for whatever process, whether it's primarily damaged like ILD or the patient is a smoker or lung phenotype or something like that, or secondarily by either infection or VQ mismatching, atelectasis, fluid volume. Now, I am not aware of nitric oxide, you said nitroglycerin, sorry. We use nitric oxide, which is of course is a vasodilator all the time to improve the VQ mismatching. In acute setting, we use inhaled epoprostenol also. I'm not aware of, at least in my clinical experience or the data I have come across, I did not see nitroglycerin use. But I feel like what you are trying to say, it's probably a vasodilator, I guess, right? That's what you're trying to say, that it's probably helps by improving the VQ mismatching, correct?
Thank you, Sandeep, for your comments on questions of nitroglycerin. Dr. Pasha, you want to comment something?
This concept, sir, has rightly pointed out why it is. I'm trying to explain why in ICUs. So that's why it is important to bring the concept of that Paul would, whether your pressure, PA pressure, which you are thinking that increasing, whether this is due to LA pressure increase or whether this is PVR related. So, and since we hardly have any medications like prostacyclin or nitric oxide is also quite expensive in ICU. So we are trying to reduce the LA pressure by using NTG, by reducing the afterload. So it will work if you have a passive pulmonary hypertension in a group 2 patient, but if it is due to PVR related, then you are not going to have any benefit. So
Thank you, Sandeep, for your enriched and very enlightening overview of PAH, though it's a rare disease, but yes, we do come across many patients of PAH. And since there are no more questions, so I declare this session closed, and I invite the organizer to carry forward. And Sandeep,
Thank you so much.
I do request you to visit our campus, and greetings from King George's Medical University once again. And thank you very much, Sandeep.
Thank you. I would love to visit. I think I'll be planning a visit in December this year, hopefully. So I'll be in touch. Thank you.
Thank you so much.
Thank you.
Thank you for that enriching session. I would like to request our respected chairpersons to kindly collect their mementos from the felicitation desk outside. Our next session explores pulmonary vascular physiology and its relevance to understanding the pathobiology of pulmonary hypertension. But before he begins, our speaker has planned a fun question and answer session to get everyone involved. So I would request everyone to join actively in his session. To chair the session, I would like to invite Dr. Anand Srivastav, Professor, Department of Respiratory Medicine, King George's Medical University, and Dr. Rahul Rathore, Senior Consultant Pulmonologist, Charak Hospital, Lucknow. Welcome.
So very good morning to everyone. After listening to two very wonderful talks, just to initiate the day, we'll try to, pull back 2 steps behind before we proceed for the day, because without knowing the anatomy and physiology of a particular system, we may not be able to understand what is right and what is wrong for the patient as far as treatment is concerned. So if you know the physiology better, you know what can be done to improve the pathology which has developed. So the nature is very, it's a very beautiful one, and it's also fascinating science of pulmonary medicine, where a systemic circulation is matching with a pulmonary vasculature or circulation, and both are quite different. One is having a more pressure rather than the other one which is having a low pressure. Why the nature has given this system? So for this, I'll request my co-chair to invite the speaker for this session, Dr. Rahul.
Good morning, everyone. So I would like to invite Dr. Prakash for presentation on topic pulmonary physiology. Over to you, doctor.
Thank you, Chairpersons. At the outset, I thank the organizers for giving me this opportunity to present at this August forum. And sincere thanks for considering me. Also, before I begin, I would like to say that 2 stalwarts have spoken on pulmonary hypertension and its management already. I hope I'll be able to match the aura of them, but that I'll leave the audience and the chairpersons to decide. So this I made from Prezi, the presentation. You'll have the QR code at the end, so you can download the presentation at the end if you require it. So it's called a one-slider. So before I begin, I'll just have an icebreaker question. I think I would request the chairpersons to take it, but if they don't want to, then maybe we can also have the audience to take it. So just a rapid fire. We have one more at the end. So when you see blue, definitely not WhatsApp ticks. What comes to your mind first? Is it heartbreak or hypoxia? So somebody can try to answer, maybe one of the residents at least. Okay, the next question is when your dil starts acting up, not due to love failure, of course. The first question you want to ask, is it left ventricle involvement or is it right ventricle involvement? Because we are all pulmonologists here. And in relationships, will you be compliant or stiff during stress? Turns out that's also the same question we ask a pulmonary artery also, pulmonary vessel. And sildenafil, urologist or a pulmonologist, who's the bigger fan of this drug? And the last question, when you're clearly under pressure, is it your HOD or your pulmonary artery that you blame? So I think the audience and the chairpersons can ponder over this. We'll come back to this and few more questions at the end. So with that, I'll begin. I bring greetings from the National Institute of TB and Respiratory Disease, where I'm a consultant there. And I welcome you to the pulmonary circulation, where it's the only place in the body where you're actively encouraged to slow down, drop off your baggage, and completely get gassed. So anywhere else you say this, and you're probably looking at a life sentence in prison. So this is the schema of the presentation that I'll be having. We'll go through a brief history and a brief history of pulmonary vascular physiology and a functional anatomy of the pulmonary vasculature, and the implications on PV physiology, which have already been beautifully discussed by the previous two speakers, especially the article on pulmonary hypertension and its etiopathogenesis by Paul Wood in the year 1958. It's already been discussed, but we'll go through it once again, and we'll give some conclusion take-home points, and we'll still have time for the rapid fire, I believe. So, historical perspectives. Before I go to the historical perspectives, I just want to bring in one point that why do we have a pulmonary circulation? What was the need for us to have a pulmonary circulation? Fishes don't have a pulmonary circulation. Most of the amphibian groups do not have a pulmonary circulation. There was no need for us to have, apart from the only fact that evolutionarily we have been gifted with the ability to consume and quench more oxygen and to absorb more oxygen and to diffuse more oxygen through our capillaries. So just to go to the history, all the amphibians, fishes, amphibians, reptiles, they all have a very poor pulmonary system, and by poor pulmonary system, I mean the thickness of the membrane is more than 2 to 3 microns. So hardly any oxygen or carbon dioxide diffusion is taking place easily in that. Whereas in the human beings, the alveolar-capillary membrane is only 0.3 microns at its lowest, and it is 0.6 microns at its thickest diameter. So evolutionarily, we have a basis to quench more oxygen, do more work, and that is why we have a separate systemic and a separate pulmonary circulation, which the primitive organisms, all the prokaryotes, including fishes and amphibians, do not have. So that is the evolutionary basis of why we have what we have. Okay, so, and according to Galen, who lived in the year, lived from 130 to 201, we were similar to fishes, as you can see in the diagram here. So we only have we have one liver and a lung and a heart, which is continuously connected, and both we have deoxygenated blood going all through the body, just like the fish do, which only has 2 chambers, as opposed to us who have 4 chambers. But this changed with the era of the Islamic golden period, when Ibn al-Nafis said that the blood from the right chamber must arrive at the left chamber, but there is no direct pathway communication between them. So that means it had to have another route by which it had to get oxygenated before it reached the left chamber to be circulated into the rest of the body. Okay, so, and this was conclusively proven in the 1500s by William Harvey at Cambridge University. So the last 50 years in pulmonary vessels, we know now of the Starling resistor effect. We know now of the topographic distribution of the blood flow, which we now call West zones 1, 2, 3, and sometimes even 4. The non-gravitational factors that affect the distribution of the pulmonary blood flow, longitudinal distribution of the pulmonary resistance. We'll come to all this in detail. Hypoxic pulmonary vasoconstriction, which has already been discussed in the last lecture, and the non-respiratory functions of the pulmonary circulation. Okay, so long gone are the times when pulmonary circulation was called the lesser circulation. It is by no means lesser, and it is by no means simple. It is probably more complex than any systemic circulation you would consider or you would want to dissect and delineate. Okay, and it's not only due to it is due to biochemical, cellular, and reactive properties of the vessels, but it's not only due to that. And the complications and the unexpectedness that we encounter in understanding the pulmonary physiology, that adds to the complexity of the pulmonary vascular physiology. Okay, so we'll come back to that. So I want to actually discuss on 2 topics, which is very important. One is the Starling resistor effect, and one is the extra-alveolar vessels and the intra-alveolar vessels. So these are the 2 main components that we'll come to. So Ernest Starling made a resistor component where it's also called Permet's waterfall, where the flow of a fluid from one area to another is acted upon by factors which are not in the fluid in the vessels itself. So if a waterfall is going from top to bottom, but there are external factors which are affecting it. That is what was defined by Starling in the Starling resistor effect, and that is what Dr. Permet said about the pulmonary vasculature. So this is very important because Starling resistor effect is the one and only physiological basis on which the West zones have been divided. And these are the West zones. The zone 1, which is the apex of the lung, where most of the septal capillaries are already collapsed. The zone 2, where the arterial pressure is more than the alveolar pressure, and that is why they have corner capillaries and corner pleats. And the zone 3, which is towards the base of the lung, which is where the alveolar pressure is lesser than the arterial and the venous pressure. So most of the capillaries are engorged, leading to a higher pulmonary vascular pressure. Okay, so what the right ventricle tells us is to work less and do more. So the pulmonary circulation is a low pressure and a high flow circuit, and the low pressure prevents the fluid from moving out of the pulmonary vessels into the interstitial space and allows the right ventricle to operate at a low energy cost. This is called RV, pulmonary artery coupling. So this coupling phenomenon is a very important phenomenon by which the right ventricle uses less energy but manages to give enough flow to the pulmonary capillaries to oxygenate all the blood and bring it back to the left ventricle. Okay, so the next concept in pulmonary vascular physiology is the steady flow and the pulsatile dynamics. So just like I'm sure everyone here knows of the impulse oscillometry. So, or a forced oscillation technique. So, in a forced oscillation technique, there are multiple frequencies which we use, and so we bombard the airway with multiple frequencies, and with that we know small frequencies reach the smaller airways, and the larger frequencies reach the smaller airways. So we know what is a small airway resistance, large airway resistance. So similar to that, if we consider the pulmonary vascular physiology at a single instance, then it is called a steady flow pulmonary hemodynamics, which is measured usually by a tricuspid annular plane systolic excursion or a pulmonary acceleration time. Whereas if we want to calculate the impedance of the right ventricle or the pulmonary artery, then we would like to go for a pulsatile or a pulse waved analysis, where we use two frequencies, Z0 and ZC, and that will help us to identify whether the pathology lies in the smaller pulmonary vessels or in the larger pulmonary vessels. Smaller pulmonary vessels as in pulmonary hypertension, where there is increased pulmonary vascular resistance. Larger pulmonary vessels as in a saddle embolus or in a pulmonary artery stenosis, etc. Okay, so this is the difference between steady state and the pulsatile flow pulmonary hemodynamics. Okay, so that brings us out of the boring topic. I know everyone's now confused as to what is this guy speaking for the last 5 minutes. It is complex, and it is not a piece of cake to understand pulmonary vascular physiology in a 15-minute talk given by someone. So I think it is very intricate and it needs more understanding. So now we'll go to the easier ones which we always see in clinical practice, and now I bring you Paul Wood. So anyone who's really interested in learning pulmonary vascular physiology and pathology and pathophysiology should read this article, and this article has never been surpassed even after 70 years. So this was published on July 2nd, 1958 by Paul Wood, and these are the same 5 mechanisms, actually 6 mechanisms now, which includes a polygenic or a mixed mechanism. So passive hyperkinetic, obstructive obliterative, vasoconstrictive, and polygenic. So which we still use. And we know that the pulmonary vasculature has a vascular tone, and the pressure of the pulmonary artery and the pressure of the left atrium, and the pathologies that affect individual areas, either the pre-capillary or the post-capillary or the capillary bed itself, determine what type of pulmonary hypertension the patient is going to develop. Okay, so this was given by Paul Wood, and with a simple formula that pulmonary vascular resistance is pulmonary artery pressure minus pulmonary capillary wedge pressure over the Q, that is the cardiac output of the pulmonary system. Okay, so that was what Paul Wood discussed. And the real determinant, as I already discussed, it is RV and the pulmonary artery coupling, which is the pulsatile flow dynamics of the right ventricle. And this is important, as I already told, because the impedance varies in various diseases. Diseases that affect the pulmonary vasculature, small pulmonary vessels behave differently. Diseases that affect the large pulmonary vessels behave differently. So that is why the RV-PA coupling has to be understood, where an adapted RV hypertrophies, maintains output, and the coupling is preserved, whereas a maladapted RV dilates, uncouples, and the output falls. And once the RV output falls, then the patient goes into progressive RV dysfunction, leading to a worsening of the functional class, and then presents with cardiac or RV failure or a cor pulmonale-like features. Okay, so to summarize, you remember Paul Wood's framework, and remember that RV is a low pressure, high reserve circuit. What sets the vascular resistance is the Poiseuille physiology, which is dependent on the diameter of the vessel, and hypoxic pulmonary vasoconstriction, which has already been discussed, the lung volume effect, the alveolar versus extraalveolar effects, West zones and the Starling resistor, and the real determinant, which is RV-PA coupling. Okay, so these are my references, and we'll come to the probably the fun part of it. So this, I think, I would request the judges, chairpersons, if you can answer this. Are you a reserved person, or do you have a reserve, like the right ventricle? What do you think, sir?
I suppose first those guys sitting at the back, they are the ones who are learning the best from you. So they should be given the chance to answer, and then yes, you are the best just to correct them.
So can we have a mic around for any one of them, please? So anyone wants to answer this? Are you a reserved person, or do you have a reserve like the right ventricle? Is it a pulmonary vascular test, or is it a personality test? Anyone? Okay, we'll go to the next one. When I say, let's go see a waterfall, what are you thinking of? Are you thinking of a trip, or are you thinking of zone 2 of West physiology? So I was thinking of a trip. Everyone's chasing a strong core these days. What do you think people are chasing? Is it abs, or is it core pulmonale? So what are people chasing? And what hurts more, somebody driving a wedge between you, or a high wedge pressure on a cath report that you see, which your cardiologist gives you? And the last one is, friends invite you clubbing this weekend. What do you check first? Do you check your calendar, or because you're a pulmonologist, you check your fingertips first? So with that, I conclude this session. As you go in, so take a lesson from the RV, do the hard work, keep your resistance low, and don't let the high pressure LVs around you stress you out. Okay, so thanks.
So it was an excellent session, and I suppose with your talk, the most happiest person would be the organizers, because they were running out of time, and you completed exactly in time. And if there are any questions from the students sitting out there, this is a learning time for you all.
To the residents, I would only say one thing. I think you should read Fishman first, and then the other 2 books that I mentioned. You can scan the QR. You can take the PPT home. Yeah, can you please put the PPT once? So it's not an easy topic to understand, and on first read, that is what I would say. Pulmonary physiology. So
Are there any questions? So if there are not, I'll just, have one and the last question, in fact.
Yes.
Just as a learning curve
Yes.
to the pulmonologist, the budding pulmonologist sitting at the back, what will happen, since it is a topic on physiology, what will happen if you give class 1 type pH drugs to a patient who is basically class 3?
Yes, sir. So in fact, it is going to have a more detrimental effect because the pathophysiology of the class 1 is a precapillary type, and the pathophysiology of 3 is either a capillary or a mixed pre or post capillary. So there is going to be a RV afterload effect. So as most of the studies have shown, STEP IPF has shown that in end-stage ILD, sildenafil has performed poorly, ambrisentan has also performed poorly. So there is going to be, not only is it not going to benefit, it is going to cause more harm in group 3 pulmonary hypertension, sir. Only the last, I think the increased trial of inhaled treprostinil has shown promise in group 3 pulmonary hypertension.
So with this, if there are no other questions, in the interest of time, we'll just conclude the session. Thank you very much, Dr. Prakash.
Thank you, sir. I would like to request our respected speaker and chairpersons to collect their memento from the felicitation counter outside. Our next session focuses on right heart catheterization and vasoreactivity testing. To chair this session, may I invite Dr. Amrish Kumar, Professor and Head, Department of Vascular Surgery, King George's Medical University; Dr. Mrityunjay Singh, Assistant Professor, Ram Manohar Lohia Institute of Medical, Department of Respiratory Medicine, Ram Manohar Lohia Institute of Medical Sciences, Lucknow. Welcome, sir.
Good morning, everyone. And for the next session, on cardiac catheterization and vasodilator testing, I would like to invite our speaker, Dr. Prashant Bhopte. He's a senior consultant, pediatric cardiology at Kokilaben Dhirubhai Ambani Hospital, Mumbai. And he's having multiple fellowships in echocardiography, pulmonary hypertension from Stollery Children's Hospital and Heart Institute, Alberta, Canada. And he has professional experience of over 12 years in pediatric cardiology and expertise in diagnosing and management of congenital heart diseases from infancy through adolescence. And his area of interest is primarily pulmonary hypertension and complex congenital heart diseases and fetal cardiology. On to you, sir. Thank you.
Yeah. Good morning, everybody. First of all, I would like to thank the organizers to invite me for this talk, and also, accommodating me before the next talk. I'm really sorry to the previous speaker. I had to barge in. Sorry, I have a flight to catch, so that's why. Anyways, I'll try to finish this in the given time. These are my disclosures, nothing particularly related to the talk by itself. And we'll try to cover right heart catheterization, aspects of right heart catheterization, procedural details, special circumstances, and risk and complications of the same. So we all know for the last 3 talks that pulmonary hypertension is defined as mean PA pressure of 20 millimeters of mercury. Incidence in Western world is 17 to 20 per million. Classified as 5 groups, and early diagnosis and accurate classification is key to successfully manage pulmonary hypertension. Now, coming to right heart catheterization. Right heart catheterization is a gold standard in diagnosis and accurate classification of pulmonary hypertension. We've seen this table before, in which we can classify the patient into pre-capillary, post-capillary, isolated post-capillary, and combined pre- and post-capillary. Now, all this is only possible if we do a right heart catheterization. If we don't do a right heart catheterization, we basically won't be able to differentiate between all these subgroups. So that is where the right heart catheterization is the gold standard for diagnosis and accurate classification of pulmonary hypertension. In addition, it allows risk stratification and prognostication. Dr. Sandeep Sai also told us that it helps us assess efficacy of therapy. Prior to interventions, definitely in group 1 pH, if you're doing port shunt or atrial flow regulator, it is necessary. An assessment of lung or heart-lung transplant, a right heart catheterization is usually required to proceed. And in patients with congenital heart disease, to assess operability, right heart catheterization is frequently done. What are the contraindications? There are not many truly. A thrombus or a tumor in the right atrium, mechanical tricuspid or pulmonary valve, a pacemaker implanted less than 1 month, and acute infection. These are some of the contraindications for doing a right heart catheterization. The question is, in our country, where cardiac catheterization is not easily available, also vasodilator testing, as we heard, nitric oxide, which is ideal drug for pulmonary vasodilator, it's not available or it is expensive. Do we really require a right heart catheterization for diagnosis? So this is a consensus statement which we wrote some time back, published a couple of months back in Pulmonary Circulation, regarding challenges and strategies in managing pulmonary arterial hypertension, that's group 1. And me and Dr. Basha Khan over here, both of us have co-authored it along with 15 or 16 other co-authors all over the country. It's the first statement of its kind from India, in which we try to answer this question. Now you see this echocardiogram. You have a patient who has got a hugely dilated right atrium, right ventricle. There is probably some tricuspid regurgitation. The interatrial and the interventricular septum both are going to the left ventricle. There is some pericardial effusion over here which is seen. Now if you see this kind of an echocardiogram, the question is, do I need a right heart cath for diagnosis? Probably not, right? The second is, what is the risk of doing a right heart catheterization? In a treatment-naive patient, this patient is not on any therapy. If I take this patient for a right heart cath, probably cannot even lie down flat for 10 minutes. If we do a right heart catheterization in this patient, we are probably inviting trouble. The third is vasodilator testing. Now, a vasodilator testing, we would give nitric oxide, and if it is positive, we would start the patient on calcium channel blocker. That's an indication for doing a vasodilator testing. My question here is, in presence of right ventricular dysfunction, do we require to do vasodilator testing? Because any which ways, even if it is positive, we may not be starting the patient on a calcium channel blocker. So considering all these, we gave objective criteria on echocardiogram, and if the objective criteria are being satisfied, then we may be able to defer right heart catheterization for some time, and we can start the patient on medications even before doing a right heart catheterization. I think this is the first document of its kind which gives this criteria to enable physicians to initiate pulmonary vasodilator therapy before doing a right heart catheterization. Having said that, I am emphasizing that it is just deference of the right heart catheterization, and not actually, you're not going away with the right heart catheterization. You start the patient on medication, stabilize the patient, and once the patient is stabilized, then do a right heart catheterization at some point in time. How do we do it? So we assess the basal hemodynamics, also do an oximetry run if the mixed venous saturation is more than 75%, do a cardiac output measurement using thermodilution technique or indirect fixed method, do an acute vasodilator testing, and in special circumstances, do an exercise testing or a fluid challenge as it is required. So right heart catheterization in adults is usually done under local anesthesia and maybe some kind of sedation. In pediatrics, we usually prefer to do it under general anesthesia, especially if the child is less than 30 kilos. We prefer the right IJV if the child is more than 30 kilos, or in an adults. That is how I personally like to do right heart catheterization, through the right IJV. And if it is less than 30 kilos, then usually femoral, and that's primarily because the smallest Swan-Ganz available is around 7.5 to 8 French in our country, and that would require an 8 French sheath, which will be quite large for the child who is less than 30 kilos. There are advantages and disadvantages of each, but preference, if possible, to do a right heart catheterization through the IJV. This is the Swan-Ganz catheter which I was talking about. It's a balloon flotation catheter. It's not very difficult procedure to do. Take the right IJV under ultrasound and float it under fluoroscopy. You may not always require fluoroscopy also to float it, because it's a floating catheter. It has 3 ports, 1 distal and 2 proximal. The distal one measures the pulmonary artery pressure. The proximal measures the right atrial pressure. and the one is for injection of saline for the thermodilation technique. This is a thermistor port which measures the temperature difference between the proximal as well as the distal tip, which helps us in calculating the cardiac output, and the balloon inflation port. And the distal pressure, we can measure the pulmonary artery pressure as well as the pulmonary artery wedge pressure. More important, and this is the most important step while doing a right heart catheterization, is calibration and zeroing. Now, wrong zero level is one of the most common errors and confounding factors in pulmonary arterial hypertension. And this is especially true for the fluid-filled catheters that we use. There are various ways of doing the zeroing. What we use is the coax method, which is at the center of the left atrium. So at the mid-axillary line, we zero it so that the measurements are as accurate as possible. And this is the error which we introduce if we don't do zeroing. Now, this is a ventricular diastolic pressure, and as we all know, the ventricular diastolic pressure has to be zero. Now, if this is not zero, we are probably overestimating the pressure. So you see the end diastolic pressures here, it's around 14 to 16. The same patient, if the zero is down, the pressure is around 5 to 10. So both of these are not accurate. The diastolic pressure has to be at zero. So for us to accurately measure the end diastolic pressures, and if we are, this is an indirect way of knowing whether we are doing it the right way or not. So make sure that the diastolic pressure is at zero, and if it is at zero, then we are probably measuring the pressures accurately. Also, we measure the pressures at, we see a lot of respiratory variations. It has to be done under normal respiration and without any Valsalva or breath holding, and measure the end expiratory pressure. And it's particularly important for measuring the pulmonary artery wedge pressure, and I'll show you an example of how it changed from group 1 to group 2 if we use the end expiratory pressure and not the mean pressure as calculated by the machine. So these are the various normal pressures. I think we have seen this before. It's very, very important to measure the pulmonary artery wedge pressure accurately. And when we are doing it, it has to be equal or lower than the diastolic PA pressure. We have to see clear A and V waves. You can see the clear A and V waves here. You see the clear A and V waves there. There has to be some respiratory swing, a stable catheter position on fluoroscopy, and blood sample from the distal should be equal to the patient's oxygen saturation or should be higher. So these are the ways in which we can know that the pulmonary artery wedge, what we are measuring, is accurate. So if you see this pulmonary artery wedge pressure tracing, and this is the tracing, we can see the A and the V waves, and this is the machine calculated mean. So the machine calculated mean, you can see it's around 11 or 12 millimeters of mercury. But if you actually use the end expiratory pressure here to calculate the pulmonary artery wedge pressure, it will come to around 16 or 17. So here I'm getting a machine calculated value of less than 15, which will go into group 1. Here I'm getting a calculated end expiratory pressure, which will be around 16 or 17. So that will change between group 1 and group 2. The machine is calculating this as 12 because it is taking this into consideration. So this is inspiration. So you see in inspiration, the pressures are very low. In expiration, the pressures are expected to be high. But what we are more interested in classification is looking at this end expiratory pressure, and don't look at the mean pressure as calculated by the machine itself. And when in doubt, always look at the ventricular and diastolic pressure. Coming to vasodilator testing, it is to be done in idiopathic, heritable, and drug-induced PH, and also congenital heart disease PH. Ideal pulmonary vasodilator has to be short-acting. It has to act specifically on the pulmonary circulation with minimal action on the systemic circulation. Inhaled nitric oxide, iloprost, and epoprostenol are the ones which are recommended. Inhaled nitric oxide is most ideal. It's available in the country. Iloprost and epoprostenol are not freely available in the country. Previously, adenosine, which was recommended, could be used as one of the pulmonary vasodilators, no longer recommended in the recent ESC/ERS guidelines, and that is because of the risk of causing hypotension with adenosine. So this is one patient in which we had a vasodilator testing. You can see the green pressures is the pulmonary artery pressure. The red pressure is the systemic pressure. The patient clearly had suprasystemic PA pressures. And once we started nitric oxide, you can see the difference. they kind of separate quite beautifully. And whenever the patient is responsive, what we have seen in the cath lab, in the first 1 or 2 minutes only, you start to see this difference. The systemic pressures goes on increasing, the PA pressures goes on decreasing, and that is maintained over the next 10 minutes. So that is associated with increase in cardiac output, or cardiac output remains the same, does not decrease. We usually use the Sit-Bond criteria, which defines vasodilator testing positivity as a drop in mean PA pressure of more than 10 millimeters of mercury to reach a level of below 40 millimeters of mercury with increase or no change in cardiac output. The incidence of positivity test, as told by Dr. Sandeep Sahai, also is around 6 to 10%. And only the patients who are vasodilator positive, we can start them on calcium channel blockers. Now, because nitric oxide is not easily available in the country, there is a lot of questions which are happening is whether sildenafil, which is also acting on the nitric oxide pathway, could be used for vasodilator testing. And one of our colleagues from south of India has published a study in which they looked at acutely it may be almost similar to nitric oxide. However, I found one study from Gießen which showed that they do not always concur the nitric oxide response and the sildenafil response. And if you see the long term, a patient who is responder to nitric oxide fares much better as compared to the patient who is responding, who's classified as responder based on sildenafil. So maybe acutely we may feel that they are same, but if you look at a long period of time, so this is almost 10, 12 years, definitely the patients who are nitric oxide positive, they do much better as compared. So they are probably not equal. We need more data to identify whether we can still use sildenafil as a pulmonary vasodilator during an acute vasodilator testing. Any which ways, if we use nitric oxide and whichever criteria we use, responders, we know to do much better as compared to those who are not responders. Now, right heart catheterization can also be used for prognostication. If the cardiac index is more than 2, they have a low risk. If the cardiac index is less than 2, it is high risk. Similarly, stroke volume and stroke volume index could be used because it may be slightly more accurate than the cardiac index because it accounts for compensatory heart rate response. So stroke volume multiplied by heart rate will be the cardiac output. So if you take out the heart rate response, stroke volume may be more accurate as compared to cardiac output. And it was found that stroke volume less than 39 ml per minute per meter square has a higher mortality as compared to the one with more than 39 ml per meter square. Similarly, pulmonary vascular resistance more than 20 has worse prognosis. A newer indicator, which is the capacitance index, which is a ratio of the stroke volume divided by the PA pulse pressure. A patient with a lower capacitance index has a worse prognosis as compared to patient with a higher capacitance index. Similarly, RV stroke volume, it tries to look into the RV-PA coupling. It's a marker of RV-PA coupling. And lower RV stroke volume index for a similar PVR indicates worse prognosis. So special circumstances, exercise testing, fluid challenge, and congenital heart disease. Now, at least I am not aware of any lab in India, cath lab in India, who has a simultaneous exercise laboratory which is available. However, it is useful in patients with scleroderma PH and CTD PH. If the patients are made to exercise, if the increase in the baseline is more than 3 mm per mercury per liter per minute, the PA by cardiac output slope, then it is suggestive of early pulmonary vascular disease. Similarly, ratio of pulmonary artery wedge pressure to cardiac output slope of more than 2 is suggestive of heart failure with preserved ejection fraction. Fluid challenge we can easily do, giving 500 ml bolus to the patient if the LVEDP is less than 15 or PA wedge is less than 15, and if we give 500 ml bolus saline over 5 to 10 minutes and a passive leg raise also may be helpful. An increase in PA wedge pressure more than 18 millimeters of mercury may indicate a patient with heart failure with preserved ejection fraction. Now, assessing operability in congenital heart disease is a separate topic by itself. I wouldn't go too much into details. It would take another 20 minutes for me to complete the talk if I go into that. However, I would like to insist one thing is try and avoid oxygen for pulmonary vasodilate testing, especially in congenital heart disease, because along with systemic circulation, oxygen has an effect on pulmonary circulation as well. And this is a very old paper. And we had published our study also in 2017, I think. So oxygen increases the QP, decreases the PVR. At the same time, it decreases the cardiac index and increases the systemic vascular resistance. So if we have a child or a patient who has got a congenital heart disease, a VSD, this is a basal QP, QS, SVRI. When we give oxygen, there is increase in QP and decrease in PVRI. However, because it also has an effect on the systemic circulation, it causes decrease in QS and increase in SVRI. Consequently, this shunt here increases. Now, the increase in the shunt is because of the decrease in the QP and increase in QP and decrease in PVRI, or decrease in QS and increase in SVRI is anybody's guess. So please try and avoid using oxygen for vasodilate testing in congenital heart disease and PH. Risk factors, there are not many, but no procedure is without risk factors. This is again our study which we published in 2015 in cardiology, in which we looked at 96 patients whom we had done a right heart catheterization. There were 3 adverse events. Most of the patients who had adverse events were in class 3 and 4 and were treatment naive with moderate to severe RV systolic dysfunction. So a treatment naive patient who is functional class 3 and 4 with moderate to severe RV dysfunction, it may not be wise to send this patient to the cath lab right away. Maybe start the medication, stabilize the patient, and then send for the cath lab. This is another meta-analysis done which shows similarly that the patients with cardiomyopathy, pulmonary vein disease, if the child is premature, less than 30 days, renal insufficiency and use of inotropes are associated with worse prognosis or associated with higher risk during the cardiac catheterization. Now, this is one of our patients. You can see this X-ray, nice and clear. We took the patient to the cath lab, and this is what happened once we gave nitric oxide. Any guesses what has happened? So this patient has gone into pulmonary edema as soon as we gave nitric oxide. And that is because this patient had something which called as a pulmonary veno-occlusive disease, in which the patient goes into pulmonary edema. So you cannot, because the the venous system is a problem. If you decrease the pulmonary artery pressure, they go into pulmonary edema. Now, luckily, we were using nitric oxide, which has a very short half-life. You can see this is unintubated patient. We had to intubate the child. The effect of nitric oxide went away in 5 to 10 minutes, and that is the reason we could salvage this. Now, imagine this scenario in which if you were using sildenafil in this patient while doing a right heart catheterization, sildenafil is longer acting, half-life is 7 to 8 hours, we would probably be in much more soup rather than using nitric oxide. So to conclude, right heart catheterization is the gold standard for diagnosis and classification of pulmonary hypertension. It is safe in experienced centers. It judges response to therapy, confers prognostic value, and helps clinical decision making. So, yes, refer the patients for right heart catheterization, do it in the right way, and it will give you a lot of information which can help you manage your patients better. Thank you so much for your kind attention.
Thank you, Dr. Prashant. It was a nice presentation. And any questions from the audience?
Can you go back to the previous X-ray?
Yeah.
So post-nitric oxide, why this cardiac size has decreased? If it is patient is going to edema, why the size has decreased?
So I am not sure, but I think it is because intubation. I think there are different cardiac, different phases of respiration. This is probably.
So probably it is ARDS, I think. If cardiac size has decreased, so because in edema, of course, it is not going to decrease. In the previous exercise, you have cardiomegaly, and then you have normal cardiac size.
No, I think this is a different respiratory. This is a different respiratory phase.
नहीं सर एक्सपिरेटरी कहाँ है?
नहीं this is
1 2 3 4 5 5.5 पे आ रहा है.
This is a different respiratory phase. This is positive pressure. This is positive pressure ventilation. This is spontaneously breathing.
this X-ray is not representative of pulmonary edema.
Anyways, when we stopped it, the patient came out of pulmonary edema.
There is one thing that I would need clarification for my purpose. Although we don't have much of personal experience doing, we have done right heart catheterization in only 2 patients when I was here. After that, maybe or bhi hue honge. So, and that too using adenosine because nitric oxide was not available. So, sir, we all know the Sedgman's criteria of reactivity testing. Although there are no head-to-head trials in reactive patients for CCB against other pulmonary hypertension drugs in reactive patients. And this Sedgman's paper in 2005 was the only paper prospective trial, around 500 patients, which showed that around only 12-13 patients were vasoreactive, and out of that only like 6%, 50% of them were chronic long-term responders. And around there was like 5-year mortality was around 48% in non-responders. So given this light, in light of this information, would we again go, like routinely go for vasoreactive testing in primary PH patient, or what is the risk benefit ratio? It seems to outweigh, the benefit seems to outweigh the risk.
That's a very good question. I have not put up my data as in this presentation. We still have to analyze it, but it's my personal opinion that, in India where calcium channel blockers are much cheaper as compared to the pulmonary vasodilators, it still has a role. Even if it is 10%, 8 to 10% of the patients who are vasodilator positive, you can start these patients on calcium channel blocker, which are cheaper, and they have, the prognosis is better in those patients. So doing a right heart catheterization, which costs somewhere between 25 to 30,000 rupees, 1 month medication of dual pulmonary vasodilators, tadalafil and ambrisentan, would cost the patient around 6,000 to 7,000 rupees. So you would be saving that much amount of money over a long period of time. So, and what we have found in our own patients also, like treatment naive patients, we don't usually go ahead for a right heart catheterization unless the patient has got a reasonably good right ventricular function. So we don't go for a right heart cath at that point in time. But even in the patients who are on dual pulmonary vasodilators, when we do the right heart catheterization 3 months or 6 months down the line, some of these patients do have vasodilator positive response. And we have converted these patients from a dual pulmonary vaso, added the calcium channel blocker and removed ambrisentan, which is the costlier medication. And I think the longest follow-up I have of this kind of patients is around 8 years, 8 or 9 years. And that patient is still on calcium channel blocker and sildenafil. So, and still has a good response to both of them, still is in functional class 2 with an NT-proBNP of less than 100. So there is a value. I wouldn't say there is absolutely no value, but the timing has to be very, very crucial. In a treatment-naive patient, functional class 3 and 4, moderate to severe RV dysfunction, we may not be justified to do a right heart catheterization by itself, leave alone vasodilator testing.
Long-term responders are still far less compared to what the testing shows.
Yes, so, but even if you have 10 patients, even if you have 10 patients or 15 patients who are vasodilator positive, 10% patients who are vasodilator positive, those 10% patients would benefit quite a lot as compared to the other 90%.
In those patients who responded initially and who were reactive, have you repeated right heart?
No, we don't usually repeat the right heart catheterization electively. We don't repeat them electively. We repeat them if the patient is not doing well. Say we start on calcium channel blockers, and 4 years, 5 years down the line, the patient starts developing symptoms again. NT-proBNP goes on increasing, 6-minute walk test goes on decreasing. In those patients, we have done a repeat right heart catheterization, and some of them have lost the vasoreactive testing, vasodilator positive. So in them, then we started on calcium on ambrisentan after the vasodilator positivity had become negative over a period of time.
Thank you, sir. I hope that you publish some of that data.
Yeah.
Soon. Thank you.
So in our institution, So when I say 28,000 for a right heart cath, it includes nitric oxide. And I think that's true for most of the institutions. It's around 25 to 30,000 rupees for doing a right heart catheterization, which includes vascular testing with nitric oxide.
Thank you.
Thank you so much.
Thank you, Prashant.
Thank you, respected speaker and chairpersons. I would like you to collect your mementos from the felicitation counter. For the next session focused on latest updates in the management of pulmonary hypertension, I would like to invite our respected chairpersons, Dr. Rachit Sharma, Associate Professor, Department of Respiratory Medicine, Eras Lucknow Medical College and Hospital, Dr. Akshay Pradhan, Professor, Department of Cardiology, King George's Medical University, Lucknow. We welcome our chairpersons.
I think it's a proud privilege for us to announce our own alumni, Dr. Satyavir Yadav from AIIMS, New Delhi, the prestigious Institute of Cardiology in India. And Dr. Satyavir has been a brilliant student during his EM career, and we are really proud to be one of his teachers. I think he has a vast experience in intervention and non-intervention. He publishes a lot. He's a good speaker. You can see him at all the major conferences across the country. Welcome, Dr. Satyavir.
Thank you very much, sir, for the warm welcome. And I would like to thank the organizers for this opportunity. So I'll be discussing about the updates in the management of PAH. So as we all know that pulmonary hypertension is classified in 5 groups. And the group 1 is basically PAH. Rest all are PAH. So pulmonary arterial hypertension is basically denotes group 1 PH. So as we all know that group 1 PH is rare, and group 2 and group 3, which is basically PH due to left heart disease and PH due to lung disease, are more common. But unfortunately, the management part basically deals with PAH. We don't have therapy for group 3 and group 2, which are the large majority of PH patients. So I'll be discussing about the management of PAH. So PH basically comprises idiopathic PH, then drug or toxin associated. But in our country, mostly PH is idiopathic. We don't see much of drug or toxin associated PH. However, we see connective tissue disorder associated PH also after the idiopathic PH. So our majority of patients are basically idiopathic PH and CTD PH, where we can give some type of therapy. So before giving any medications in PH patients, the vasoreactive testing is mandatory, which is a part of right heart catheterization. Dr. Prashant already told us about the part of vasoreactive testing, so I won't go much detail in the vasoreactive testing, but it's mandatory for idiopathic, hereditary, and drug-induced PH. One important part in type 1 PH, it's not indicated in CTD-associated PH. So it's usually contraindicated in CTD PH. So anybody who is having CTD PH, vasoreactivity is usually not recommended. And only 5 to 10% of patients are vasoreactive, but it's also a big number because majority of these PH patients are female in the age group of 20 to 40, or mostly PH patients are females. So suppose somebody is vasoreactive and we are able to achieve good response on CCB, then we can avoid all the expensive PS specific therapy, which are usually teratogenic also. So these are childbearing potential patients. So we can give calcium channel blocker to such patients. And agents are inhaled nitric oxide, iloprost, or epoprostenol. But unfortunately, availability of these agents is also a big issue. Cost is also a big issue, because most of our patients, most of the catheterizations, we usually charge in the range of 3,000 to 5,000 rupees. So it's not feasible for us to use these agents. So we can, in such situation, we can use a cheaper agent, which is adenosine. So positive response is basically if the patient is having a PA pressure less than 40 absolute value, or if the pressure is decreasing to less than 10 millimeter of mercury, but that should be without decreasing in the cardiac output. And if the patient is class 4 or patient is having hypotension, then we should not do vasoreactive testing. So suppose you did the vasoreactive testing, there are chances 5% patients who are vasoreactive, then we have to give oral calcium therapy to such patients. But if the patient is non-vasoreactive, then we have to start the patient on dual pulmonary vasodilator, which is usually ambrisentan with tadalafil. But suppose the patient is having a class 4 and other high-risk features like NT-proBNP is quite elevated, patient is having pericardial effusion. In such patients, we usually start with the triple therapy, which is ambrisentan, tadalafil with IV prostacyclins. But however, IV prostacyclins are not easily available. I am working at All India Institute and we don't have access to IV prostacyclins. So in such patients, we can use oral prostacyclin analog in the form of selexipag. So this is also, although guidelines don't recommend, but in our scenario, we can use triple therapy. Patient is having class 4, having repeated syncope, pericardial effusion. Otherwise, we have to start with the dual therapy, either in the form of ambrisentan with tadalafil or macitentan with tadalafil. So I will discuss how, why the guidelines recommend these ambrisentan with tadalafil or macitentan with tadalafil. So the evidence is basically from some major trials. Before that, I would like to discuss about 3 targeted pathways, although Dr. Sandeep discussed about these. So we have endothelin 1 pathway. So ambrisentan, bosentan, and macitentan work on these pathways, while we have prostacyclin pathways, epoprostenol, treprostinil, iloprost, and selexipag work on prostacyclin pathway, while sildenafil and tadalafil work on the nitric oxide pathways, and riociguat also work on the same pathway. So the dual therapy that most of the guidelines now recommend that we should straight away start the patient on dual therapy comes mainly from the AMBITION trial. So it was a large trial which took around 500 patients, and they randomized in 2:1:1 form. And the primary endpoint for this trial was the reduction in clinical failure rate, and main benefit of this dual therapy was in the form of that the patients who were on the dual therapy, the hospitalization due to progressive PS was significantly reduced in such patients. As we can see that the hazard ratio was around 0.5, so there was around 50% reduction in the hospitalizations. So after the AMBITION trial, it was most of the guidelines started recommending dual vasodilator therapy as a class 1 therapy for such patients, because most of the patients of PH are in WHO classification class 2 or class 3. We use WHO classification for PS and NYHA classification for other heart failure patients. So most of our patients are in class 2 or class 3. So this trial basically fits to our patients who are coming into class 2 or class 3. Then another important trial came, Griffin study. So they basically studied, suppose somebody is taking initial combination therapy, then how should we add selexipag as a upfront combination, or should we add as a sequential therapy? So this trial almost included 1,200 patients. Around 20% patients were not taking any therapy, while around 50% patients were on monotherapy, while around 1/3 of the patients were on the combination therapy. So this, after adding selexipag in the dose of 200 to 1,600 microgram twice in a day, so they also found significant improvement in the composite endpoint of worsening clinical endpoints, and there was around 40% reduction in the clinical endpoints. Another study which basically compared dual therapy with the initial combination therapy. So one arm was receiving macitentan, tadalafil, and selexipag, while other arm was on the dual therapy, but there was no significant difference in the primary endpoint in the form of pulmonary vascular resistance, 6-minute walk distance, and NT-proBNP. However, there was secondary analysis in the form of secondary endpoints. There was 40% reduction in the disease progression, but that was not the primary endpoint, and trial was not powered for that. So guidelines don't recommend initial combination therapy. So this is the slide which is showing what the guideline says. I already told you initial combination ambrisentan with tadalafil is class 1 recommendation. Macitentan with tadalafil is also class 1 recommendation, while other ERAs and PDE5 inhibitors are class 2A, while initial combination is not recommended. So apart from these endothelin receptor antagonist and PDE5 inhibitors, we now have a new agent which is sotatercept, and it is believed to it's considered as a disease-modifying therapy because in some trials it has decreased the mean pulmonary arterial pressures, which till now no other therapy has shown. It's basically act on the activin receptor. So this is a slide which is showing all the, I've tried to include almost all the trials of sotatercept. So initially, Pulsar, Stellar trial, Pulsar trial was phase 2 trial, then Stellar trial came, Soteria trial, Spectra trial, recently Hyperion and Zenith trial also published. Now there is an ongoing trial, Moonbeam, in pediatric population of sotatercept. So I'll try to discuss few of these trials in detail. So initially Stellar trial, which was published in 2023 in New England Journal of Medicine. So they basically took around 160 patients, and the dose of sotatercept is 0.3 milligram per kg, and they increase up to 0.7 milligram per kg every 3 weeks. So they randomize in 1:1 group, and the difference was basically in the 6-minute walk test and time to first occurrence of death or non-fatal clinical event. So there was significant difference. The p-value was significant. Another trial of sotatercept was in high-risk patients with PH. So in this trial, most of the patients were the patients who were waiting for lung transplant. So in this trial, around 160 patients, the primary endpoint was a composite of death, lung transplantation, and hospitalization due to worsening PES, and there was significant difference. So, and apart from the primary endpoint, almost all the secondary endpoints were significant in the sotatercept group. So this trial basically showed that if we use sotatercept in advanced PH, those who are waiting for lung transplant, it significantly decreased the composite of death with hospitalization. So after the overwhelming benefit of sotatercept in the severe PH group, the sotatercept research group tried to give sotatercept in the patients who were just diagnosed with PH. The criteria was, the inclusion criteria was that they should have a PH diagnosis within 1 year. So in this trial also, they found significant benefit and the mean PA pressure was reduced. So this trial was prematurely terminated because of the overwhelming benefit in the initial phase of PH also. So apart from these all therapies, we should be careful about some general measures in PH patients. We should give diuretic therapy if patient is congested. And If the patient is having hypoxemia at rest, we should give supplemental oxygen. Then anticoagulation is also an important aspect, which is a cheap therapy, and some guidelines says that it's a class 2 indication, and some have downgraded oral anticoagulation to 2B also. However, there are no randomized trials like we have for endothelin receptor antagonists for anticoagulation. We are doing one randomized trial for anticoagulation in PAS patients. Then diet and exercise is also a role in as a general measures, and vaccinations are also important as influenza and pneumococcal vaccines. Then if suppose somebody is asking for what precautions they should take before air travel, then we should tell them that they should take routine medications and they should use the supplemental oxygen if the oxygen saturation is less than 92%. Another important thing is contraceptions. So long-acting reversible contraceptives can be used. However, estrogen-containing contraceptives should be avoided, and progesterone-only pill may be used, but they also interact with the cytochrome P450 enzymes. So bosentan usually decreases the effectiveness of progesterone-only pills. Another important part is the pregnancy concerns in the PAS. So maternal mortality is around 11 to 25% in such patients. So we should not give endothelin receptor antagonist and riociguat in such patients. So only available therapy in our countries, we can safely use sildenafil and tadalafil if the patient is pregnant and having PAS. So we should be very careful. We should not give ERAs and riociguat. However, we can use calcium channel blocker, PD5 inhibitor. Prostacyclins we usually don't have access. Another important aspect is the follow-up. So these patients require a close follow-up. So suppose you are starting therapy, then you should ask the patient to come within 6 weeks and after every 3 months. And you should what you should assess. You should do the WHO functional classification. Then you should do 6-minute walk distance and anti-pro-BNP or BNP you can do. Echo you can do on the follow-up. But if the patient is deteriorating, the symptoms are disproportionate to your TR gradient, because in idiopathic PS patient, echo is not a very good modality. We don't get good signals of TR in such patients. So it's sometimes give a false sense of hope that patient is improving. So if the patient is clinically deteriorating, it's better to do a cath. Then there are some tools for refractory patients. You can put the patient on ECMO and right to left shunt, like you can do atrial septostomy, you can put atrial flow regulator and port shunt, both surgically and transcatheter port shunts have been tried in refractory patients. Septostomy, we also done balloon atrial septostomy in some patients, but we have to be careful if we are doing balloon septostomy. The patient's mean RA pressure should be less than 20 and baseline saturation should be more than 85. Otherwise, these patients don't tolerate the balloon atrial septostomy. Then last resort is the lung transplantation. So apart from these therapies, sotatercept I have already discussed, seralutinib, imatinib, and rodatristat and sirolimus are being tried, and few of them recently published also. So one is ralinepag, which is similar to selexipag. It's an oral prostacyclin analog, just published in Lancet few days back. So the main difference between two is that it's single selexipag we use twice in a day, while this ralinepag we can use once in a day. So we can, if it's available in near future in our country, we can use this ralinepag in the patients who are WHO class 3 or class 4. So the efficacy and safety was good. However, the patients who were given this therapy, there were some side effects and patient stopped the medication. Another is the seralutinib, which was tested as a phase 2 trial, and now there is a extension studies also going on. So it was tested in few patients, and the primary endpoint was PVR, and there was significant improvement in pulmonary vascular resistance. So maybe in future we can have seralutinib for PH patients. So to summarize my talk, the signs and symptoms of PH are very subtle and non-specific. Sometimes patients do complain of dyspnea, palpitation, and syncope. So we have to carefully look for the symptoms and signs. Then we have to keep our threshold very low to identify patient early in the disease course, because most of our patients, we work in a referral center. Most of our patients are having PEH with the mean pulmonary artery pressure of around 100 milli. They are in the range of systemic pressures. So by the time patient of idiopathic PH comes to a referral center, they are in the sickest of the forms. So for a person, for a resident, or for a physician who are working in the periphery, they should have a lower threshold. They should identify patient as early as possible, because most of the middle-aged female, they usually complain of chest pain, dyspnea, and we don't take them seriously. We don't do echo properly. Sometimes we do miss PH on echo because TR signals are not great. So if we try to find such patients early in the disease course, we now have good therapies that can improve survival also. Another thing is initial combination therapy is required for most of the patients, while translational studies have suggested some alternative pathways in the form of sotatercept, seralutinib. So we have hope that in coming decade, we might improve the prognosis of PH patients, because 20 years back, 10-year survival of such patients was around 30 to 40%, while now 10-year survival is in the range of 50 to 60%. And we are hoping that with the translational therapy, we can improve the prognosis of such patients, and we can improve the prognosis in the range of 10-year survival of around 80%. Thank you.
So there is a proverb in English which says that what the mind does not know, the eyes cannot see. So PH is such a disease which we don't expect as a physician, as a clinician, as an echocardiographer. And I must congratulate the organizers for organizing a meeting on such a underdiagnosed and under-recognized conditions, yet highly prevalent and highly catastrophic. And as you rightly pointed out, even not in India, even Western centers, the mean period from a symptom onset to diagnosis is around 4 years. It's not that we are doing bad. I think the entire globe is doing bad. Thank you so much for an excellent lecture. A few comments from my side. When you said that in CTD-PH, you don't need to do vasoreactivity testing.
It's contraindicated.
So is it because they are found to be non-reactive, or because they worsen after the...
So there are two reasons. Most of them are non-reactive and associated ILD also. Most of the CTD-PH are having lung disease also. So that's why vasoreactivity is usually not recommended.
Any experience with sotatercept?
So I have used sotatercept in, I think, 4 patients. And just in the initial phase, they are doing well. But all the 4 patients are quite very sick patients. But we have just started using in last 3 months. I have used in 4 patients, and we are following. We don't know the long-term effect, and the problem with sotatercept is 1 vial of 45 mg is costing around 3.1 lakh rupees, which is very, very costly for patients. So what we do, we just club 2 patients, because most of the patients having body weight of around 30 to 40 kg. So 45 milligram vial we can use in 2 or 3 patients. And that's the only thing. And we don't know, because you have to give at least for 6 months, thrice weekly dose. So it's very costly.
Any specific side effects with sotatercept which you should be
worried about?
So there
are 2 side effects. One is thrombocytopenia, and another is the polycythemia. So if the hemoglobin is increasing by 2, then you have to, you can stop and you should wait. If the hemoglobin is increasing by 1 milligram per deciliter, then you should not increase the dose from 0.3 milligram per kg to 0.7. You can keep the dose and you can watch for that. For thrombocytopenia, if there are any bleeding manifestations or if the platelet count is less than 50,000, then you can think of stopping and you wait for platelet to rise, and you can try after 3 weeks in such situation also. Another one is telangiectasia. These are the common side effects.
Thank you. So we have a large body of rheumatic heart disease patients who are either inoperable or who don't want to go therapy, and it's again a residual unmet need for pulmonary hypertension. So any experience of using this?
Unfortunately, as I told in the beginning, that sir, you are talking about the group 2 and group 3 PS. So unfortunately, these medications, they don't improve, but sometimes they do harm also for such patients. So we don't use these agents for rheumatic heart disease associated PH.
Thank you so much. Any questions from the floor? Or else we can close the session.
Sir, which group of pulmonary hypertension we can reverse the pressure after giving the medications?
So in group 1 PH, sotatercept has shown in some trials that it decreases the mean pulmonary arterial pressures. So this is the only agent which has shown in the studies to decrease the mean pulmonary artery pressure. That's why it's being considered as a disease reversal agent.
Yes, for group 1, sotatercept is a very good agent, and we have also put one patient on sotatercept. So that is also till now it is 3 months, and there is no side effect so far, and symptoms are getting improving.
It's simple. It's like insulin. You can use subcutaneously. First dose you have to give in the hospital. You can observe for 24 hours. After that, if the patient is not having any side effect, then you can tell the patient to use at home. But the cost is the main
so
problem.
Cost is the main factor. It is so costly, but the patient is in a program, so they are affording somehow.
Thank you.
Thank you, sir. I would like respected speaker and chairpersons to kindly collect the mementos from the felicitation desk. Our next session highlights modern pharmacotherapy for Group 1 pulmonary arterial hypertension. To chair this session, may I invite Dr. K.B. Gupta, sir, Professor and Head, Department of Respiratory Medicine, Eras Lucknow Medical College and Hospital, and Dr. Darshan Bajaj, Professor, Department of Respiratory Medicine, King George's Medical University, Lucknow.
Good morning, everyone. Now, first of all, my sincere thanks to organizer of this PH-ILD Summit, Professor Dept, for giving me this opportunity to chair this session in this scientific convention. Now, the topic is being discussed by Dr. Subhakar Kandi. Dr. Subhakar Kandi is a very well-known person, eminent physician, academician in the field of pulmonology. He is also the secretary of the Indian Chest Society, and he is the fellow of the Royal College of the Physician, London, fellow of the American College of Chest Physician, chair International Council of the Global Governor's Chest, national security in Indian society. And then the Government of India several national and international awards contributed to the standard of the TB care in India, 60 publications in national and international journal, and postgrad teacher and examiner for 28 universities in the country. May I invite Dr. Gandhi to kindly deliver his talk.
Thank you, Dr. Gupta ji. At the outset, I thank Dr. Ved Prakash and his team for inviting me to share some of my thoughts in the modern treatment of Group 1 PH. Unfortunately, the previous talk, it is almost a repetition. I don't know why. When I asked, he will discuss overall update. There's nothing to discuss in Group 2 and Group 3 and Group 4 and Group 5 management because there is no pharmacotherapy. You have to treat the cause. If you have the cardiac problem, treat the cardiac problem. If it's due to lung, address the lung issues. So if it's a chronic thromboembolic, there is surgery is a role. Only, of course, Resetigard has a role in the Group 4, and Group 5 is unclassified. So only change, I think you have to pardon me, most of the slides will be a repetition. Only change is the change of chairpersons and change of the speakers. That's all and of course, the slide font also is changed. I think if you go back to the development of drugs, before 1995, we have only calcium channel blockers with us. From 1995, the various agents have come into the development and the treatment of pulmonary hypertension. Initially, the intravenous epoprostenol, then bosantin, then sildenafil, in 2007, ambrisentan, in 2009, tadalafil, and 2013, Resetigard, and 2015, the Selexipag, and 2024, the sotatercept, the molecule which I think there was a discussion. And the other agents also, the previous speaker, Dr. Yadav, has highlighted us. So I did not go again to the classification of pulmonary hypertension. So how this pulmonary hypertension is classified? Based on the etiology and based on the hemodynamics. If you see on the etiology, the Group 1 classification is mainly idiopathic or heritable, mainly because of the genes. The most common associated gene is BMPR2, other being ACVR1, and all those are tongue twisters. And the drugs and toxins, the most commonly the drugs which can produce Group 1 pulmonary hypertension are all those drugs which you use for obesity like fenfluramine, amphetamine, and cytotoxic drugs which used for leukemias. They can produce Group 1 hypertension. The other causes being like connective tissue diseases, mainly scleroderma, and mixed connective tissue disease can also produce Group 1 pulmonary hypertension, and HIV is one of the important causes which can produce the Group 1 pulmonary hypertension. And the liver diseases and congenital heart disease can also produce Group 1 pulmonary hypertension. Schistosomiasis, of course, there is a Group 3 mainly due to lung, but schistosomiasis of lung infection is classified under Group 1 because here the mechanism of pulmonary hypertension is because of the larvae clog the pulmonary vessels and they produce vasoconstriction and ultimately leads to pulmonary hypertension. If you see the hemodynamic dashboard, so previously the cutoff is 25 millimeters of mercury. Now the cutoff has come to 20 millimeters of mercury. So any pressure beyond, mean arterial pressure beyond 20 millimeters of mercury, you can label it as a Group 1 pulmonary hypertension. And then the pulmonary vascular resistance, previously it was 3 Wood units. Now anything above more than 2 Wood units is considered as a group 1 pulmonary hypertension. And the other important is pulmonary arterial wedge pressure equal or less than 50 millimeters of mercury. This is, suppose if it's more, it is due to left heart disease. If it is less, it is group 1 pulmonary hypertension. With this, we'll go into the next thing. And I think there was a lot of discussion on the vasoreactive test. So now you cannot diagnose any pulmonary hypertension without right heart catheterization. I think we have a wonderful lecture from Dr. Prashant. He has discussed how to do the right heart catheterization, and he has shown his experience. Unfortunately, most of the cases in India being diagnosed by non-invasive test, which is not the case. The gold standard is still the right heart catheterization. Without right heart catheterization, you can't label it as a group 1 pulmonary hypertension. And once you do the right heart catheterization, the next is the vasoreactive test. I think this was also discussed in the previous speaker. So we confine this vasoreactive test to idiopathic, heritable, and drug-induced pulmonary hypertension only. And I think there was a question also, why can't you do in the vasoreactive test? This was already explained. And the agents used is inhaled nitric oxide, intravenous epoprostenol, and intravenous adenosine. And to say it is a positive test, there should be more than 10 millimeters of mercury fall, and the absolute should be 40 millimeters of mercury, and the cardiac output should be stable or increase. If there's a fall in the cardiac output, you can't assess that. So once vasoreactive test is positive, you can try out for calcium channel blockers. I think everybody understood these calcium channel blockers are used for a long time for the management of systemic hypertension. When the vasoreactive test is positive, as already told, there's 10% of these patients, there will be vasoreactive test is positive. Out of these patients, 5% of these patients respond to calcium channel blockers, and this calcium channel, because calcium inside the vessel causes vasoconstriction, so it prevents the entry of calcium into the vessel. That is why they can reduce the pulmonary hypertension. The calcium channel blockers, we all already know, the nifedipine, diltiazem, and amlodipine. The best agent to be is, if you want to give a calcium channel blocker, particularly in a government setup where the medicines are not available, if it is a group 1 pulmonary hypertension and if vasoreactive test is positive, amlodipine is the best choice. And mind you, don't use verapamil, which is strictly contraindicated because it produces potent negative inotropic effect. Even though verapamil is a calcium channel blocker, you should not use verapamil when you are treating a group 1 pulmonary hypertension in whose patients the vasoreactive test is positive. Then the pharmacotherapy. So if you want to give pharmacotherapy, you have to understand the pathways. If you understand the pathways, you can easily give the drugs targeting those pathways. There are 4 pathways. I think previous speaker has told 3 pathways. There are 4 pathways. The endothelial pathway, and the nitric oxide pathway, and the prostacyclin pathway, and the new pathway is the activin BMP pathway. Your drug sotatercept acts on this pathway. So endothelial pathway, I think endothelium 1 acts as a vasoconstrictor. So if you block that endothelium receptor blocker, antagonist, so it will relieve the vasoconstriction, thus it can produce vasodilatation. And not only that, these endothelium 1 receptors, 1 will have to produce mitogenesis, and because of the mitogenesis, there is a proliferation of smooth muscle, and smooth muscle proliferation will lead to narrowing of the vessel and produces pulmonary hypertension. So this, if you block those endothelial receptors, so you can prevent the vasoconstriction, you can prevent the mitogenesis. Thus these act, so the agents, I will come to the next slide. Then the nitric oxide pathway. The nitric oxide, endogenous nitric oxide promotes vasodilatation and anti-proliferation. So it is amplified by phosphodiesterase 5 inhibitors and soluble guanylate cyclase stimulators. What happens if this soluble guanylate cyclase is destroyed by this nitric oxide pathway? So it is blocks these phosphodiesterase 5 inhibitors, they enhances the stimulation and thus produce the vasodilatation. The third pathway is the prostacyclin pathway. This is a PGI2 promotes vasodilatation and antiplatelet effects. Antiplatelet effects means because the platelet aggregation, there will be narrowing of the vessel and which can produce vasoconstriction and pulmonary hypertension. So it prevents the platelet aggregation, the prostacyclin pathway, so and restores the prostanoids and IP receptor agonists. The fourth pathway is the signaling pathway and activin BMP pathway. It regulates smooth muscle proliferation versus apoptosis. There is an imbalance between the proliferation and apoptosis. What these pathway, the agents acting on this pathway, they promote the apoptosis and suppresses the proliferation. So the apoptosis pathway is high, when then this can produce, you can address the pulmonary hypertension, and sotatercept acts here to reverse the vascular remodeling. This is the only agent which can reverse the remodeling. You have to mind, somebody asked about sotatercept, they not only reduces the pulmonary artery pressure, it also reverses the remodeling. Normally, our concept is once remodeling happens, nothing will be reversed. But the sotatercept has shown it can produce remodeling also. And before starting these agents, we have to classify whether they are low risk profile or high risk profile or intermediate risk profile. Based on the risk profile, we give whether single agent, dual agent or triple agent is the question. So the test, which in the interest of time, I don't want to go into all those scoring systems, the WHO function class 1 and 2, mainly based on your 6-minute walk test. If it is more than 440 meters, in the 6-minute walk test is more than 440 meters, he falls under WHO class 1 and 2, and anti-pro-BNP, normal or mildly elevated, they're all classified as low or intermediate low risk profile. In this, we give upfront dual oral therapy. I think already the previous speaker said no more monotherapy. There is no more monotherapy for pulmonary hypertension. Always start with the dual therapy, and the agents I will come into the future slides. And if the WHO function class 3 and 4, based on 6-minute walk test distance, it is less than 440 meters, and echocardiography showing a right ventricular dysfunction, and anti-pro-BNP is moderately or markedly elevated. They are classified under WHO class 3 and class 4, and all these cases mandated triple therapy. I think you understand, you have to functionally classify them: low intermediate, high intermediate, and high risk. So if it is low intermediate and low risk profile, give dual therapy. If it is intermediate high and high risk profile, you give triple therapy. The basis is the WHO function classification by 6-minute walk test and anti-pro-BNP. Of course, before that, you have to rule out all other causes, do a spirometry, do a DLCO, do a HRCT test, do a 2D echo, all those tests, because you have to rule out other causes also. Then monotherapy, as I already told you, history. Now it is early dual therapy prevents irreversible remodeling. If there is a delay in starting the dual therapy, the remodeling happens, and which is irreversible. Of course, sotatercept has some effect on the remodeling. So the standard of care regime is, so the endothelium receptor antagonist, the best choice is macitentan, which is the best choice because it's once daily. You can use it once daily, and you give it along with combination of tadalafil 40 mg once daily. So among the endothelium receptor antagonists, bosentan, ambrisentan, and macitentan, macitentan is preferred choice because it has low hepatotoxicity, low peripheral edema, and long acting. That is the reason among these three agents of endothelial receptor antagonists, always choose macitentan. So when you want to give a dual therapy, give a combination of macitentan along with tadalafil. Of course, the other option is ambrisentan and tadalafil. Between these two, I prefer giving a macitentan along with tadalafil. The clinical rationale is hitting two distinct therapeutic pathways because we are addressing the endothelial receptor pathways and PDE5. So the nitric oxide pathway. So we are blocking two pathways. That is why the effect will be more. So I think the ambition trial the previous speaker has already discussed. I don't think it is only a repetition. They have compared monotherapy with a dual therapy. Dual therapy, there is a 50% reduction. With monotherapy, there is a 50% reduction in the clinical failure with the dual therapy. So after this ambition trial, monotherapy has gone into only history. So always give a dual therapy. So then the other agents like endothelial receptor agents and PDE5 and prostacyclin. The objective is they stop rapid clinical deterioration and protect the right ventricle via immediate pathway. And here it is triple therapy. When do you give triple therapy? WHO class 3 and 4, I think so. Thank you. At least one response has come from that side. So they are called high intermediate risk or high risk, and these are the cases ultimately go into heart transplantation. So these are the cases, severe pulmonary hypertension and right heart failure. So we have to give a triple therapy. In addition to the agents which we have discussed, that is endothelial receptor antagonist and PDE5, here the third agent added is prostacyclin. The prostacyclin selection is ideally the intravenous epoprostenol. There's a lot of data, long-term data. In the interest of time, I have removed, when he is presenting, I have removed the slides, all those slides. Intravenous epoprostenol is the long-term data is showing the only agent which was proved, and even though there are other treprostinil, all those agents, prostacyclins are there, the intravenous epoprostenol is used. So upfront triple therapy, in that you give endothelial receptor antagonist, PDE5 inhibitor, and parenteral prostacyclin. Again, in the parenteral prostacyclin, the preferred choice is intravenous epoprostenol. So this is a diagnostic matrix of different agents, mechanism, and dosing and toxicities. I think only a summary of these are. And these all doses I don't want to repeat. And you always no, I think if postgraduates are there, don't by heart these doses because always you have to carry a chart and so nobody can by heart so many thousands of drugs doses. So always carry a chart. So when these agents are given, how to follow up these patients? Every 3 to 6 months you follow up. Suppose if you are giving calcium channel blockers, do after 3 to 6 months. If there is an improvement, continue it. And if there is no improvement, you shift over to other therapies. Welcome, Dhruv Chaudhary, sir. The only survival proven monotherapy in severe PH is an extreme logistical burden is highly routine. You can give flexible treprostinil, you can give in a subcutaneous route. Is notorious for causing severe dose-limiting infusion site pain. Ileoprost, these are all prostacyclin agents, extremely high dosing burden requiring 6 to 9 inhalation daily. This is the inhaled route. And Selexipag, I think the previous speaker has dealt with this molecule a lot. So the oral non-prostacyclin hypoagonist. This is among the prostacyclin agents, only oral agent currently available in India. I don't know the epoprostenol, treprostinil, ileoprost are available in India, but Selexipag is available. This is the preferred choice when you want to use the oral prostacyclin drugs. And sotatercept, I think these molecules are also discussed with almost, he has shown several trials. I will also skip this slide. And one trial which he has told 7 trials. If you give 7 trials, you will forget all the trials. That is why I kept only one trial, that is Stellar trial. This Stellar trial has shown using sotatercept, there is 84% of the patient achieved unprecedented reduction in the risk of death and clinical worsening. It has shown beyond doubt there is an 84% reduction in the risk of death or clinical worsening, significant improvement in the 6 minutes walk test distance, and safety monitoring protocols. Also, they have done in this trial. There is a erythrocytosis risk can increase hemoglobin, and hematocrit requires baseline and periodic blood counts. They need blood counts. And thrombocytopenia is one more. So it's active monitoring of platelets is necessary. Sir, you are giving sotatercept, you have to follow all those things. Hemodynamics, monitor for systemic hypertension. Increased blood pressure can be there with this. And mucocutaneous events, monitor for epistaxis and telangiectasis. So this Stellar trial has shown that they have monitored. These are all the things when you are giving these things, you have to monitor those things, and it has proven doubt, beyond doubt. I already told it increases the apoptosis and reduces the smooth muscle population, and also it, to certain extent, you can reverse the remodeling also. So these are some of the new drugs in the horizon radar, ralinepag and serotinib and Rhoda. I think these are all tongue twisters, so I have to read 2 or 3 times to pronounce these things. I think these drugs also was dealt by the previous speaker. I think with this, I thank you for your nice patience. Sorry, I think it may be, some of the slides may be repetition, but expression is different. Slides are different, that's all.
So thank you, Shubhakar sir. It was really a roadmap for a modern therapy in type 1 PH. And Shubhakar Gandhi sir has been one of my favorite mentors in shaping my career also. And he has always supported me wherever he can. And when first I saw Shubhakar Gandhi sir, I saw him as a strict person, but over the years I recognized he's a very witty and humorous person also.
Only in the classrooms, outside the classrooms.
So coming to the topic, so of course we know science has now changed from one vasodilator to combination therapy to escalation of 2 prostacyclins, and now a vascular remodeling therapy as this sotatercept. But the Indian scenario is quite different. There are a lot of lacuna in Indian scenario, and we are not following the algorithm properly here, because even the RSC are not done in this part of the country. Anywhere, I don't know where it is done. So whatever we decide, and of course as pulmonologists we get fewer cases of type 1 PH in our department. Of course cardiology, the scenario has been different. So the thing is, the algorithm is not followed here. Then the lacuna regarding the following the one to escalation to a combined vasodilator therapy is also not followed because of the under awareness of even the doctors, and so much more sessions like this of training and retraining are required on this subject. So I congratulate Ved Boss for arranging this mega event on this topic. We have 22 sessions today on pH, and so a grand round of applause for Kandi sir and Ved Boss for that. Arey taali bajao yaar.
Always, if you keep a known person as chairperson, that is advantage.
So, any questions from the house and any comments from my...
So, remaining all pulmonary hypertension, the only choice is the oxygen. Oxygen is the most potent vasodilator in this country. Among all the drugs, oxygen is also a drug. The most potent vasodilator is oxygen. And remaining only, all these are for group 1. Other things, cardiologists manage with failure, they manage, valvular disease they manage, lungs, you address ILD and OSA, whatever it may, you address, and the chronic pulmonary thromboembolism. There, the surgery is main role, and this respiratory guard has also a role. Other than the group 1 pulmonary hypertension, where the drugs have some certain extent value, is respiratory guard in group 4 pulmonary hypertension.
So, I think no more questions and comment from the House.
Yeah.
I sincerely thank my good friend, Dr. Svar Kandi, who is very close to my heart always, for the nice lecture and great delivery of the talks. Thank you very much.
Thank you, sir.
Thank you, respected speaker and chairpersons. Kindly collect your mementos from the felicitation desk. Our next session addresses pulmonary hypertension due to left heart disease, with the lecture being delivered as a remote session. To chair this session, may I invite Dr. Anjana Singh, Assistant Professor, Department of Biochemistry, Eras Lucknow Medical College and Hospital; Dr. Mansi Gupta, Assistant Professor, Department of Pulmonary Medicine, SGPGIMS Lucknow; Dr. Gyanendra Shukla, Senior Chest Consultant, Divine Hospital, Lucknow. Welcome, Chairperson.
Dr. Aditi Sangvi, she's not there, I think.
Yes, can you see my screen?
Okay. She is the consultant cardiologist, Narayana Institute of Cardiac Science, Bangalore, and she have a fellowship in cardiovascular disease USA, fellowship in advanced heart failure and transplant cardiology USA. Previous position is the assistant professor of medicine and advanced heart failure and transplant cardiology at the Mount Sinai Hospital. Should I read on? Okay, let us start, ma'am. She's there.
Good afternoon, everyone. Thank you so much for inviting me to speak on this topic. I apologize I could not be there in person, but I'm really grateful to the committee for giving me this opportunity to participate in this wonderful symposium. So now we'll be shifting gears a little bit from Group 1 PAH and pulmonary vasodilator therapy for PAH to Group 2 PH. So as we have seen this morning already, Group 2 PH is because of left heart disease essentially. So let's talk a little bit more about the intersection of left heart disease and pulmonary hypertension. So this is really the most prevalent form of pulmonary hypertension that you will see in practice, and the therapeutic approach really varies because of this underlying pathophysiology, and personalized clinical decision making is needed in these patients because no two patients will be alike. There will be different contributing factors in each patient. So the prevalence of pulmonary hypertension in left heart disease is really quite significant, somewhere between 20 to 80% depending on what registry data you are looking at. And most commonly, the cause of left heart disease causing PH is LV dysfunction. So let's look at the substrate. There can be various types of left heart diseases, including heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, and this is an entity that we are seeing more and more now. And now over 50% of heart failure that we are seeing is due to preserved ejection fraction because of increasing age, increasing comorbidities like diabetes, hypertension, obesity. Then there can be congenital or acquired left heart inflow or outflow tract obstruction and congenital or acquired valvular heart disease like mitral stenosis, mitral regurgitation, aortic stenosis. Then there can be specific cardiomyopathies like hypertrophic cardiomyopathy and infiltrative heart disease. So coming to the definition and classification, this is something that we have seen a number of times this morning. So we know the definition of pulmonary hypertension now is a mean PA pressure of greater than 20 millimeters, and PH due to left heart disease will be classified if wedge pressure is greater than 15 millimeter mercury on right heart catheterization. It is very important to have actual hemodynamics in order to classify the pulmonary hypertension accurately. Now there can be two types of group 2 PH. Isolated post-capillary pulmonary hypertension is if you meet these above criteria and your pulmonary vascular resistance is less than 2 Woods unit. And combined post and pre-capillary pulmonary hypertension is when you meet these above criteria, so your wedge is also elevated and pulmonary vascular resistance is also elevated. And this is the essential pathophysiology for how pulmonary hypertension develops in left heart disease. So we know in left heart disease there is elevated left atrial pressure, and that leads to a passive increase in pulmonary venous pressure. And at this stage, pulmonary vascular resistance is normal. However, it increases the afterload for the right ventricle. So at this stage, the transpulmonary gradient will be elevated and wedge pressure will also be elevated. Over time, there is a reactive pulmonary vascular remodeling, and that leads to elevated pulmonary vascular resistance from chronically elevated left atrial pressure. So at this stage, in addition to elevated wedge pressure, we will also start seeing an elevation in your pulmonary vascular resistance. And why is this important? This is important because pulmonary vascular resistance is an independent risk factor in heart failure, both in reduced EF as well as preserved EF. So over here in the solid line, we are seeing patients who have no pulmonary hypertension, and these patients have the best prognosis. Then comes patients who have passive pulmonary hypertension, meaning their pulmonary vascular resistance is low. And the worst prognosis is of those heart failure patients who have PH along with an elevated PVR. So those who have combined pre and post capillary pulmonary hypertension, those patients have the highest mortality. We can see 50% survival at 5 years in these patients. So really high mortality in this subgroup of patients. Now coming to the diagnosis. We have seen the diagnostic tree for pulmonary hypertension. So the first thing that you have to do when your history, signs, symptoms, lab tests are suggestive of PH is an echo. On echo, if you have a high or intermediate probability of PH, then VQ scan should be done, and then the first thing that should be done is assess the patient for any left heart disease. Only if the patient does not have any left heart disease, then you go down the other diagnostic workup. So what should make you suspect whether a patient has PH due to left heart disease? There are several comorbid conditions which commonly accompany left heart disease, and risk factors for having left heart disease like obesity, hypertension, CAD, diabetes, valvular heart disease, arrhythmias like atrial fibrillation particularly, systolic function that is reduced, peripheral arterial disease, sedentary lifestyle, dyslipidemia, chronic alcohol use. So if your patient has these comorbid conditions or risk factors, you should have a high suspicion that this patient's PH is due to left heart disease. And these are the common comorbid conditions, and depending on how many you have them, you would classify the patient's risk of having PH due to left heart disease as mild, moderate, or severe. And particularly if you have an intermediate or high probability of having PH due to left heart disease, you should definitely investigate that further. So what are some clinical features? The typical patient will be an elderly female. History and clinical features you'll have that suggest cardiac disease, chest pain, some clinical features like dyspnea particularly will be common to both patients. Typically, oxygen requirement is uncommon in these group of patients. Chest X-ray can show elevated left atrial size, LV size, cardiomegaly, and pulmonary congestion like interstitial edema, curly V lines, alveolar edema, pleural effusions. PFTs will typically be normal. You can have normal or mildly reduced DLCO, particularly in HFpEF patients. VQ scan will be normal. Again, your chest CT will show more signs of left heart disease and pulmonary edema. These are some classical echo features. So typically in pre-capillary pulmonary hypertension, that is group 1 or group 3, 4, maybe even 5, typically in those patients with pre-capillary pulmonary hypertension, you will have right heart chambers that are dilated more than the left heart chambers. Left heart chambers will be small, and the RV will form the apex as shown over here. However, in post-capillary pulmonary hypertension, typically the left heart chambers will be dilated. If you have HFpEF, then the LA will be dilated. If you have HFrEF, then the LV will typically be dilated and the LV will form the apex. Then the eccentricity index, which is the ratio of the transverse and longitudinal radii, the diameters in your short axis view. Eccentricity index will be increased in pre-capillary PH, but it will be decreased in post-capillary PH. IVC can be dilated in both, and in HFpEF particularly, you will see significant diastolic dysfunction. So EA ratio can be either reversed or EA ratio can be greater than 2 depending on the degree of diastolic dysfunction. In grade 3 diastolic dysfunction, EA ratio will be greater than 2 and EE prime will be elevated greater than 12 on average. And typically in advanced patients, it will be significantly elevated. Though in pre-capillary PH, your EA ratio and EE prime will be normal. Then coming to right heart cath, this is a very important test in diagnosing these patients, confirming the diagnosis and guiding appropriate management as well. In post-capillary PH, in addition to elevated PA pressures, you will see elevated wedge pressure. If you're unable to get an accurate wedge pressure, then you should check an LV-EDP as well, and you will have pulmonary vascular resistance that may be normal if you have isolated post-capillary PH, or it will be elevated if you have combined pre- and post-capillary PH. Sometimes at rest, you may not see elevated left-sided filling pressures, particularly in HFpEF patients. And in those patients, saline loading, exercise test, or even a passive leg raise can be helpful. Saline loading is no longer recommended by the guidelines anymore because you have to rapidly infuse a large volume of saline within 5 minutes, and that may induce pulmonary edema in sensitive patients. So exercising is recommended. If you have a high suspicion of PH, of left heart disease PH, HFpEF, and your baseline pressures are normal, then you should always exercise these patients and get an answer. Do not leave the cath lab without an answer. Vasodilator testing can be helpful in this group of patients depending on what your clinical question is, what the clinical scenario is. So for example, if you are doing catheterization to see if it's an advanced heart failure patient and you're considering heart transplant, then it's very important to establish reversibility of the pulmonary vascular resistance. So for that, vasodilator testing would be helpful. And for this group of patients, vasodilator testing should be done with a systemic vasodilator like nitroprusside, not with nitric oxide and not with oxygen. If you give a pulmonary vasodilator like nitric oxide or sildenafil to these patients, then you can precipitate pulmonary edema. So that should not be given when you have an elevated wedge pressure. Now, certain numbers, calculations that you get from right heart catheterization also have prognostic value, like your RA to wedge ratio, PA compliance, that is your stroke volume divided by the PA pulse pressure. Now, I just want to highlight the diagnostic aspect of this with a few cases. So this is a 45-year-old female who has long-standing non-ischemic cardiomyopathy and had a CRT, and her echo-derived PA systolic pressure is 60. These are some echo images. So we can see that her LV is dilated. There is spontaneous echo contrast as well. She has significant MR and TR on the echo. So this is a patient with HFrEF. And the question always comes, why does she have severe PH? What type of PH it is? So we did a right heart catheterization for her, and her RA pressure is 10, PA pressure is 70/36, her wedge is also 36, cardiac index is reduced at 1.6, and her pulmonary vascular resistance is elevated at 4. So this patient has combined pre and post capillary pulmonary hypertension based on the things that we discussed. She also had several features to suggest advanced heart failure, and we decided to evaluate her for transplant. So because of the elevated PVR, it was important to establish if this is a fixed elevation in her PVR or if this is reversible, and that would make her a candidate for transplant. So we did a vasodilator challenge with sodium nitroprusside, and she responded beautifully with it, with a reduction in her PA pressure and a reduction in her wedge pressure to 20. Along with that, cardiac index increased to 2.3, her blood pressure was maintained, and her pulmonary vascular resistance reduced to 1.8. So this patient was a candidate for transplant and did undergo heart transplant 3 years ago. This is another case. A 72-year-old male who is overweight with diabetes, hypertension, atrial fibrillation, CKD, and echo-derived PA pressure was 55. And this patient was referred to me. He had already been started on sildenafil and ambrisentan. And we can see on his echo over here, there is concentric LVH, LA is dilated. So there's we can see his EE prime ratio is significantly elevated at 47. EA ratio is very high, it is 4.6. So he has all the features to suggest HFpEF and group 2 pulmonary hypertension. And indeed, on right heart catheterization, he did have group 2 pulmonary hypertension. So PA pressure was 50/28. Wedge pressure was 24 with big V waves of 35, which suggest either significant MR or poor LA compliance. And cardiac index was also reduced. Pulmonary vascular resistance was just at borderline elevated at 2.6. So this is a clear case of group 2 pulmonary hypertension. And as I'll go over in the next few slides, pulmonary vasodilators are not indicated in this subset of patients and may in fact be harmful. So HFpEF is an important subgroup of patients who will have pulmonary hypertension, and these are some scoring systems which can help you suspect whether someone has HFpEF or not. So there's pre-test probability based on signs and symptoms and clinical features like shortness of breath, comorbidities, poor exercise tolerance. Then there is the HFA-PEF score and the H2FPEF score. So if you have significant features from these scores, which basically include certain echo parameters like diastolic dysfunction, morphological aspects like LA enlargement, LV mass, wall thickness, elevated natriuretic peptides, clinical features, obesity, hypertension, AFib, age, and presence of diastolic dysfunction. If you have significant number of these features, you have a high probability of having HFpEF, and you should always evaluate that as the reason for your PH in these patients. This is a case where at rest, this is a pulmonary capillary wedge pressure tracing. We can see at rest that this wedge pressure looks completely normal. And so if you had just stopped over here, you would think that this patient does not have left heart disease, and you would walk away without an answer. But just with simple exercise, waving his arms, we can see that the wedge pressure dramatically increases to almost 35 with big B waves of 55 to 60. So that tells you that there is poor LA compliance and HFpEF physiology. This is another very interesting case that we had. 45-year-old male with ascites, lower extremity edema, anemia, acute kidney injury. We can see the LA size is slightly increased. LV size looks normal. LV function looks normal, but there is RARV dilatation, significant TR, and some degree of MR as well. So certain things didn't fit in the clinical picture for pre-capillary or post-capillary PH. We did a right heart catheterization, which revealed surprising findings. So RA pressure was elevated at 18. There was mild pulmonary hypertension with a mean PA pressure of 32. Wedge pressure was elevated at 22 with B waves of 33, but his cardiac index was 10 and PVR was very low, SVR was very low. So this gentleman had high output heart failure, and we, on further evaluation, we found that he had large hemangiomas in his liver and spleen. So next coming to, and for that patient, we ultimately did a partial splenic artery embolization, with which his hemodynamics significantly improved, and we had hemodynamic monitoring post-operatively as well. And once he had undergone partial embolization, cardiac output dramatically reduced, his symptoms normalized, and now he's doing well almost 2 years post-procedure. So next coming to the management of valvular heart disease leading to pulmonary hypertension, and it really depends on the type of valvular heart disease you have. Mitral stenosis is very common in this country, and we see that most of those patients, over 50% of mitral stenosis patients that we see, particularly rheumatic heart disease, because it tends to be long-standing, they have right heart, they do have pulmonary hypertension. We should avoid pulmonary vasodilators in that setting because it can worsen pulmonary edema. And even post-surgery, about 40% or so continue to have pulmonary hypertension. Some of these patients will have a significant precapillary component, and maybe those patients might benefit from pulmonary vasodilator therapy, but it has to be done under very controlled settings with objective data and close monitoring. And those patients do have poorer long-term outcomes if they have significant PH post-intervention. Again, about 50% of patients with severe AS do have pulmonary hypertension, and it does increase their perioperative risk as well. However, post-intervention, most patients, the PH will resolve within 3 months post-intervention. Even hypertrophic cardiomyopathy, some patients, about 10 to 20% of patients do have pulmonary hypertension, and this probably does increase the surgical risk if they are being considered for myectomy. Infiltrative heart disease, most of these patients will have pulmonary hypertension. We don't know the effect of systemic vasodilators in these subgroups. In HFpEF, pure HFpEF, some systemic vasodilators like ARNI have been shown to have a beneficial effect, but we don't know if that will have the same effect in infiltrative heart disease. Definitely pulmonary vasodilators should not be used in this group. Those patients can actually feel worse. We see a lot of patients with infiltrative heart disease, restrictive cardiomyopathy who've been started on sildenafil, tadalafil, ambrisentan, and they actually feel much better once you stop these medicines. Next, coming to HFrEF, there have been a lot of trials done on HFrEF and pulmonary vasodilators, but none of them have been shown to be helpful. There has actually been some signal of harm as well. Initially, these patients will have isolated post-capillary PH, but over time they can go on to develop combined post and pre-capillary PH. And this has some relevance if you're considering MR intervention also. There may be some benefit with Vericiguat. There was some initial enthusiasm that this may help with pulmonary vasodilation, but that has not panned out. There is no data on that. there may be some role of ARNI and SGLT2 inhibitors in reducing their pulmonary hypertension, and now maybe even GLP-1 agonists, though these have not been tried in patients with an EF of less than 40%. Next, coming to HFpEF. Management for PH and HFpEF really has to be holistic. SGLT2 inhibitors, maybe GLP-1 agonists, and ARNI, sacubitril valsartan, may have some benefit in certain subgroup of patients with HFpEF. ARNI, particularly in women with an EF less than 60% and hypertensive, may have a beneficial effect. And some patients I have seen do feel better once you put them on an ARNI. Then addressing AFib may help with HFpEF as well. Though data for AFib ablation is stronger with HFrEF than with HFpEF, then this is perhaps the most important part, addressing comorbid conditions like sleep apnea, obesity, diabetes. That is really the mainstay of treatment in patients with HFpEF. CardioMEMS is an implantable PA sensor which has been shown to improve outcomes, reduce hospitalizations in patients with HFpEF, but that is not available in India. There's a lot of work been going on with interatrial shunt device that seems to be exciting, but more to come on that. Now, pulmonary vasodilators, there is no benefit with the use in HFpEF and PH. There has been signals of possible harm seen with ambrisentan, macitentan, sildenafil, tadalafil, and riociguat in patients with HFpEF. The trials were either neutral or showed harm. And prognostication with a CPET is helpful in this group of patients. If they have a peak VO2 that is less than 60% of predicted for their age and sex, those patients have a high mortality. Now, coming to overlapping phenotypes, really in clinical practice, this is what we see most commonly. Pure PH left heart disease in the real world is infrequent. Most patients have an overlap. Most will have group 2 and 3 overlap from some degree of lung disease like sleep apnea, COPD. About 1/3 of CTEF patients also have an elevated LV-EDP, as we're seeing patients who are older now. Even patients with group 1 PAH, as we are seeing older and older patients with it, and patients with more comorbidities, they do have some overlap of left heart disease. And if you have group 1 PAH with left heart disease, the PAH medicines may have diminished efficacy and reduced tolerability. And in this group of patients, it is recommended by the guidelines to start with single pulmonary vasodilator therapy, assess the tolerability, assess for side effects, and then add on a second agent.
Dr. Aditi, we are actually running short of time. Could you just wind up your talk?
Yes, this is my last slide.
Okay.
So this is really these are really the clinical stages of pulmonary hypertension with left heart disease that we've discussed. At-risk patients, then patients once they develop structural heart disease, symptomatic disease. Disease that you're in. So with that, I'll end. Thank you so much.
Wonderful talk on group 2 pulmonary hypertension. So any questions from the audience? Because this is an audience of pulmonologists, any cardiologist or any pulmonologist for that matter. Do you have any questions?
Dr. Aditi, good afternoon. Dr. Dhruv Chaudhary here. I just wanted to know one thing. You have talked about different algorithms which are there. What do you think is the role of the biomarkers in terms of screening and picking them up early, besides obviously the criteria which we are putting in?
Yes, so that's a great question. BNP does have a role, but we know that BNP may not be as elevated in patients with HFpEF compared to patients with HFrEF. And particularly in patients who are obese as well, the BNP may not be significantly elevated. So if it is elevated, it is helpful, but if it is normal and you otherwise have a clinical suspicion, a normal BNP should not rule out HFpEF.
Because what we are looking at with the preserved ejection fraction, with the diabetes, hypertension incidence definitely is going up. So one question again to you in that context is, if we do an exercise testing as you were showing it up, that your pulmonary capillary wedge is going up, your pressure is going more than 2 Woods units, etc. So if we have anybody looked at it, that on exercise, what happens to the biomarkers so that you can pick them early, otherwise you definitely need a specialized centers, because screening, that is something we are missing.
So biomarker elevation typically happens chronically. I'm not sure while doing an exercise test within a few seconds to minutes if you would really, get biomarker elevation. Elevation of biomarkers like BNP or even markers of fibrosis, ST2, that require a chronic period of changes in neurohormonal mechanisms, sympathetic activation, the fibrosis, inflammation. Those typically reflect chronic changes.
Now the reason for asking is, I come from the critical care background, and looking at an incipient cardiac dysfunction, we bank a lot today besides echocardiography on biomarkers in the ICU settings. If we put these patients on weaning, and if there is a cardiac cause, usually when we follow it up, there is usually 2 to 3-fold increase in the BNPs and anti-proBNPs. So I'm just putting that hypothetical question to you as a part of a research, also to see whether, like we do TMTs, if we do it in these cases, short of stenosis or HOCM, can it be beneficial to pick up early? Because everybody can't, we have very few PH centers in the country as of today.
Sorry, I thought you were asking about biomarkers during exercise.
Yeah, biomarkers, again, exercise, I am saying that when you do a cardiac stress testing, or you look out, you do a stress echocardiography, do you think that if we consider, or anybody has considered, my knowledge is a little limited, so looking at your vast experience, wanted to know about it, that if you start using biomarkers at every 3 minutes or so, like we used to do in TMTs, etc. So can it make a difference, or it's just a hypothetical thing, or it will take much longer? I'm trying to extrapolate it, what we see it during the weaning.
Yes, I think that's it's a great thought. If you talk about the commercially available biomarkers like troponin and BNP, troponin would be elevated more in the setting of myocardial ischemia. Now that can be supply-demand mismatch, and that does start increasing within 4 to 6 hours of myocardial ischemia. But that does not necessarily reflect the HFpEF physiology that we are interested in this, what we are talking about. So checking troponin during exercise will not necessarily tell you about HFpEF if that is what you are looking at. Again, BNP elevation requires chronic changes in the pathophysiology. So I'm not sure within a few minutes whether you will see changes.
To answer sir's question, so we are from the same team. So this comes to pulmonologist, because HFpEF nobody wants to touch from cardiology. So as you said, biomarkers are not helping, but we have designed something called exercise-induced echocardiogram. So they are on that bicycle. You do the images, ask them to do exercise, and you will see that their E by E prime ratio is changing, and diastolic dysfunction will immediately manifest in 3 to 4 minutes of exercise. This is outpatient. Critical care, still debatable, but in OPD, it is a very valid tool to use it, and we are using it quite frequently.
Thank you very much. I do agree what you're saying.
Yes, sir.
I am a little different in terms of pulmonology. I come from internal medicine. My MD thesis was on stress testing. So we did a lot of it, looking at part of it. That's what I'm saying. As a part of critical care, what we see is
correct, sir.
We want to differentiate what is the reason for weaning difficulties, whether it's primarily cardiac, whether it's a primarily lung, or it's a cardiopulmonary. So if there is no overload, there is nothing else, because they have their own limitations.
Correct, sir.
So I'm just put that question, like when in the short setting we check the BNP before, and once we have given these patients who are recurrent failing in the weaning, and we check the BNPs after the kidney is fine, no rushes there, then we see that the BNPs, they tend to shoot up. So in acute care, we are doing it up. So I'm trying to extrapolate. I'm not saying it is right or wrong, but I thought I will just...
So one is the image. You can do echo also in your ICU, or the other thing, you are much more learned than me. people have used mixed venous. So when they are weaning and they are checking the mixed venous, and that is a biomarker which we can use. If you see that your mixed venous is coming down, that means your afterload is increasing.
That's
Mixed venous is a biomarker.
Specifically because
Yes, sir.
large number of pulmonologists are not very comfortable with
Correct, sir.
echocardiography.
Yes.
So they are trying to
Then
use it
mixed
as a
venous.
surrogate.
Yes.
As a final answer will come there, what you are saying.
Yes.
Fully agree with you. To pick them early so that we
Correct,
don't
sir.
miss them.
Yes, sir. So mixed venous, what do you think versus BNP?
You see, we are using a lot of anti-pro-BNP in terms of where there is a weaning failure.
Yes, sir.
There we are using it up provided there is no earlier cardiac failure, etc. or not there. But I do agree that in the clinical side, when patient comes to us with the breathlessness, it becomes a challenge for us in terms of looking at HPAF. We have to ask the cardiologist to see, do it, different maneuvers as you have shown it up. But still, we do miss a large number of this, especially chronic evaluation of breathlessness. I think that is something, there I am seeing it, looking for it. If it has not been done, I may request you may look at it. That's what I was discussing with Dr. Murli Mohan also. So probably, whether I'm right or wrong, I don't know. Because I was finding you people are setting it up, and we have been doing it up in the intensive care settings. So if there it can make a difference. So I do expect and hope that if it may be reasonably probability is there, it may be right, it may be wrong, I don't know. That's why I put that question.
Absolutely, sir. Even on the intensive care side, as you have rightly mentioned, BNP is elevated in a lot of patients in the ICU, and there it is actually multifactorial. And even in the patients who are failing weaning trial, it probably did not increase within 5 minutes or 10 minutes of being on CPAP. It has probably been elevated for a while. If we check the BNP on admission, check it in the ICU, that will give us some sort of trend. Again, because BNP elevation requires time. And there are other factors also that can make a difference that can elevate BNP, particularly in the ICU side, like sepsis, presence of infection, renal dysfunction, atrial fibrillation, viral infections like influenza particularly. All of these will increase your BNP.
Thank you all for this session. I think we move on to the next one now. Thank you.
Thank you so much.
Thank you, respected speaker and chairpersons. Kindly collect your mementos from the felicitation counter. We now move on to pulmonary hypertension associated with interstitial lung disease. To chair this session, may I invite Dr. Abhishek Gupta, Senior Consultant Pulmonologist, Sanjeevani Hospital, Lucknow, Dr. Saurabh Ojha, Senior Consultant Pulmonologist, Globe Hospital, Lucknow, and Dr. Amit Anand, Assistant Professor, Department of Medicine, King George's Medical University. Welcome.
पहले जो है पहले दूरदर्शन के बहुत ही मशहूर न्यूज़ मीडिया और हम ही लोगों के यहाँ.
On the behalf of PS Summit team, I would like to call the next speaker, Dr. Mansi Gupta ma'am. She is additional professor at Sanjay Gandhi Postgraduate Institute of Medical Sciences, and she is well-renowned speaker and has done multiple publications. And over to you, ma'am.
So very good afternoon to all of you. I'm taking this talk on behalf of Professor Alok Nath, who could not be here due to a personal emergency at home. So the topic is very much, everybody is interested that, we already knew about this entity, which is pulmonary hypertension in interstitial lung diseases. But what was not available to us was any treatment which could offer beyond oxygen therapy in such patients, which still remains a very important component of management. And So let's see, we'll start with a case scenario to keep it interesting. A 64-year-old lady who had an established idiopathic NSIP and she was already on immunosuppression. She had a rapidly progressive MMRC dyspnea, which is grade 3 now, and profound fatigue over last 5 months despite a stable fibrotic disease at baseline treatment. And the vitals showed a marked desaturation on 6-minute walk test, which started from 92% to 81%. And the walk distance was also 245 meters. This is something to be noticed that I'm saying a patient is rapidly deteriorating despite a radiological stability on immunosuppression, and the patient's 6-minute walk test is quite dismal. Now, on examination, which is mostly missed, the cardiological part, she had a loud P2, and she also had pitting edema, prominent jugular venous pulsations, and elevated A. Now, anybody from a pulmonary part could think that since the patient is deteriorating for 5 months, could she be having a gradual progression of disease or maybe a indolent exacerbation which has not been properly treated? Fair enough. The pulmonary function test, since the patient was stable enough, it was performed, and we found that the FVC was 68%, not very bad for an ILD, and FEV1 to FVC 82%, which is moderate restrictive defect, but DLCO was severely compromised at 28%. So for the residents to understand, there's something called an FVC to DLCO ratio. Whenever we are talking of restrictive lung diseases, two of the important parameters that you have to look for progression is FVC, which tells you about the restriction, and also about the DLCO, which is the gas impairment parameter. So patients who have an ILD would have involvement or deterioration of both the parameters. But DLCO is not just dependent on the interstitium. It is a marker of gas transfer, which would also which will also incorporate pulmonary vascular integrity into account. So anybody who's having an out of proportion fall of DLCO would actually be having some component of pulmonary vasculature involvement. So this was suggestive, and the ratio, if it is more than 1.5 FVC to DLCO ratio, then it points towards an additional pulmonary vascular problem. As you can see the CT of the patient, all of you are very good at diagnosing ILD, but never forget to look at the mediastinum, and also the contrast window tells us that the main pulmonary artery diameter is 33 mm, and the ratio between pulmonary artery and ascending aorta is 1.18. The normal ratio is somewhere around 1, so it has increased, and the pulmonary artery diameter, anything more than 29, is significant in terms of enlargement. Now the echo was done, and also the right heart parameters that showed that the TRV, TR velocity jet, was also suggestive of RV dysfunction. There was dilated RV, TAPSE was reduced 15 mm. The serum NT-proBNP as a marker of myocardial dysfunction, so that was also elevated. It was 540 picograms per milliliters, and the trop I was within normal limits. Functional capacity we've already discussed. So this is the question to the audience. Now that we know that patient has pulmonary hypertension, what would you like to do in this kind of a patient? Any resident would like to answer? You want to, so since morning we have been hearing how to evaluate a pulmonary hypertension, but ILD could be a different scenario. So would you like to start him on treatment thinking that it is a diagnosed case, why to do any further thing? Or maybe right heart catheterization, which is a gold standard, would you like to do that? So just go with the options here. Doing a right heart catheterization. So a patient of ILD is a very twitchy patient. He's already hypoxemic, and many of the patients come with elevated pulmonary artery pressures during their ILD exacerbation. So doing an RHC in this kind of a setting when the patient is coming in right heart failure could be actually a risky proposition. Another option is treat your acute ILD component, treat the heart failure component that patient has come up with, initiate antifibrotics, and reevaluate the patient when stable, and then consider giving any therapy for pulmonary hypertension. That sounds more reasonable. It might look a conservative approach, but for patient safety, I think that would be a good option. The third is empirically start on some therapy like sildenafil or ERA therapy, endothelin receptor antagonist. This is not because so we don't know what drugs have good outcomes in ILD, what not. Abhi will come to that discussion part later, but right now option B looks like the better option. So when we talk of PH epidemiology, we know that the diagnosis of PAH has been revised in 2022 ERS guidelines. Now they have reduced the cutoff for diagnosis of pulmonary hypertension, and with that, the prevalence of pulmonary hypertension in ILD is also increased. So IPF remains the dominant group. Apart from that, one other group which has very common pulmonary hypertension with poor pulmonary artery pressures, they're elevated, is CPFE, which is combined pulmonary fibrosis and emphysema. And the third group of ILD, which we are concerned mostly, is scleroderma ILD, which commonly presents with a group 1 component of pulmonary hypertension. So these three are main important ILDs which you should be concerned with. And it has been seen that the mortality increases almost 3 times if a patient is having pulmonary hypertension in ILD. And most of the patients you would actually think of sending for lung transplant due to an end-stage ILD, almost 70-80% of those patients are already having pulmonary hypertension as a comorbidity. So these are the diagnostic criteria. I'm sure previous speakers have told. The updated criteria has dropped the mean pulmonary artery diagnostic criteria to 20 mmHg, and severe pulmonary hypertension is more than 5 Wood units, and pulmonary vascular resistance more than 2 Wood units. This has been revised. So in terms of etiology and phenotypic diversity, what 3 types I'm telling about is fibrotic IIPs. The main problem with them is traction bronchiectasis, a lot of reticulations and honeycombing. And then there is a rapid loss of the vascular bed because of the fibrotic disease, which strongly correlates with your pulmonary artery pressures. And the primary therapy for these patients would be antifibrotics, oxygen therapy, and inhaled treprostinil. That is the main drug that we are going to talk about in subsequent slides. The second disease, as I said, was scleroderma, which is the most common entity for CTD-ILD, which is associated with pulmonary hypertension. But apart from that, RA-ILD and MCTD, they're also very important. They have a component of vasculopathy in itself. So they will have a component of group 3 hypertension along with a group 1 intrinsic proliferative arteriopathy. So herein, you will have to treat the patient with good immunosuppression, antifibrotics, and here, apart from just using inhaled treprostinil, maybe other pulmonary hypertension vasodilators could also be helpful. CPF is a very dismal zone. There you have a patient who has preserved lung functions, but the DLCO is almost very severely impaired. And most of the patients succumb to their illness very early. The mortality is more than 50% in 2 years of diagnosis. And they have out of proportion pulmonary hypertension. So they are mostly given inhaled bronchodilators, and inhaled treprostinil could be an option here. So this we have already said that there is a progressive fibrosis and vascular pruning, and it is the leading cause of death in most of the patients in ILD. The vasculopathy pathophysiology has been discussed. I'm not going to talk in detail about it. So there is one big component of capillary bed destruction in ILD because of the fibrosis which is happening and the collagen deposition. So those pathways are active. Second is hypoxic vasoconstriction, which is due to the oxygen problem and the pulmonary vasculature responds to hypoxia. Second thing is vascular remodeling, where the primary disease or the cytokine release would lead to vascular remodeling pathway. So these are the 3 main pathways the drugs were targeted at. Now, sir has already told about there are 4 pathways, but these are the 3 main important ones where therapies are primarily targeted. So endothelin pathway, nitric oxide pathway, and prostacyclin pathway. So particularly for ILD, PH, ILD, prostacyclin pathway is the one that we'll be targeting with inhaled treprostinil. Another thing is that we were discussing activin and BMP pathway. These are the molecular drivers of the disease. So again, like any fibrotic disease, even vasculature gets affected by these pro-fibrotic, pro-inflammatory molecular drivers. And there's a lot of research now going on. All these markers that I've written here, it's nothing new. All these markers are already there in the pathophysiological cascade of ILD development. And they also bias the pathway towards a development of PH. When I say pulmonary fibrosis and emphysema, it's a dual insult. So patient is already having an emphysematous loss of the vasculature bed, and also fibrosis, which is happening in the basis, exaggerates that vascular loss, which leads to severe hypoxemia, and the vascular vasoconstriction is much more profound as compared to the other ILDs. And unfortunately, those people who are not evaluating their patients with DLCO spirometry could be normal in many of these patients. And unfortunately, these patients will, if you do the CT scans, they do not respond very well to the therapies which are directed at pulmonary hypertension because the pathophysiology is little different in CPFE. They will have PVOD-like lesions which respond poorly to systemic vasodilators. They have in situ microthrombosis, and they also have neovascularization chaos. So this is the group which doesn't respond very well to treatment for pulmonary hypertension. Clinical presentation and red flags in pulmonary hypertension, they are mostly similar, but because of ILD, it may bias your findings in terms of auscultation, it may bias your findings in other ways, but by and large, whatever workup, whatever examination is needed for any patient of pulmonary hypertension, that remains valid for PH and ILD. So I've already told about the pulmonary function testing clues. One thing is out of proportion DLCO loss, FVC to DLCO ratio, serial DLCO decline without any change in FVC, more than 15%. And also, if your pre-treatment DLCO is already at 40%, you can expect an underlying pulmonary hypertension at the outset. So these are the three things that you should keep in mind. Second is 6-minute walk test. Marked desaturation of more than 15% on a 6-minute walk test, or your baseline 6-minute walk distance in less than 250 meters. Again, you should be very careful in evaluation of pulmonary hypertension. CPET at good centers, if you have, then of course this will contribute to diagnosis. But by and large, other radiological echocardiography and these functional parameters are more than sufficient to make a diagnosis of PH and ILD. Biomarkers has been discussed at length in the previous talk. So same biomarkers. Natriuretic peptides are very commonly used, which is NT-proBNP and BNP. Others could be HFA-BP and KL6, which is a prognostic marker in ILD itself, and GDF15. Nowadays, there is a lot of AI coming in picture, which particularly for radiologists, it's a boon because if the scans are properly taken, then something called AI-driven detection of peripheral vascular pruning. That is something of a research tool right now because the models are still being trained. But if it comes to usage, commercial usage, in few years it will be, then it is a very strong predictor of PVR elevation, and it will take away a lot of subjective work from echocardiography in terms of imaging. This I've already discussed about the echocardiographic tools, similar to what we see in other types of pulmonary hypertension. Now, people have already developed a lot of clinical prediction models also. There's a Ford model which has variables from functional parameters, and the oxygen desaturation, the performance is moderate. It is, the sensitivity specificity is around 70%. Similar to that, this pH and ILD detection tool, all these models are internally validated, but large-scale studies are always needed for these external validations. VQ scan and CTEF rule out is a rule in all the cases of pulmonary hypertension. Group 4 has to be ruled out in all cases because particularly in ILD, there is a pro-coagulable state, ILD predisposed to a pro-coagulable state. So another component of pulmonary hypertension in ILD would come from a group 4 component that should not be missed. So these are the cases who will not respond very well to the pH vasodilator therapy later on, and sometimes they would actually need a surgical intervention in terms of a PEA. So coming back to the case, the patient was treated with steroids and antibiotics for an ILD exacerbation, also treated with diuretics, and repeat CT showed some resolution of GGOs, which was the acute component, but there was an increase of fibrosis from the baseline after the patient settled out. So she was 65 years old already, the fibrotic component was very high, the radiological pattern was rediscussed, and now she was initiated on a progressive pulmonary fibrosis regimen with antifibrotics, and her 6-minute walk distance increased over almost a year. Now, the repeat echocardiography still showed a significant RV dysfunction. This patient now is the question that do you want to document a pulmonary hypertension in a proper confirmed way, where the RHC would take over. So yes, in a patient who has been clinically stabilized, RHC must be performed when he is stable and euvolemic, and you cannot do RHC in patients who have ILD exacerbations or pulmonary infections because that component will also it will mislead you with the results of the pulmonary artery pressures. And RHC is indicated when patient is planned for a targeted therapy like inhaled treprostinil, evaluation and listing for transplant, enrollment for any clinical trials, and unexplained rapid clinical collapse or a right ventricular failure. So these are the current indications for RHC in PH and ILD, provided your patient is stable enough to do an RHC. Technical pitfalls, this is something which is beyond the scope of this talk, so you can all read up about the technical pitfalls of doing an RHC in a patient who is an ILD. The second thing is we should not miss a component of post-capillary pulmonary hypertension. The last talk was also discussing the same thing, that many of the patients would have occult heart failure with preserved ejection fraction. This is something which is already known, that the compliance of the heart chambers is not going to be good, particularly the risk factors being the fibrosis around in the lungs. Also the patients have age, and the drugs also sometimes are doing that. So these patients, you already have to rule out post-capillary wedge pressure of more than 18 to be sure that you have a pre-capillary pulmonary hypertension and not a component of heart failure. And vasodilator testing with nitric oxide and adenosine, they are not recommended for the pulmonary hypertension group 3 because there is a high risk of VQ mismatch in such patients who are already hypoxemic, and they can land up with acute right heart failure also. So this is something which is very important. So group 3 is very tricky in terms of making a treatment-related decision. Another component which has been described just for the residents to understand, there are certain, so when the registries were being made for PH and ILD, it was found that in Compara and Aspire registries, a component of patients or a proportion of patients came out with mild ILD. They had reticular shadows, they had mild interstitial lung abnormalities, or you call them ILAs nowadays. So they had ILAs, and now they also had either mild emphysema. So some parenchymal involvement was there, but they also had pulmonary vascular pressures which were increased. So they will also come with a component of, they will also come as a phenotype of mild ILD with severe PAH, but the thing was that they have their therapeutic response to drugs or the survival, all these things will actually be like ILDs, and this is some group which has to be explored over time. So because their pathophysiology may be a little different from classical group 3 PH-ILD. So for our patient, the right heart was done when she stabilized, and it showed the classical, she had this pulmonary artery pressures which were raised. MPAP was 38, PCWP was 10, and she had a Wood units of 6.4, making it severe pulmonary hypertension. So we have already discussed there is isolated pre-capillary pulmonary hypertension in ILD, severe pre-capillary pulmonary hypertension in ILD, which is our patient, and combined pre- and post-capillary, where your pulmonary capillary pre-existing ILD is combined with some heart failure with normal ejection fraction or a CAD, so you have a heart failure component, and you have isolated post-capillary, which is not to be treated with vasodilators. It needs only diuretics and cardiac care in terms of comorbidity management. So baseline ILD optimization is must in a patient who's extremely fibrotic, honeycombing, and those patients of PPF variety. Of course, nintedanib and pirfenidone will be the drug of choice to manage the ILD. And for CTD ILD and other types of inflammatory ILDs, you can always go for a good aggressive immunosuppression, because active disease in ILD also contributes to hypoxemia and recurrent exacerbations, and that could be a contributory factor to worsening of pulmonary hypertension. So ILD optimization is a must. Second component is optimize the oxygen therapy. The supplemental LTOT should not be denied to patients who are actually developing pulmonary hypertension. So target saturation should be 88 to 92% to avoid any hypoxic vasoconstriction. It will provide the hemodynamic benefit. And many of the patients, sometimes they would need HFNCs in their rehabilitation clinics and other where they're exercising. So that time also hypoxemia should be avoided with utmost care. Second is do not forget about sleep disordered breathing. In all the patients, again, the studies on sleep disordered breathing are limited in ILD because the patient's not being stable for undergoing a sleep study, but the prevalence could be up to 50% of patients could be having a nocturnal hypoventilation. This we have seen a lot of time in our ICU. We have made the residents notice all of that. So if the patients are having any component of hypoventilation during sleep, that should be dealt with CPAP or NIV as the diagnosis is. Then rehabilitation and nutritional component, diuretic optimization, left heart care, and also vaccinations. And the patient should be listed for a lung transplant if the patient has severe pulmonary hypertension. Now coming to the drug, the landmark trial, the last component of this talk would be that inhaled treprostinil. Is it available in India? Commercially, it's not available. So for any patient who needs to be given this drug, has to connect to a center who is arranging these drugs on compassionate grounds through a patient import system. So you can do that, but again, the cost becomes a deterring factor. But it can be procured in India. It's not impossible if the patient really needs it and the patient is willing to spend some money. So INCREASE trial, which came in 2021, was the first randomized controlled trial in phase 3, which showed benefit, and then it became FDA approved also for the treatment of group 3 pulmonary hypertension, and it showed that it increased the primary endpoint, the 6-minute walk distance was improved, the reduction of clinical worsening events also was noticed, and NT-proBNP was also stabilized in many patients. So this trial was the landmark trial, and it also showed that the exacerbation was lower in patients who were using Tyvaso. Tyvaso is a drug which is, right now it's patented, so you can actually, it comes with a DPI device in itself, and it's a breath actuated DPI, so it delivers the right amount of drug with single breath. As an extrapolation, the CPFE subgroup was also analyzed, and COPD group was also analyzed, but the COPD group did not do very well with this drug, so the trial was terminated. And CPFE, again, the data was encouraging, so it is still under evaluation. Then the landmark TETON trial 1 and 2. TETON was done in North America with 500, 600 patients, and another TETON 2 was a global trial of almost 600 patients. So now they had a data of almost 1,200 patients with them, which were mainly IPF patients, or you can call it a progressive pulmonary fibrosis variant, who were on antifibrotics most of the times. And they said that almost the mean decline was, FVC decline was lower in patients who were using inhaled treprostinil by almost 115 liters. And again, the other benefits were reduction in acute exacerbation rate, antifibrotics were compatible with this drug, and a patient's quality of life also improved. So finally, this patient, with the help of a center, we could give her this drug, and this patient improved using this therapy, already continuing with nintedanib, and also she's listed for an early lung transplantation. So these are the improvement in her parameters. 6-minute walk distance increased after by 65 meters at almost 6 months, and the BNP has reduced, oxygen has improved, and all these things are coming better. So other drugs, they are off-label vasodilators. In the interest of time, I'm not continuing with the other drugs. So they are basically contraindicated in ILD with PH. And the final word would be to use your drugs wisely and evaluate your patient with a detailed and systematic approach. So thank you for your attention.
Thank you, ma'am. It was a wonderful talk, knowing you took the talk in the last minute from the Alok sir, but it was from basic to recent updates. And it was crisp talk, and even I would agree with the PGs would have got recent updates regarding whether to treat PH in ILD or not. Ma'am, one question that especially in scleroderma and sarcoid ILD, where the pH plays an important prognostic marker, if a patient comes to you of sarcoid or scleroderma with severe pH, would you like to give right front the pH therapy, or would like to assess or start with the ILD treatment first and then wait and watch, and how frequently you would like to follow?
So for scleroderma, in sarcoidosis, it's multifactorial pathway. So to say that whether we will give it can be a random scenario. It has to be a very customized evaluation in a sarcoidosis patient because it falls in group 5. But for CTD, scleroderma ILD, the use of vasodilators, if you look at the pathophysiology, almost 50% to 70% of SSC ILD would have pulmonary hypertension, and the group 1 component is a lot dominant. So these patients are put on vasodilators, and there's a data to support the use of tadalafil as an antifibrotic component also. So these patients definitely do well when they are given vasodilators at the outset. Many of the patients who agree to undergoing a right heart catheterization, all those things are obviously, so those patients stable enough should be undergoing a RHC before starting treatment. Yes. Yeah, so in that case, it has to be started, yeah. But the evaluation will remain same. So what I'll tell you as an example, scleroderma ILD, a patient has been referred from an immunologist for out of proportionate dyspnea. When you do their CT scans, it's just mild NSIP with some GGOs. ILD definitely is not the reason. When you do their lung functions or the 6-minute, if they're not able to perform, the 6-minute test or the lung functions are very bad in terms of DLCO impairment. So you know that the group 1 pulmonary hypertension component is there because ILD is not even visible on the CT. So these are the patients you can actually go for the treatment. Yeah.
Scleroderma, ma'am, IPH, where the primary component is the pulmonary hypertension, if it turns out to be severe, so should we start only with the tadalafil, or directly we can go right front in the
that
2
you
or
can
3?
go with the guideline management. You can go with the dual vasodilators. You can go for a combination, whatever they are available. Ambrisentan and tadalafil could be a good choice that way.
It was excellent lecture, ma'am. Just out of the box, one question. Most of the time in ICU, in critical care, in cardiac critical care or in critical care ICU, while reading a patient of PH with RV dysfunction, we are using inhaled Miliron and injectable Miliron at the same time. Whether it is applicable in ILD patients also with PH, what is your experience on that?
In terms of managing the right heart failure?
Yes, right heart failure with PH, weaning from ventilator.
So management of right heart failure due to any cause of underlying PH will remain the same in ICU. The same drugs would work. But the problem is that group 1 pulmonary hypertension, there's a structural vasculopathy. So you can only, the prognosis will be a little different in terms of patient's outcomes if the component comes primarily from group 1 hypertension. And that is not the time where you can actually introduce any vasodilators also. So that patients would have a grimmer outcome as compared to the other groups of pulmonary hypertension landing with RV failure. Is that what you wanted to know? Sure.
Any question from the audience? Darshan, sir.
It's not a question actually, but just of course you test almost everything regarding your treatment and the management. The only thing which we are lacking right now is the lung transplant centers in this part of the country. And so Lucknow is probably going to very soon, we have a lung transplant center. Wait, boss, your attention please. So very soon probably we will be starting a lung transplant center in Lucknow itself, and we require collaboration from each and everyone in Lucknow, from all the medical colleges of SGP, KGMC, RML. So maybe for these kind of diseases, of course, CPFE and the PH, which is complicated by ILDs, we require more of transplants, and we have to collaborate with the thoracic surgeons now. Beyond this treatment of like all these drugs, we require transplant centers. Thank you.
Okay, thank you.
Yeah, definitely we have to collaborate not only in Lucknow, but also in all parts of the country. All the centers doing this wonderful job in the country, and also from other countries like center in Houston, San Antonio, and at Cleveland Clinic is also in contact. So we are in collaborations for this next upcoming program. And Julius Punnen sir is also here, wonderful cardiac and lung transplant surgeon from Narayana Health. So, sir, we are in process to develop the heart and lung transplantation center at this place, and probably this will be the first of its kind in the public sector, having a quite a good center we have planned. So if the things goes fine in future, then probably we will develop this center very soon. So thank you all for this.
I think definitely you are moving in right direction, but one of the thing, if you are seriously considering transplant, you should have a good donation, because currently what we are seeing in the state of Karnataka and Tamil Nadu, the utilization rate of lung is approximately 10%. So if you want to do 5 transplant in a year, you should be having at least 50 donors, 50 donations, so that you can pick and choose and you have a good outcome. This is the time where we should be investing donor, so that by the time your transplant facility comes, you have a good donor management. So this is the time we should start paying attention for donors.
Yeah, definitely, sir. This is the area of concern, and at KGMU from very beginning, the program took off nicely, and we have donated around 35 cadaveric retrievals in itself at our trauma center in KGMU, and so then the program slowed down, and now we are trying to pick it up, and we are having the pledge and the request from the PMO, Honorable Narendra Modi ji, regarding the pledge, and pulmonary and critical care having 256 members is the first, having all the members have pledged for organ donation, including me and all the members of this department. So we are trying hard, and probably with the support of NOTO and SOTO and all from all corners, we will probably we will see in a better way, I think so.
So going back to your query, बॉस के कहने पे तो जिंदा आदमी वाला लंग मरे कैडेवी किधर छोड़ी.
In circulatory failure also we want to develop the facility.
As Dr. Julius says that we are pledging, but after 60 we are reaching there, nobody is going to utilize our organ. So we want youngsters to participate. Even if you become a donor, nobody will utilize these organs once we cross 60.
I think our department is the youngest one in the country. So for this purpose, I will be happy if we of any use for anyone, I think. Sir, your comments.
You see, that's the major challenge. At Rohtak also we face the similar thing. It needs an institutional commitment, not an individual commitment. And once you have an institutional commitment and the people there, and it has to be a multidisciplinary approaches, because what we are finding is the people who are interested, administration puts them back. Those who are not interested, they are put there somewhere else. So I think that is something very peculiar which is there. So organ retrieval is one part, and for there, I think you need to, not only with your trauma center, with neurosurgery or other places where you are getting them. Now the new guidelines for the declaration of brain death has also been released by the ministry. For that you need to have a big pool which is there. But what I am finding the biggest challenge in the public sector is commitment and coordination. Paper, yes, practically everybody passed the buck.
Yes, definitely, sir. This is the real challenge we are facing nowadays. And Punnen sir is also here. I would like to hear him regarding the development of reperfusion after cardiac arrest. So what is the take on in this?
As in donors or in general? As of now, we haven't got the rules in the country for DCD laid out. There is no rule which says you can't do it, but we've not had any guidelines from NATO or anything for DCD process. So that is one part. The other thing is when you do DCD hearts particularly, it becomes very expensive because of the machines that you need to use, the disposables involved, the perfusion solutions involved. At a point where we are not even utilizing all the organs offered to us, I don't see why we should spend so much extra money to increase the number of donations. So we know that in the country we have 140,000 road traffic accident deaths. Maybe if we can have 10% of them donating, we'll have excess donations than what we can do transplants. It is not that we don't have people dying. We just don't utilize it properly, and we don't have a policy which helps that. Tamil Nadu was the first state which came up with some government orders which required all brain death to be, it had to be informed to the government, it's notified, and all of them should be requested for organ donation. And there were 6 different GOs which made donation process very easy in Tamil Nadu. And there were some officers who were very interested in getting it done. We tried to use the same GOs in Karnataka, but it didn't. Yeah, but the government, the legal department of the government said we cannot do that. For it is legal in Tamil Nadu, but not legal in Karnataka. So we have a lot of these hurdles, which if you look back at the time when we started doing transplants, it was much more difficult. We have come a long way from that point of time. So when you start a program now, there is a lot of learning which is already available from the policy level, from the people's level, from the management level. So it would be a lot easier now to start a program than it used to be 20 years ago.
Yeah, definitely, sir. The things are, I think, getting better.
In continuation of what Dr. Julian said, it was Jayalalitha who showed the political commitment at the level. And secondly, that is where the role of these babas and religious people come into place. We need to harness them for this particular purpose, because if you see in Gujarat, the number has gone up because these are the issues which are extremely challenging. And you need both political commitment and social realization. I do remember in 80s, Dr. Gupta is there also, and all of you, when we asked for the blood donation, people used to run away. Now that become a routine now. Eye donation, people still have not picked it up. Kidney, everybody is available and agreeable. So you need 2 values. One, political commitment at the level of the state, where the people themselves come and do it. That's what Jayalalitha did, and that's how program took over in this. And so secondly is obviously, this is where the role of culture and religion becomes extremely important, which we underplay in India. You go to the Western world, they put a lot of emphasis on it.
Yes, definitely, sir. So there is a need for more political commitment regarding this, and at the policy level for future of organ donations in the country. And I used to say at many platforms at the government level or at PMO level, we have given some inputs. और मैंने तो ये भी कहा कि सर जो ऑर्गन डोनेशंस हैं, ये हमारा जो अभी मेडिकल टूरिज्म चल रहा है कंट्री में, ये अभी गरीब देशों के लिए चल रहा है. अमीर देशों के लिए हमारा मेडिकल टूरिज्म वर्केबल नहीं है अभी का मॉडल. और this is the one area, organ donation, when we have the 100% donations of brain dead patients, probably then we will get the medical tourism picked up for, I think, for the Western world and the developed countries. In my opinion, if we have the plenty of organs, then we will take all the patients of us and having contributions at the global level. So when the India will come to the global contributions regarding organs, organ donations, then the scenario will change regarding the medical tourism in India. Your take on, sir?
At the moment, the law clearly prohibits transplanting cadaver organs to foreign nationals who are not your relative. People of Indian origin can have, PIO, etc., they can have, but a foreign national, live donation cannot be done. Cadaver organs can be given only if you get a no from the whole country. So practically it becomes quite difficult to do. The law is like that.
Yeah, definitely. We need to change the policy. We need to change the law also, but we have to increase the donations. When the donation surpasses our need, then we have the plenty of donations, then plenty of organs, then we can utilize for foreign nationals also. So that is the way forward, I think, in my opinion. Sir, your take?
We have not been able to, in ICUs, we are finding a challenge on end-of-life decisions. We are going step. I think I will stop short here, but at ICCM, we have been trying our hard, except for the few critical care units. You see, the persons who needs besides politicians and involvement of religious people are the doctors themselves. I'm sorry to use the statement when I say that medical professionals are one of the biggest impediment in terms of donations, in terms of this, and this is a practical experience because every person who wants to take a decision go and ask about it from one or other the doctor. So I think sensitization at different levels of your education is as important.
Only thing, as an elderly, I can suggest, that's a very good thing. We saw this dream in 2005, I believe, when Dr. Hari Gautam was Vice Chancellor. We have seen also soon in our department commitment. And I'm happy that these boys are going ahead. But only thing I have to add one thing. For these things, most of the thing has been done. One has to teamwork, and whosoever in the team has to work in a mission mode. Then probably these things would be possible. And I'm happy that this is going to happen in Lucknow city, what we dreamt long back in 2005. Thank you, Ved. Keep it up.
Thank you, sir. It is because of your inspirations and guidance all the way. And we are happy that sir is the senior most, probably having the Padam Shri Award from Lucknow. So big round of applause for Rajan Prasad sir, one. And we have Professor D. Behra sir, another Padam Shri from Chest. And one is missing. I think we are trying hard to bring him in probably next meeting. So we will have Guleria sir also. So big round of applause for Padam Shris, two Padam Shri here. So I think now we have to chairperson.
So we can close the session. Thank you.
Thank you, respected chairpersons and speaker. Kindly collect your mementos from the felicitation counter. Before going on to the next session, we have a surprise element. Professor Dr. Subhakar Kandi sir has meticulously prepared an engaging quiz session for all of us. So I would like to invite Dr. Kandi sir on the podium, please. And sir had asked me to announce the prize as well, but I think it is so important and the prize is so big that we would be honored if sir announces it himself. On to you, sir. I would like all the postgraduate students to kindly take part in the quiz, and A4 size papers will be distributed to you for the answers.
I think, thank you, Dr. Ved Prakash. Actually, it is not there in the schedule because I'm not happy that I have done a topic which was already done. So that's why I want to do something new that I have always set up. Whenever I prepare a topic, I'll prepare a quiz relating to that questions. So, this is nothing new. If you have concentrated my lecture and Dr. Yadav lecture, all the answers are there. So that nothing new. There are 15 questions. So the 15 questions, anybody got above 80%, minimum 80% is the cutoff point. If they pass through the 80%, and then we will see if they are below 80%, no prizes. Above 80%, there will be a prize. I think we will give a free NAPCON registration to Jaipur. This last webinar also we conducted, and we have given for 2 postgraduates. So without wasting time, I think there are 15 questions. Each question has multiple choice answers. There is only one answer. I am giving a clue. There are no multiple answers. That is one clue. And I think the sheets are there. It's not a copywriting session. Just write question number 1, A, B, C, D, R. That's enough. After that, someone will collect. If the time permits, I will discuss the answers. Otherwise, I will discuss at the end of the, somewhere some time is there. So, and how much time you need for each question? 50 seconds is enough? 50 seconds is enough? Okay. So after 50 seconds, I automatically change the slide. So are you ready? Are you ready? No voice is coming from the other side. Are you ready? Okay. So a 34-year-old woman with idiopathic pulmonary arterial hypertension, WHO function class 2, is started on ambrisentan. Which baseline investigation is most important before initiation? Serum uric acid, pregnancy test, serum calcium, and creatine kinase. We'll go to the second question. There are 4 options are given. Which statement regarding bosentan is correct? Selective ETA receptor antagonist causes dose-dependent hepatotoxicity requiring liver function monitoring, contraindicated with all PDE5 inhibitors because of severe hypertension, eliminated primarily unchanged by kidneys. Okay, we'll go to the next question. A patient receiving sildenafil for pulmonary arterial hypertension is prescribed isosorbide mononitrate for angina. The major concern is A, severe bradycardia, B, pulmonary edema, C, profound systemic hypertension, D, acute hepatic failure. Okay, we'll go to the next question. Which pulmonary arterial hypertension drugs act by direct stimulation of a soluble guanylate cyclase, that is SGC, independent of endogenous nitric oxide. For some agent, there should be endogenous nitric oxide should be there in the system, but this drug, independent of nitric oxide, it will act. A, tadalafil, B, selexipag, C, rosuvastatin, D, ilioprost. We'll go to the next question. Concomitant use of rosuvastatin and sildenafil is avoided because clinical studies demonstrated increased pulmonary vascular resistance, excessive systemic hypertension without additional clinical benefit, severe hepatotoxicity, increased risk of pulmonary fibrosis. Okay, we'll go to the next question. Patient with WHO function class 4 idiopathic pulmonary arterial hypertension and right ventricular failure, I think class 4 means there will be right ventricular failure, requires continuous intravenous prostacyclin therapy. Which agent has demonstrated mortality benefit in randomized clinical trials? A, ilioprost, B, treprostinil, C, epoprostinil, D, selexipag. We'll go to the next question. Which property of epoprostinol makes interruption of infusion potentially catastrophic? A, extensive tissue accumulation. B, half-life of approximately 3 to 6 minutes. C, irreversible endothelial receptor blockade. D, delayed onset of vasodilator action. We'll go to the next question. 8th question, that is treprostinil differs from epoprostinil in that it can only be administered intravenously, has a substantially longer half-life permitting subcutaneous administration, is not a prostacyclin analog at all, has no effect on platelet aggregation. among these, which statement best describes Selexipag? It is a prostacyclin analog administered only by inhalation. It is a selective IP receptor agonist that is structurally non-prostanoid. It is a dual endothelium receptor antagonist. D. It is PDE5 inhibitor with additional prostacyclin activity. A patient on macitentan develops progressive ankle edema but has stable liver enzymes. The most likely mechanism is drug-induced nephrotic syndrome, B, direct myocardial toxicity, C, endothelin blockade causing peripheral vasodilation, D, pulmonary venous obstruction. In the AMBITION trial, the combination of ambrisentan plus tadalafil demonstrated A, no advantage over monotherapy, reduced risk of clinical failure events compared with either drug alone, increased mortality despite improved walk distance, benefit only in connective tissue disease associated PAH. Twelfth question is, which adverse effect is most characteristic of inhaled ileoprost? A, gingival hyperplasia, B, tendon rupture, C, jaw pain and cough, D, hyperkalemia. The next question is, patient receiving bosentan is started on warfarin, which interaction is expected? Bosentan inhibits CYP2C9, increasing INR. Bosentan reduces hepatic enzymes and may reduce the warfarin effect. C, warfarin markedly increases bosentan levels via PGP inhibition. D, there is no clinically relevant interaction exists. which scenario represents the strongest indication for escalation from dual oral therapy to parenteral prostacyclin-based therapy? WHO functional class 2, 6 minutes walk distance, 480 meters, NT-pro-BNP mildly elevated, option A. And option B is WHO functional class 2 with stable echocardiography for 12 months. And option C is WHO function class 3 with syncope, RAP more than 14 millimeters of mercury, and CI more than 1.8 liters per minute per meter square. Or D, WHO function class 1 with persistent TR velocity. Yeah, I think this is the last question. So, which PAH drug requires avoidance of strong CYP3A4 inhibitors, such as ketoconazole, because of significant increase in the drug exposure? A, ambrisentan, B, selexipag, C, tadalafil, D, epoprostenol. I think someone can collect the answer sheets. Madam, someone can collect the answer sheets, no? Please, just please hand over the answer sheets. It's okay. Result will be announced after the talk. I will tell the answers also because Bera sir is waiting. I can't keep him waiting. Yeah. Sir, 5 minutes, okay? 5 minutes, okay. Yeah. All the answer sheets are collected. Then I will go to the answers. So, I think the first question is this one, I think. I don't repeat the question again. So, the answer for this, before I answer, anybody want to volunteer? Huh? Because they have teratogenicity, so pregnancy test is a must. I think he has told you have to do what contraception, everything Dr. Yadav has discussed in length. So, all endothelial receptor antagonists are teratogenic. So, a baseline pregnancy test and a reliable contraception is a mandatory before initiation of endothelial receptor antagonists. I think then this question is which statement regarding bosentan is correct. I think we have 3 endothelial receptor antagonists. I told the last one is less hepatotoxic. I think you can know the answer then. Bosentan blocks both ETA and ETB receptors and is associated with dose-related elevation of aminotransferase. So monthly liver function test monitoring is recommended. That is the disadvantage. Other, they have less hepatotoxicity, whereas ambrisentan. A patient receiving sildenafil for PH is prescribed isosorbide dinitrate. I think this, if you understand the mechanism, the answer is very easy. They produce hypertension or that, sildenafil? And isosorbide dinitrate, what happens? They also produce hypertension. So the answer is both PDE5 inhibitors prevent CGMP degradation. Nitrate increase the CGMP production. The combination can cause life-threatening hypertension. Which PAH drugs acts by direct stimulation of soluble guanylate cyclase independent of endogenous nitric oxide? Riociguat directly stimulate SGC and also sensitizes it to nitric oxide, increasing the CGMP even when whereas the other agents there should be nitric oxide levels in this, otherwise they won't act. Independent of nitric oxide levels, this molecule will act. Concomitant use of riociguat and sildenafil is avoided because clinical studies demonstrated. The answer is combining riociguat with PDE5 inhibitors lead to excessive vasodilatation and hypertension. So the combination is contract. Both will produce vasodilatation. So if you give both in combination, as we have seen in the previous picture, when you give nitrates also, they produce tremendous vasodilatation. Ultimately, they may produce hypertension. A patient with WHO class 4 idiopathic pulmonary hypertension, right ventricular failure, requires continuous intravenous prostacyclin therapy. Which agent has mortality benefit? I told only one agent which has the data shows intravenous epoprostenol is the only PAH therapy with proven survival benefit in randomized controlled trials, because a lot of studies are conducted. Only this agent has a proven mortality benefit. Which property of epoprostenol makes interruption of infusion potentially catastrophic? Epoprostenol has an ultra short half-life, that is 3 to 6 minutes. Interruption can rapidly cause rebound pulmonary hypertension, RV failure, and death. Then the treprostinol differs from epoprostenol in that it can only be administered, I don't want to repeat the options. The answer is B. Treprostinol has a longer half-life and can be given subcutaneously. When there is a long half-life, it can be given subcutaneously, intravenously, or inhaled forms, or orally, offering greater flexibility than epoprostenol. That is the advantage. It can be given any route. Which statement best describes selexipag? Selexipag is a selective prostacyclin receptor agonist and is non-prostanoid. It is a non-prostanoid. Even though it's a prostacyclin, it is a non-prostanoid. Distinguishing it from the prostacyclin analogs such as epoprostenol and treprostinol. 10. A patient on macitentan develops progressive ankle edema. I told this is the molecule which has less peripheral edema, but sometimes patients can develop ankle edema, but has stable liver enzymes. The most likely mechanism is peripheral edema is a common adverse effect endothelial receptor antagonist, particularly due to vasodilatation and sodium and fluid retention, and may occur despite normal hepatic. There's nothing to do with the hepatic function. Hepatic function abnormality can produce edema, but here, irrespective of the hepatic function, because of the peripheral is common adverse effect due to peripheral vasodilatation. In the Ambition trial, I think Dr. Yadav has quoted extensively on this trial and also given this is the end chapter for monotherapy, and based on this trial, the upfront ambicentran tenofovir has significantly reduced clinical failure events compared with monotherapy. After this trial, no more monotherapy in management of pulmonary hypertension. Which adverse effect is more characteristic of inhaled ileoprost? This is one of the important side effects of inhaled ileoprost is commonly cough, flushing, headache, and jaw pain, especially around the time of inhalation. The patient receiving bosentan is started on warfarin. Which interaction is expected? So bosentan induces CYP3A4 and CY2C9, which can increase warfarin metabolism and lower the INR, necessitating closer monitor. So it will affect the drug levels of warfarin. So you need a closer monitoring, and it will lower the INR. Which scenario represents the strongest indication for escalation from dual valve therapy to parenteral prostacyclin-based therapy? I think syncope, elevated right atrial pressure, and low cardiac index indicate high-risk disease warranting parenteral prostacyclin therapy. The last question answer is, which PAH drug requires avoidance of CYP3A4 inhibitors such as ketoconazole because of significant increase of drug exposure? The telnafil is metabolized predominantly by CYP3A4. The potent inhibitor can substantially increase the telnafil concentration, increasing the risk of hypertension. So if you give this, the ketoconazole and along with telnafil, there is increased levels of telnafil and may lead to hypertension. With this, thank you once again for your participation. I will close and hand over to Dr. Behra sir to go ahead with proceedings. I don't know whether...
Thank you so much, sir, for that wonderful, thought-provoking quiz session. We now move on to our next session. The session is titled Risk Stratification in Pulmonary Hypertension. To chair this session, may I invite Dr. Haider Abbas, sir, Professor and Head, Department of Emergency Medicine, King George's Medical University. Dr. K.K. Savlani, sir, Professor, Department of Medicine, King George's Medical University. And Dr. Rajneesh Srivastav, sir, Senior Consultant Pulmonologist from Max Hospital, Lucknow.
Good afternoon, everyone. The next speaker is Dr. Digambar Behra, sir. He is a Padma Shri awardee and a stalwart in the field of pulmonary medicine. He has got over 45 years of experience in pulmonary medicine, joined PG MER Chandigarh in 1978 as a junior resident. He was the head of the department there, dean, as well as director of the PGI Chandigarh. Sir, I would like to welcome you. You don't need any introduction, sir. Welcome, Professor Digambar Behra, sir.
Thank you, chairpersons, and a very good afternoon to all of you. So during the next few minutes, I will be just discussing with you about the risk assessment in pulmonary artery hypertension. The question is why we should do a risk stratification, what are the advantages? You know, it is this risk stratification is useful in predicting the outcomes and guiding treatment of patients with pulmonary artery hypertension. So the aim is to reach a low mortality risk. So the most important thing why we do it, it is just to predict what will be the outcome and again how to guide the therapy, what treatment. You know, all you must have heard since morning about the various treatment options. So in addition to validate the risk tools, the pulmonary vascular resistance associated markers are increasingly relevant in guiding the treatment decisions. Of course, it is there. So then how are you going to discuss or decide these points? You must have again heard about the pulmonary artery hypertension, how its evolution, its involvement. It started, you know, the NIH registry started in 1990s, and then the European Society of Cardiology and the European Respiratory Society, they published their joint pulmonary hypertension guidelines in 2015. And then subsequently there are many guidelines basically, and then the various World Symposium on Pulmonary Hypertension, they are organized, and then we had got, I think the updated was the 7th World Symposium on Pulmonary Hypertension in 2024, and the updated version of 2026 is just under review, and I think it is going to be published very soon. So this is what the various WHO committees and the World Symposia on Pulmonary Hypertension that started in the 1960s, about when the term carpulmonale or the secondary type of pulmonary hypertension was realized, and then with different years and then different symposia they were organized, and the latest one I said about the 7th symposium that was held in 2023-24. As I told you, the risk stratification is important, that is to predict the outcome and the guiding the treatment. So the most predictive prognostic factors are the 3 non-invasive parameters. We have got both there are many, but the most 3 important non-invasive parameters are the WHO functional class, then the 6-minute walk distance, and then the natriuretic peptides. So that is one of the biomarkers. So these are included in all the currently validated risk stratification tools. Of course, there are others. I will be tell you as I go along. The limitations, however, are mainly related to the reduced specificity of the severity of pulmonary artery hypertension. So these variables may not always be adequate in isolation for guiding the individualized treatment decisions. However, with effective combination treatment regimens and emerging pulmonary arterial hypertension therapies, which are very nicely discussed in the morning, the markers of pulmonary vascular remodeling that are increasingly they are becoming relevant in guiding the treatment of the patients with pulmonary arterial hypertension. So the importance of these biomarkers is also, is necessary. We have to understand about that. So while reaching the most important thing, once we make a risk stratification, so our aim is to reach the low mortality risk that is assessed with a validated risk tool. It remains an important treatment goal. Preliminary data suggest that invasive hemodynamics and cardiac imaging may add further to this, they may add value in guiding the treatment decision. So these are the 2 newer ones which has been added or suggested. So this is, as I told you, the risk assessment in pulmonary arterial hypertension is now a multi-dimensional process to guide therapy and prognosis. So the 4 or 5 important things are the functional class, biomarkers, then the exercise capacity, imaging, the cardiac imaging, and the hemodynamic studies. So the basic key principles of risk assessment, I think this is 2026 guideline very clearly says that the basic thing is the confirm the diagnosis. So the right heart catheterization is mandatory to confirm the pulmonary artery hypertension, and you know that the main diagnosis is to have the mean pulmonary artery pressure of 20 millimeter mercury with pulmonary vascular resistance of more than 3 Wood units for precapillary pulmonary artery hypertension. So the accurate diagnosis is essential before initiating the disease-targeted therapy, which remains a cornerstone for the risk stratification. So you have to have the diagnosis should be confirmed or the, should be confirmed. So now coming to the various areas of which are the will be used, we will start with the clinical features. What is the significance? Symptoms and signs are not consistently included, although while heart rate and systolic blood pressure are included in the registries of pulmonary arterial hypertension to evaluate the early and long-term pulmonary arterial hypertension disease management, what we call as the REVEAL in risk scores. Nonetheless, the clinical features play a prominent role in the management of patients with pulmonary arterial hypertension. Say, for example, patients' feedback and the clinical signs of right heart failure are often instrumental in informing the physicians about the disease severity and trajectories. So the WHO functional class is an important component of all established prognostic scores and represents an independent predictor of prognosis. The next one is to find out the exercise capacity, or what is called the 6-minute walk test. I think it is a very commonly used and commonly known to find out the exercise capacity. So it is simple, safe, inexpensive. And it is a sub-maximal exercise test. It is widely used to measure the exercise capacity and accepted by global health authorities to assess how a patient functions. That gives an idea about how the patient is doing. So the 6-minute walk distance as an absolute value is associated with prognosis at both the time of diagnosis and during follow-up. This is at each step it is important. So changes in this 6-minute walk distance is neither a predictor of major clinical events, either in the short-term follow-up, nor a valid surrogate at the end point for outcome. These are some of the disadvantages of 6-minute walk distance. It is also very well associated with changes in the quality of life. The minimum important difference for the change in 6-minute walk distance is about 33 to 36 meters. So deterioration in the distance is associated with an increased risk of morbidity and mortality events. So improvement is not necessarily associated with better outcomes. And then the 6-minute walk distance is correlated again to the pulmonary artery hypertension severity. It is also influenced by age and other factors. The percentage predicted values sometimes are described, so they are no more predictive than the absolute values. So there is a meaningful threshold of the 6-minute walk test, that is 165 meter and 440 meter as the grounds of low and high risk. So that means a cutoff value of 160 meter had the highest positive likelihood ratio for death, while the highest negative likelihood ratio, that means higher the distance the person can walk, the best predictor of survival, the threshold is 440 meters. So these absolute values are also important. So heart rate recovery, some people use the heart rate recovery at 1 minute at the end of the exercise. The saturation is also have some contribution. Then the cardiopulmonary exercise testing, particularly which is done usually in the laboratories, that means the highest attained oxygen uptake, or what we call the peak VO2, that is associated with survival. And this highest attained oxygen uptake in combination with the invasively measured stroke volume index, or the SVI, they again may provide incremental prognostic value in intermediate risk patients of pulmonary arterial hypertension. Then another parameter is the slope of the total exhaled volume by exhaled carbon dioxide. The slope, or the lowest ventilatory equivalent for carbon dioxide, is also associated with poor exercise capacity. and survival. So the cardiopulmonary exercise testing is also very important. Then the biomarkers, I think the best ones studied and the most important ones are the BNP, or the brain natriuretic peptide, and then the N-terminal pro-BNP, that is NT-pro-BNP. These are the two biomarkers which are the most widely used as prognostic. So they are yet to be used widely, but they are being evaluated recently. Now the next one is the echocardiography. The right heart failure is the main determinant of outcome in patients with pulmonary artery hypertension, as I told you in the beginning. Then some of the parameters during echocardiography, some of the specific indicators like tricuspid, annular, plain systolic excursion, or what they call the TAPSE. It is to assess the systolic displacement of the tricuspid annulus towards the right ventricular apex. So this is a simple and frequently used indicator of right ventricular longitudinal systolic function. Then the pressure of TAPSE less than the excursion less than 18 millimeter was independently associated with mortality. Then it is angle and load dependent and reflects only the basal longitudinal function, neglecting the contribution of the apical and outflow tract. That again, indicates the functioning of the cardiac. So then you can see there are many other parameters. They can be found out from the echocardiography. Some of them important ones: the right ventricular fractional area change, then the speckle tracking echocardiography, then the RV and the right ventricle and right atrial dilatation, then the three-dimensional echocardiography, right ventricular overload, tricuspid regurgitation, its presence, that represents a marker of right ventricular remodeling. And then the parameters associated with increased right ventricular filling pressure, particularly if there is pericardial effusion, and the inferior vena cava diameter, they are again predictors of prognosis. So all these parameters are, can be studied during the echocardiography. So also echocardiography is useful for detecting the effect of pulmonary artery therapy on the right heart morphology and function during the follow-up. Then the cardiovascular magnetic resonance, that is an imaging modality that provides highly specific information on the right ventricular structure and function. It is considered the gold standard for its non-invasive assessment. Then some of the parameters they are studied, like the right ventricular end systolic volume index, or the right ventricular end systolic end diastolic volume index. So when used as an adjunct to contemporary scoring systems, so they enhance this discrimination whether the patient is at intermediate or high risk. Then I have already told you right ventricular diastolic thing. Then the presence of right ventricular hypertrophy, the combination of high right ventricular volume with a mass with a low right ventricular mass, the volume and mass effect that again can be studied through this cardiovascular magnetic resonance. Then the right ventricular ejection fraction is also an independent predictor of prognosis. So the prognostic role of this cardiac MRI parameter seems to be better at follow-up than at baseline. Then coming to some of the invasive hemodynamics that I was indicating, so over the past 2 decades, the mean age of the patients in registry cohorts has significantly increased. That means the age of the patients with the pulmonary artery hypertension, the age they are occurring more and more at the higher ages. But on the other hand, the measurement, the numerical value of the mean pulmonary artery pressure is possibly not a very good indicator as is realized nowadays. Say for example, if somebody is having the high pulmonary artery pressure and say for example, if it is a congenital, due to congenital heart disease, the pulmonary artery pressure can be very high. And the PV, the pulmonary vascular resistance has decreased. However, in most of these series, this pressure was not correlated with survival. The prognostic role, therefore, of the baseline RA pressure is now has been well established. So other independent baseline predictors of death are the cardiac index, then the SVI, then pulmonary artery compliance, and the mixed venous oxygen saturation. So cardiac index in particular seems of additional prognostic relevance when evaluated at the peak exercise. Now, I think it is also important to know about the patient-reported outcome measures. That means it provides a patient-centric metric regarding the impact of pulmonary artery hypertension, specifically the health-related quality of life, as that means the quality as perceived by the patient. That is also very important, and that should not be ignored. So there are various instrumental scales that are available. Some of them I have just mentioned. So the emotional or cognitive domains, assessment factors such as anxiety, depression, energy, and social functioning, etc., are also very important while assessing the the risk. So I think I have already told. Now I have just tried to discuss about the various parameters and their role. So therefore, if we now come to the functional assessment, we have got the a little bit elaboration on that. The WHO functional class, it ranges from class 1 to, or that means when no symptom, to class 4 when the symptom is at rest. So it is functional class remains a cornerstone. Then the exercise capacity that we have already discussed in detail. Then various biomarkers again I have discussed. Then the imaging and hemodynamics we have already deferred. The important ones are the right heart catheterization, right atrial pressure, cardiac index, and the mixed venous oxygen saturations. So all these parameters are critical for a risk assessment. And then the multidimensional risk stratification is also important. The 2026 guidelines of the European Society of Cardiology and European Respiratory Society guidelines recommend that we have to integrate 3 or more than 3 variables across the functional, biochemical, or the biomarker which is said, then exercise, and hemodynamic domains to categorize patients as low, intermediate, or high risk. So the tools such as Rebuild 2, as I will be discussing subsequently, or the ESC, ERS risk calculators can assist in quantifying the risk even if some variables are missing. That means you have to at least use 3 variables and then you give the risk. The WHO functional class, as I was telling you, you have got class 1, that means no symptoms with the ordinary activity, only with the exertion. Class 2 is symptoms with the ordinary activity. Class 3 is symptoms with less than ordinary activity. So you cannot do usual course supping without dyspnea. And class 4 is when the patient is symptomatic at rest. So I'm sure you must have heard these things in the morning. Then the treatment choices are driven by risk, and the goal is to move patients to low risk quickly. So one of the examples, for example, the European Society of Cardiology and the Respiratory Society, European Respiratory Society, approach our diagnosis. They use a 3-strata model predicting 1-year mortality. Say, for example, if it is low risk, then the mortality at 1 year is less than 5%. If it is intermediate, it is between 5 to 20%. And if the risk is, if it is high, then the mortality at 1 year is more than 20%. So this risk assessment variables, it uses 10 domains, and these are some of the important ones. That is the clinical progression, signs of right heart failure, syncope, then WHO functional class, biomarkers, I told about the BNP, exercise capacity, hemodynamics, imaging, and then the cardiopulmonary exercise testing. So even if you do not have everything, the calculator can still be useful with the 3 or more than 3 variables. So the rebuild 2 that builds on similar core variables, but it has got further patient context like patient demographics, renal function, blood pressure, and the diffusion capacity, etc. are taken into account. This is the baseline score. Risk score is calculated. I think, I don't know whether you are able to see, but these things are available online, so you can use those parameters and then give a number, and then you can predict whether the patient is at what level of risk. Then the rebuild 2 assessment, it is a rebuild registry risk score 2. It is a prognostic tool. It is designed to predict the 1-year mortality risk in patients with pulmonary artery hypertension. It is calculated using 13 variables that includes, as I told you, the demographics, functional class, 6-minute walking distance, then the biomarker, that is BNP, then hemodynamics, and echocardiography. So it stratifies again patients into 3 risk categories. Low risk, that means if it is 6 or less than 6, so 1-year survival is more, just 2 more minutes, more than 90%. Intermediate risk, if it is between 7 to 8, so again the 1-year survival comes down to 85 to 90%. And if it is high risk, that means if the value is 9 or more, the 1-year survival is less than 70%. So this is based, this score is derived based on the large United States rebuild registry. So this is how that looks like. So this is the rebuild 2 and the rebuild light 2, the score that you can do using different parameters, then give a score to that, and then you can calculate accordingly. So then then while you are assessing the risk, so the key principles will be follow-up and reassessment also is important. The stable patient should be reassessed every 3 to 6 months using these parameters, as we have already discussed. So the treatment goals will focus on achieving or maintaining a low-risk profile that indicates improved survival. Then therapy may be escalated or modified based on the assessment results. So this is the summary of what I have told. As you can see, the pulmonary vascular register, and you can see 3, the hemodynamic parameters, and then the echocardiography values, and then the validated risk assessment scores that we have told. So this is the summary of what we have told. So again, this is the chart of the treatment chart, and again on the right hand side, you can see first you have to diagnose, give a definite diagnosis, and then they assess the risk, and then initiate the therapy depending upon the risk. So summarizing what I said, so the modern pulmonary artery hypertension risk assessment is multidimensional, combining the functional class, biomarkers, exercise testing, imaging, and hemodynamics. So regular reassessment ensures timely therapy adjustments, so aiming to move patients to a low-risk profile, which is strongly associated with improved long-term outcomes. So this approach reflects the 2026 European Society of Cardiology and ERS guidelines and the US expert consensus for optimal management of PH. So I think this is the end of it. Thank you very much for your kind attention.
Hello. Thank you, sir, for a very informative and lucid lecture. As you highlighted, sir, some of the important parameters like functional assessment followed by biomarkers, then echo, and then obviously MRI and even catheterization can help you in assessing the risk. And most important aim should be to correctly assess the risk and start the treatment to reduce the risk of those patients. And 4 things you mentioned in the follow-up. It simply requires WHO class, biomarkers, 6-minute walk test, and echocardiography, which during the follow-up is a very important tool to see how the patient is going, Sir Joy. Thank you. Now topic is open for discussion. If you have any questions, welcome. It seems there are no questions, so we close the session now. Thank you, sir.
Thank you so much, sir, for that wonderful lecture. Thank you, respected chairpersons. Kindly collect your mementos from the felicitation counter. Our next session focuses on connective tissue diseases, associated pulmonary arterial hypertension, and its multidisciplinary approach. To chair this session, may I invite Dr. Nikhil Gupta, sir, Additional Professor, Department of Medicine, RML, Lucknow. Welcome, sir.
For the next lecture, I would like to call Dr. Sandeep Balkrishnan, and he's Assistant Professor, Department of Clinical Immunology and Hematology in SGPGI. So he will be talking on the connective tissue disease.
I would also like to take this moment to invite Dr. Rahul Srivastav, sir, and Dr. Nidhish Chandra, sir, on the dais as chairpersons. Welcome, sir.
Shall I start? Good afternoon all, respected seniors and colleagues. I am Dr. Sandeep. I am the Assistant Professor in Immunology Department, SGPJ. Actually, this lecture is supposed to be taken by our Professor Vikas sir. Since he is having some family issues, this task was given to me. So I will be starting now. So I will be starting with few cases. So first case is a 35-year-old female. She presented with polyarthritis for 5 years, progressive skin thickening for 3 years, Raynaud's phenomena, digital pits, And initially she was treated with hydroxychloroquine and methotrexate. And after that, now she presented with progressive dyspnea on exertion, and her chest X-ray was showing prominent pulmonary artery. And her PFT showed a DLC of 50%. Echo was showing a dilated RA and RV, moderate TR with an RVSP of 72. HRCT shows normal lung parenchyma. So the images, you can see, this is the characteristics scleroderma facies with skin thickening, microstomia, pinched nose, and the second picture shows the classical Raynaud's, and these are the digital pitted scar. So this is a case of systemic sclerosis related pulmonary hypertension, and there is no interstitial lung disease on the HRCT. So case 2 is a 27-year-old female presented to us in 2019 with polyarthritis, photosensitive malar rash, Raynaud's phenomenon, dyspnea on exertion, NYHA class 2 to class 3 progressed. Serologically, her ANA was positive with high titers anti-DS DNA, low complements. Anti-ribosomal P was also positive. APS, antiphospholipid, and lupus anticoagulant both were negative. Her echo showed an RVSP of 79 with moderate TR. CT pulmonary angiogram was normal. So she was diagnosed as a case of lupus with PAH with high disease activity. She received 6 pulses of NIH cyclophosphamide with vasodilators. Post-induction cyclo, her RVSP came to 55, and she was maintained on Azoran for 4 years, and progressively her RVSP came from 44 then to 27. Now she is off immunosuppression and she is asymptomatic with an yearly echo showing RVSP of around 25. So this is the classical lupus-associated pulmonary artery hypertension. Similarly, we have another spectrum of disease, that is MCTD, presented with puffy fingers, Raynaud's, polyarthritis, salt and pepper pigmentation with U1 RNB antibodies positivity. With normal CT chest, her RBSP is around 55. So this is the third case. This is the MCTD associated PAH. So in CTD associated PAH, we have these are the 3 most common causes, that is lupus, systemic sclerosis, and MCTD. So if we see the global burden of CTD associated PAH, almost 1/4 of the patients of PAH are CTD associated, and in both in Western and Asian registries. But coming to the Asian and Western registries, which CTD is most common? In Western registries, lupus associated PAH is more common, while in Asian registries, systemic sclerosis associated PAH predominates. So the understanding the regional heterogeneity is the first step towards precision medicine in CTD associated PAH. Coming to the major Asian registries from Korea, Indonesia, India, Japan, we can see that CTD associated PAH from the Indian registries were less. So is this a true epidemiological difference or it's an under recognition? This is because majority of these registries diagnosed PAH based on echo. And there are under referral from rheumatology clinics and less diagnosis of this CTDs like systemic sclerosis and MCTD. And there are differences in the spectrum across the regions, and there are also selection bias within these registries. CTD associated PAH had a very poor survival. So there is a drastic reduction in the survival when the patient developed pulmonary artery hypertension and interstitial lung disease. So we have to see, is there any pathological differences between the PAH due to lupus, systemic sclerosis, or MCTD? At a first glance, all these presents to us with dyspnea, elevated pulmonary pressures, right ventricular dysfunction. But on autopsy studies, it has been shown that SLE-PAH, there is a lot of vasculitis. You can see there are a lot of vasculitis in the adventitia. All the layers are involved with luminal narrowing, with fibrinoid arteritis. So SLE-PAH, there is more inflammation than fibrosis. So the advantage of this pathological finding that it will respond to immunosuppression if you catch these patients at the right time. Second is in systemic sclerosis associated PAH, here there is more fibrosis. Scleroderma is a more fibrotic disease. There is fibrous occlusion with intimal thickening. There is fibrous occlusion of the small blood vessels. All these lead to impaired gas exchange. So in systemic sclerosis, there is more fibrosis than inflammation. And the response to the immunosuppression is also plus minus. Coming to the MCTD PAH, here it is an intermediate in between lupus versus systemic sclerosis. So here there is both component of fibrosis and inflammation. So it is a response to the immunosuppression is also here also it is plus minus. And we should also understand when the pulmonary hypertension or the pulmonary vascularity begins years before the overt pulmonary hypertension, the disease starts in the small vessels. We can see years before the onset of overt PH, there is small vessel intimal thickening is going on, intimal hypertrophy, intimal disease is going on. As there is disease progress, there is widespread involvement of the other blood vessels, that is venules, veins, arteries, and lead to widespread obstruction. So PH remodeling starts before clinical PH becomes evident. Coming to the immunopathogenesis of CTD-PAH, so this is a normal pulmonary artery, and whenever there is endothelial injury, that is the beginning of all the events. So there is beginning with endothelial injury. It could be due to inflammation, viral infections, anti-endothelial cell antibodies. All these leads to recruitment of inflammatory cells, and these leads to chronic then release of chemokines, cytokines, growth factors, leading to chronic vasoconstriction, smooth muscle dysfunction, endothelial dysfunction, vascular remodeling, thrombus formation, collagen deposition. All these leads to a dysregulation of angiogenesis. So they begins with endothelial injury, followed by immune dysregulation, ultimately driving progressive vascular fibrosis. So this is another concept, that is endothelial injury, leading to the exposure of these endothelial antigens that leads to breakdown of immune tolerance. There is a reduction in the T regulatory cells. There is activation or upregulation of the B cells and T cells, which are autoreactive, and there is production of anti-endothelial cell antibodies. And there is this in the early phase, this blood vessel wall is intensely infiltrated by these immune complexes and blood and inflammatory cells. And as the disease progresses, there is smooth muscle proliferation, intimal hyperplasia, thrombi, and fibrosis. And in a late stage, these cells, these endothelial cells, become resistant to the apoptosis, and there is lesions like plexiform lesions. So the importance of studying the entire immunity from starting from the endothelial to the fibrosis is that the early stages, like the right side, there is these early lesions are reversible stage. So that will respond to the immunosuppression. But patient once go to the later stage, if you see a patient after 10 years of disease, it could be full of fibrosis and it may not have a complete recovery. So our goal is to intervene before irreversible vascular damage sets in. There are autoantibodies experimentally evaluated in CTD-PAH. The most important antibody is anti-endothelial antibodies. These are not done routinely. These have been seen elevated in MCTD-PAH and lupus-associated PAH. So what are the clinical predictors of PAH in a case of systemic sclerosis? So in a case of systemic sclerosis, other disease manifestations like esophageal involvement, interstitial lung disease, syndromic antibodies, calcinosis, digital vasculopathy, Zika symptoms, all these can have a predictor of an impending PH in this patient. Coming to the screening of systemic sclerosis, in PH and systemic sclerosis, there are three clinically we used to do a PFT, a biomarker, and a functional assessment. So in a PFT, most important is reduction in the DLCO less than 60% or more than 20% in 1 year in the absence of significant lung volume abnormalities, or a FVC DLCO ratio more than 1.6. An important biomarker is NT-proBNP, which has a sensitivity of 90% and sensitivity and specificity of 90%, and more than twice the upper limit of normal is suggestive of PAH. And 6-minute walk distance correlates with this PAH also. So who should, in a case of systemic sclerosis, who should undergo a right heart catheterization? So this is based on a study. This is known as a Dept study, and the objective was to develop an evidence-based detection algorithm in pulmonary artery hypertension in systemic sclerosis to minimize the missing cases of PAH and to optimize the use of right heart catheterization. So they included patients of systemic sclerosis more than 3 years of disease duration with DLCO less than 60%. So in this algorithm, they have derived 6 variables. These they have done by multivariable analysis, and they have found that these variables, the first variable is the FVC by DLCO ratio, past or current telangiectasia, anti-syndromic antibodies, serum NT-proBNP levels, serum uric acid levels, right axis deviation on ECG. And if these scoring, and if the point is more than 300, such patients we should refer for echocardiogram. In echo, they have taken only two variables, that is the right atrial area, the TR velocity. And in the step 2, if it is more than 35, we refer these patients to right heart catheterization. So what is the advantage of Dept algorithm? The sensitivity is around 96%, and it will miss only around 4% of the cases compared to the European guidelines. So Dept algorithm is preferred. When the primary goals of Dept algorithm, there is overrepresentation of limited cutaneous systemic sclerosis. Limited cutaneous systemic sclerosis is the disease which is associated with PAH at the onset. So if you screen more cases, you will get more PAH. And it is unable to identify other forms of PAH like group 2 and group 3. And they have included only 2 echo variables. They have ignored a lot of other important echo parameters. They ignored pulmonary veno-occlusive diseases. There was not much systematical radiological assessment, and it was a cross-sectional analysis. So long-term algorithm performance is also plus minus. So an important, as Bharat sir has already discussed about 6-minute walk distance. So the minimal important difference of 6-minute walk distance is around 33 to 36 meters. And less than 165 meters associated with highest mortality, more than 440 is a stronger predictor for survival. And we can see that patients with systemic sclerosis with PAH had a marked reduction in the 6-minute walk distance compared to without PAH. But be careful in a CTD ILD or CTD PAH, these 6-minute walk distance is influenced by other factors like ILD, arthritis, myositis, and deconditioning. And it is best useful for follow-up than screening. An important biomarker is NT-proBNP. I am not going to this, sir has already detailed. And to summarize the screening in PH and systemic sclerosis, we have the European guideline. These are the echo-based guidelines, high risk, intermediate, and when to refer for right heart catheterization. Dept algorithm I have discussed. And ASIG also, they also promote proBNP, DLCO, and plus minus, positive and negative, they will refer for right heart catheterization. So special point on the risk stratification in CTD-PH. For example, I will show 2 cases. Patient 1 is a 30-year-old male with idiopathic pulmonary artery hypertension, and case B is a 65-year-old male with systemic sclerosis PH. Both of them are having the same WHO functional class, same 6-minute walk distance, same proBNP levels, and patient B is having additional renal dysfunction. So are these patients same? If you see the PAH parameters, they are almost same functional class. But if you see in the European guideline, they focus mainly on the PAH severity. That is the functional class, 6-minute walk distance, biomarkers, RV imaging, hemodynamics, which guides in treatment escalation. But compared to that, the Reveal 2.0, they focus on the overall prognosis. They includes, apart from the PAH, beyond PAH, they assess the age of the patient, underlying CTD subtype, renal functions, number of hospitalizations, and PAH severity. So as already I have mentioned, there are fallacies in 6-minute walk distance if you assess in a case of CTD. There are fallacies in proBNP, it can be elevated in renal dysfunction, and there are also, we should see the different subtypes of CTDs behave differently, like lupus will behave entirely different. In systemic sclerosis and Sjogren's, etc., all these behave differently to the immunosuppression or the vasodilator therapy. And an important point is nail fold capillaroscopy. Studies have shown that the nail fold capillaroscopy, which can be done easily in the bedside or in the OPD, which have a positive correlation with the pulmonary artery systolic pressures. And is there any evidence for anticoagulation in CTD-PH? In a study, in a descriptive study of 187 systemic sclerosis patient, on warfarin with a mean INR of 2, they have found that the long-term warfarin therapy was associated with poor survival. So how to follow up these patients? So initial follow-up around 1 to 3 months after starting the therapy. We have to risk assess every 3 to 6 months. We should assess functional class, 6-minute walk, pro-BNP if it is available, echo and risk score, and repeat the right heart catheterization when clinically indicated. Treatment escalation if low risk status is not achieved. We always try to achieve a low risk disease status. Coming to the immunosuppression in systemic sclerosis associated PAH. So this is a randomized controlled trial of 57 patients of systemic sclerosis of less than 5-year disease duration, treated with rituximab 1 gram 2 doses versus placebo. They have background PAH therapy were continued. The primary endpoint was 6-minute walk distances 24 weeks. And they have found that actually this trial didn't met the primary endpoint. So they have found that the maximum improvement in the 6-minute walk distance is around 24 to 36 weeks. And half of these patients achieved an improvement in the 6-minute walk distance. That is the minimal improvement that is more than 33 meters. And is there any immunological link? So we have seen that when we give rituximab to this patient, the rituximab will suppress the immune system. It will deplete the B cells. So we can see as the B cell has the 6-minute walk distance is improving, correspondingly the B cell count is also depleted. So there is an immunological correlation. Here also we can see once the 6-minute walk distance is improving, the B cell count is depleting. So the rituximab improved exercise capacity, but there should be large studies to prove in systemic sclerosis associated PAH. What are the PAH predictors in lupus? So the main predictors are Raynaud's phenomenon. When usually Raynaud's phenomenon usually we see in systemic sclerosis, MCTD spectrum. But in the case of lupus, if you are getting Raynaud's phenomenon, pleuritis, pericarditis, RNP antibodies, Rho antibodies, anti-cardiolipin antibodies, we should suspect impending PAH, should always see for PAH. And is there any simple test which can predict PAH in the case of lupus? Yes, this is the uric acid levels. So studies have shown that the uric acid levels positively correlated with the pro-BNP levels and systolic pulmonary artery pressures. And a cutoff of 6.5, if it is more than that, it has a high specificity of around 96% in predicting pulmonary artery hypertension. So elevated uric acid may serve as an inexpensive adjuvant marker for identifying lupus patient with at risk of PAH. So always send a serum uric acid level in a follow-up case of SLE also. Coming to the immunosuppressive therapy in lupus PAH, I have described. In lupus PAH, there is a lot of immune response. There is a lot of inflammation. There is a lot of vasculitis. So this is a small study actually. It's 34 patients randomized control trial of cyclophosphamide, 500 milligram monthly, 6 doses versus enalapril, 10 milligram per day. And they have followed for 6 months. So they have found that cyclophosphamide had a patient reduced the pulmonary artery pressure from 15, while patients on enalapril had a reduction of around 7. But this is a small study with a 34 sample and with a short follow-up of 6 months. So we can't justify this as a major trial, but we used to give SLE PAH cyclophosphamide with almost good response to that also. Clinically also we are giving in our center. And finally, if we see which is the treatment in systemic sclerosis which have maximum benefit in survival, the main outcome in the case of systemic sclerosis is survival. So that is HSCT, hematopoietic stem cell transplant. So there are landmark trials in systemic sclerosis which have caused improvement in survival, but the major drawback of all these trials, they have excluded patients with PAH. In some of the studies, they have excluded total PAH. In some studies, they have excluded when the RVSP is more than 40. So HSCT may modify the disease because there is benefit in interstitial lung disease, but the role of established PAH remains uncertain. So my take-home message is CTD PAH account for nearly 1/4 of the group one pH with important regional difference in the disease spectrum. SLE pH predominates inflammatory, whereas scleroderma pH is characterized by irreversible fibrosis. And the vascular remodeling begins long before the clinically overt pH develops. The therapeutic window lies in the early inflammatory phase. Declining DLCO, elevated proBNP are important screening marker of systemic sclerosis pH. Detect algorithm improves the sensitivity of pH case in systemic sclerosis. 6-minute walk distance is prognostic but is influenced by ILD, arthritis, myopathy, and deconditioning. Nail fold abnormalities may mirror pH, but remodeling and it can identify high-risk patients. Immunosuppressive therapy is beneficial in selected patients with immune-mediated pH, particularly in lupus pH. Thank you.
Thank you, Dr. Sandeep, for that comprehensive and extended lecture on CTD-PH. Audience has got any questions? If there is no questions from audience, I would like to ask Dr. Sandeep. So most of our audience are non-rheumatologists. So if they are practicing pulmonologists who have got not that much of exposure into CTDs, as an immunologist in your daily OPD, suppose I am a pulmonologist who is sending a patient with PH to you, I don't know the etiology. How would you be approaching? What would be your checklist or a set of questions that you would be asking so as to segregate patients into inflammatory, fibrotic, or a mixed pattern or an MCD pattern?
Main thing is we should try to find the exact duration of disease, total duration of illness. Whenever a rheumatology patient comes to our OPD, first question we will ask, what is the exact duration of disease? So it will be very different because CTDs have different manifestations. Patient can have arthritis at one point, after many years can have myositis, after many of ILD, PH. So most important is the exact duration of disease. It will take some time. Many of the patients may say that my disease is only 3 years, but after many repeated questions, or we should give some time, they may not be remembering. So they will say that, yeah, it's almost 10 years down the line. So that means it is almost 10 years means almost the disease has begun. So that is the most important. The duration of disease itself will say whether disease is treatable or not. And for all patients, the main CTDs, we have lupus, we have systemic sclerosis, and we have MCTD. Which disease have maximum PAHs? Systemic sclerosis. Among systemic sclerosis, the limited cutaneous systemic sclerosis have early onset PAH, severe PAH. And other diseases, MCTD. So systemic sclerosis, MCTD, almost 90% of the patients will have PAH. So always we should do routinely functional assessment. What is the effort intolerance? How many stairs they can walk? How many distance they can travel? So effort, then do a 6-minute walk distance. You should do a baseline echo. Specifically, we should ask for right ventricular RVSP. Majority of the cases, the cardiologist, they will do a ejection fraction, they will do the chambers, they may not be able to mention. So we should specifically ask the cardiologist to do a right ventricular systolic pressure. RVSP is one of the most important. And PFT with DLCO. Early decline in DLCO, the volumes may be normal. Early decline in DLCO will predict. That means you should keep. If there is a 20% fall, like in interstitial lung disease, there is a composite decline. There is a 20% fall. Don't wait for 20% fall. Even if the patient is worsening more than, in 6 months itself, a patient is worsening with 10%, we should intervene. Such patients may benefit with immunosuppression. And other causes like thromboembolism, chronic thromboembolism.
Just one more question regarding the autoantibody panel testing. What are the antibodies that you would recommend in a patient with PH?
Anyway, all CTD patients will get an ANA pattern. So the ANA pattern and ENA, extractable nuclear antigens, has to be done. So the maximum predictor is anti-U1-RNP. U1-RNP is the antibody which is associated with endothelial injury. So we have seen that the endothelial injury is the beginning of all these things. So when these U1-RNP antibodies are positive, in the case of lupus, those patients will have, mostly those patients will develop this thing. And at the same time, antiphospholipid antibodies, APS, and most of the time APS antibodies they used to mention, but lupus anticoagulant is the most Another important antibody which routinely it's not done. So lupus anticoagulant has to be done in all cases. ENA has to be done.
Thank you, sir, for the nice presentation. Sir, one more doubt. You showed there is a little evidence of rituximab in SSCPH. So I want to ask, what is your experience about rituximab in SSCPH?
But most of our patients, if you see, we have a very little number of patients with pure pulmonary artery hypertension. Most of those patients have associated interstitial lung disease. So we have patients of lupus with isolated PAH. There are few patients with this. But systemic sclerosis, most of the patients are having associated interstitial lung disease. So that is why the HSCT data, they could not, it is in a major, their survival was their primary endpoint, event-free survival. But majority of those patients were having ILD. So it is very difficult to, we have very less number of patients with having pure PAH and limited systemic sclerosis have, but their prognosis is bad even with rituximab. Whatever you give, because of severe RVSP 90, 100, nothing will happen. Those patients may succumb.
Very rightly said. I would like to add something because most of the autoimmune disorders initially they are very vague symptoms. So in day-to-day practice, in general physicians and chest specialists, they miss the patients. Sometimes they think it is psychological symptoms or psychosomatic symptoms. So we have to more precise and we have to thoughtful about that patient might be having this CTD. And most common 3 CTDs are we know lupus and then systemic sclerosis and this rheumatoid arthritis related ILDs are most common. So more vigilance and more you have to more thoughtful and early detection is more important in these patients. Thank you.
Thank you.
Thank you very much.
Thank you, respected speaker and chairpersons. We now move to the assessment of right ventricular pulmonary arterial coupling in children with pulmonary arterial hypertension, our next session. To chair this session, may I invite Dr. S.K. Sonkar, Professor, Department of Medicine, King George's Medical University, Dr. Vinod Kumar, Associate Professor in Department of Pediatrics, King George's Medical University, and Dr. Shubham Tiwari, Assistant Professor, Department of Respiratory Medicine, Hind Institute of Medical Sciences, Lucknow. Welcome, respected chairpersons.
Good afternoon. So our next topic would be talked by Dr. Shashi Raj, and that topic as discussed. So please, Dr. Shashi Raj.
Hello everyone. Good afternoon. I hope I can keep this boring topic little engaging on this postprandial drowsiness some may have. So I'm part of the heart failure and transplant team at NH, looking after children and young adults with advanced heart failure and pulmonary hypertension. As you know, pulmonary hypertension, first of all, many thanks to Dr. Ved Prakash and all the organizing team for, inviting a whole host of experts from different fields and, trying to engage with the audience here and share our ideas, how each institution may, practice more than the didactic and what goes behind, the subject topics itself, which everyone would be, quite familiar with. It would be even, practical to know, how we actually do on the field, considering the logistics and constraints and, socioeconomic conditions and facilities and follow-up, right? Because this is a chronic condition. If we ask, in fact, there was an interesting call for a paper for the title being Pulmonary Hypertension, Who to Manage, by pulmonologists, cardiologists, or both, or others, right? I'm a rheumatologist. So it really is a chronic condition where you really need a team who is dedicated to actively manage this chronic condition, probably led by pulmonologists, I would say. But, there has to be really close interaction with, a lot of people, cardiac surgeon, right? Because there is a unique treatment modality in, CTIF, for example. So although we look at it as a chronic condition, I would just bring in a very narrow focus of this topic where, we will just go over, what we do at our place and then, how that can be translated. I don't have disclosures relevant to this topic. So I think everyone is familiar with, all the previous speakers have gone through this in terms of, how do we risk stratify pH? My talk is predominantly based on group 1 pH, just as a disclaimer. So we know that these are simple measures and it is well validated that, functional class, 6-minute walk test and NT-proBNP. As the disease progresses, we see how the change in several of the hemodynamics really affect, what really we are looking for. In fact, we would say that at some point, the invasive measure of PVR may be independent of the disease progression because that may not directly correlate at that stage of advanced disease. So we are also, I think, familiar with the previous speakers, who have highlighted the role of NT-proBNP, which really reflects, right heart overload and dysfunction, and it's well correlated with hemodynamics and 6-minute walk test, both at baseline as well as follow-up. Now, I think these are also, well highlighted already previously. Deterioration in 6-minute walk test is associated with increased morbidity and mortality, but however, there are enough literature to show that improvement may not necessarily means we are better off. So we just need to keep an eye on what is really the trajectory of the patient as a snapshot assessment when we do in the clinic. So we know, this is 165 meters and 450. This is mainly by Western criteria, but somewhat in that range would be the guardrails of low risk versus high risk. And definitely 165 meters, which is really small, you would think that there is a high likelihood of death. Of course, as adults, there might be a little more comorbidities, and also this is definitely, applicable in younger population for sure. And if we do have a systematic way of assessment in terms of cardiopulmonary exercise test, of course, there are, variety of parameters which we can look at as, poor exercise capacity and survival. So coming to the imaging part, now, again, this is subject to, what kind of institutional setup we have, expertise we have, and how do we utilize the data what we have for an individual patient, because ultimately that's what it comes up to. Yes, we can always get a test, refer to a place and get a report, but can we really apply that and then follow up for this particular patient? So there is definitely a big role, an increasing role of cardiac MRI, especially at follow-up than at baseline. So RVEF, more than 45% at follow-up predicts a low risk of death. So if you do see patients who have had this disease on treatment, they come to you after several years, maybe as a one-time second opinion, or they may have had a report. So just look at the numbers and see, because it's clearly related to the RV function, what we are looking at. And this is one way of looking at things. Yeah. And RVEF for follow-up definitely has a superior power compared to invasively assessed PVR, as we know, because that's where the, whether the interaction of the RV function and the PA vascular bed, when does it maintain, when does it start uncoupling? So RV dysfunction can definitely progress, as we know, pathophysiologically, despite a decrease in PVR at the later stage of the disease. Now, I think previous speakers have already, gone over, what is a low risk versus, high risk parameters. So if we have the basic 3 parameters in terms of functional class, 6-minute walk test and NT-proBNP in the low risk category range, there is a high likelihood of survival at, 1 year and 3 years, and a low risk of mortality. The same with the reveal light score as well. Now, let's just go back to the basics, a little bit of, I think, everyone practicing in this field would be well familiar with how do we, really quantify and know the details behind what we are looking for in this condition, right? So this is just a diagram as a simplistic way of looking at, a fireman's way of, putting out the fire through this hose where you need this air chamber, that Windkissel effect, right? So I can't make this pointer. So Yeah, so this is what really keeps the water going, right? So in the pulmonary vascular bed, if we go back to the physiology or pathophysiology classes, we know that the right heart is looking at the pulmonary vascular bed in totality, but there is a difference between what the smaller elastic arteries versus what how we assess the pulmonary vascular resistance would be. So pulmonary vascular resistance mainly is located in the small arteries and arterioles, right? It strongly depends on the vessel diameter. So conventionally, the ratio of transpulmonary gradient over cardiac output is what the PVR is, as opposed to compliance, which is essentially the storage capacity of all the arteries and arterioles taken together. So the inverse of resistance obviously is a compliance, but the way we look at it as the stroke volume over the pulse pressure. Essentially, how is that pulsatility effect or the dynamic effect of the pulmonary vascular bed is what we really are looking at as a compliance, although routinely it's quite easy to get the PVR when we do the RHC and the measurements, right? Because unless you do a thermodynamic thermodilution method, we can't really get even through the RHC the compliance part of it. So arterial compliance permits passive arterial expansion during ventricular systole to accommodate much of the stroke volume and enable arterial recoil, thus continuing blood flow during diastole. That is the basis behind what we know. So compliance is calculated as a change in cross-sectional area or volume over change in the pressure at a fixed vessel length. So of course, with change in vessel length, meaning change in lobar segments with any disease, especially type 3 or anything else, we could see that we may not really capture the essence of the pathophysiology just by looking at the central pulmonary arteries or the branch pulmonary arteries, because there is so much more, as we would see in the next few slides, the importance of pulmonary arterial compliance. Yeah. So passive arterial expansion buffers the ventricular contraction through the coupling, maintaining the low pressure and low pulsatile cardiac load, and this is especially more important on the right heart side. So loss of arterial compliance increases pulse pressure, pulsatile arterial load, and then pulse wave velocity. So that causes the premature wave reflections, and that is what really affects the RV performance over time. So this is, I guess, a table from one of the annals of ATS from 2016, where this is all well known in textbooks, right? So we know the basic difference between the pulmonary circulation and the systemic circulation, as you see in the second column here. So the location of vascular compliance, the 20% of the compliance is in main and and the branch pulmonary arteries. 80% is located beyond the first branches, right? As opposed to 80% of the compliance in the proximal conduit vessels in the systemic circulation. And then there are all these values what would be clearly different. So RV, as we know, is clearly working against a low pressure system as opposed to the left ventricle. Now, again, this is just a continuation of what we just talked about. If you have a decreased pulmonary artery compliance, then you will have an increased PA pulse pressure and high pulsatility. That will lead to increased RV workload, which will eventually lead to RV uncoupling and RV dysfunction. Of course, there are molecular pathways how it would be. There would be a multitude of factors which would affect the pulmonary artery compliance. So with this, let's just go back to the imaging part of how we would look at this disease. It's not just from a cardiologist perspective, but that's how I would look at it, as in terms of either echo or an MRI. Basically, we are looking at the same imaging changes based on the modality what we see. Some of these are already well proven and well known in terms of decreasing RV, fractional area change, or decreasing TAPC is well known, and then increasing IVC diameter and all. And again, once we start looking into more things, we would know which is improving versus which is worsening. Of course, we would not look into the changes in the imaging as a standalone modality, right? So we would just have to put into perspective where the patient's trajectory is in terms of the disease. Now, the mismatch between RV's ability to contract and the afterload it needs to overcome is really what, the basis behind what we look at as RV to PA coupling. So now, again, I would not go into more of these details in terms of, I think everyone would be familiar with how the RV changes and in terms of volume and function and all. So now, since we have advanced imaging modalities, and how do we extrapolate that information to the actual patient? So if we look at the coupling as, the ratio of stroke volume versus end systolic volume is what we would be looking at if you go back to the previous slide in terms of, how the end diastolic, and systolic pressure, this curve would keep on shifting rightward, right? That is where the uncoupling would really come up to. So by echo, conventionally what we call the ratio of TAPC versus RV systolic pressure, that is a crude estimation of the coupling. So what is a normal coupling efficiency? So in a normal person, if you look at these numbers, it would be 1.5 to 2. Now, early signs of maladaptive remodeling. Say, because we always, as clinicians, we want to look at certain numbers and thresholds and see, right? Because that is the human nature of, cutting to things. Although intuitively we would be looking at many other things, but we always want to rely on, what is the LVEF, or what is the NT-proBNP? We want to look at as a binary outcome, although it may not work that way. But still, for estimation of end systolic versus arterial compliance for the coupling, the normal coupling would be 1.5 to 2. The early signs of maladaptive remodeling would be 0.89 to 1.1 rather. So severe RV maladaptation, you're really looking at 0.6. So if you take a cutoff of 0.8 with an RVEF of less than 35, you're really, by definition, you have a complete uncoupling of RV to PA. So this is just one way of looking at things from one imaging perspective. But it just gives you, and if you start looking at patients and see where you are and how they behave, it is totally, there's a total disconnect. A patient would just deny symptoms, they'll be completely functional. If you look at their imaging, and if you go by this classification, you would not even freeze that, they are in advanced disease, right? But we know that what is the survival, 2 years, 3 years down the line, they would be dead, right? So, now, let's just, I'll just show you some examples of what we have seen. Now the normal end systolic volume index would be 30 to 60, and stroke volume index would be 15 to 48. So let's just quickly look into these, patients. The 17-year-old, has an RVEF of 51, and, the coupling ratio is still 1.1. So, early maladaptation, but still well preserved. As opposed to these two patients, they are already in an advanced disease. A 20-year-old and a 26-year-old, you look at their disease duration. This 26-year-old has only a 2-year duration of symptoms. Her LVEF is 28. Her, going by conventional criteria, she is well beyond uncoupled. She has presented 26-year-old, right? So, let's look at this 39-year-old. So, each patient would behave differently, and it also brings into, how well they have been compliant with the medications and whether there are associated comorbidities and all. So this is just a perspective of, what are we looking at when we start keeping that lens deeper into the patient, right? So one idea to take home, progressive vasculopathy, remodeling and, PA pressures eventually leads to RV failure. And that is a predominant determinant of outcomes across age groups. So accurate non-invasive assessment of RV to PA interaction would be central to risk factors. So RV PA coupling, would be a robust prognostic marker and including the RV compliance. So with this background, what we did was we just picked up over, 3-4 years, children and young adults, about 36 patients with a prospective, cohort study. The average, mean age was 14 with a female sex of 55%, right? And half of them were idiopathic PH and some were, genetically proven, and only 2 or 3 had CHD repair in their infancy, although technically they would still be group 1 PH because, some of the CHDs, clearly they have increased predisposition to PH, but a 3-year-old or a 4-year-old rather, ASD with no PH undergoing ASD closure, there is no way to tell in this current era, at 20 years later, he would have primary PH. So again, we have a variety of baseline therapies and what is their functional class. Most of them were class 2 to 3, and their 6-minute walk distance was a mean of 400. Now, if you look at this echo and cardiac MRI parameters, you look at this, LV ejection fraction being preserved. So echo-derived RV to PA coupling, they are way down, right? 0.2, you have mean. And then again, MRI-derived coupling, you have 0.6. So nearly the mean RV to PA coupling ratio in our population is 0.6. By conventional definition, they are well beyond uncoupling, right? Again, every one of these have undergone echo, cath, MRI, and all the conventional metrics, and that is what we have included, right? So you look at their, compliance numbers, 1.5. You really need to have more than 2.5 to have a normal compliance. So their outcome, 1 year survival is, at this point is 100%, but at 3 year survival is 95% in this category. So when you, study the multivariate model, only the PA compliance was really the determinant of, their disease progression, irrespective of what their MRI volumes and function were. So what we really found was when we screened, a group of, children and young adults, and you use a multimodality assessment of an echo, MRI, right heart cath, NT-proBNP, 6-minute walk test, CMR-derived, volumetric parameters are definitely complementary, and it would just tell you, how advanced their disease trajectory is. Yeah. Again, I think everyone is familiar with what is a low-risk status in a PH patient, right? So, absence or minimum symptoms, preserved 6-minute walk test, and RVEF definitely more than 45, and right atrial pressure less than 8. So what do? I don't think we do much differently compared to what established protocols say. We just have a more coordinated team where we are in constant discussion with whether this patient is in the overall trajectory of their disease. Are they in a euvolemic and a stable state? Are they worsening? Should we do something different, or at least should we start talking about any advanced therapies? So, especially related to transplant. Of course, there are experimental therapies in terms of atrial flow regulator. We have recently published a small series of patients as well, but the device itself is not widely available, so it is not standard of care, at least in our treatment. And occasionally we have done port stent, although the procedural risk sometimes prohibits doing us in most of the patients. So I think everyone would be familiar with the dual therapy being the standard of care and all those things. So I will just end this talk with what I see in a patient, when a 18-year-old or a 24-year-old or even a 10-year-old comes in with, they're already pre-screened because of variety of things that they come with symptoms, and we know that what likely they have as a primary group 1 PH. So clinical and history exam, echo, definitely all the parameters, not only for baseline but on follow-up. As long as it is done in a dedicated and reproducible manner, echo is still fairly accurate, I would say. MRI, if you have ability to do it properly with protocols and interpret, and then discuss with the radiologist what it really means. Because there are many things which it would go into numbers. You can't just look at the EF and say, because if there is a lot of TR or PR, have they looked at forward flow in terms of cardiac output, and not just look at the difference between the end diastolic versus end systolic volume, because that's not what we are really looking for. Do they really mean what they report is what, as a clinician, you would want to ask the radiologist? Because that's what essentially it comes up to. When they say RV, because most of your patients, when you see an MRI, they would be in the 30s. We probably wouldn't be doing an MRI with the patient 45% and above, because they're probably too early in the disease. So when a well-looking patient with class 1 symptoms, with a low NT-proBNP, with a high 6-minute walk test, gets an MRI report of RVE of 25, which is by default what we see, 25 to 30%. Is that what they really mean? I mean, then you can look at the value of regurgitation. So they would be surprised to know, yes, the disease is progressing, just that we don't get to see it from outside. Yeah. So again, RHC, right? As long as it's properly done in terms of, by default, we don't use general anesthesia. We just with IV sedation, we do enter the left heart just because of logistics of not having a 7 French, balloon catheter and all. So we do both right and left heart cath by default, and only with IV sedation with nitric. And of course, laboratory tests, 6-minute walk test, and we almost do, the ability to get genetic tests is again, based on availability and, affordability and all, but 2/3 of the patients do get, end up getting, a whole exome. So this is our way of, doing things, and I'll be happy to, take any questions or, listen to others in terms of what they do differently in terms of trying to understand this chronic condition where the patients, as long as they come to follow up at a certain place, they should be well cared of. The problem with our fragmented healthcare is, first of all, affordability of the medications. It can easily cost more than 10 to 15,000 per month if they are taking it really, strictly, right? Dose titration and tests, and so it is not an easy disease to treat anyway. Especially, distance and many other things come into play. In any reasonable either government or private setup, to do all the tests, still come back and have a closure on that particular patient within that 5 to 10 minutes is a big challenge for any chronic condition. So, thank you.
Okay, thank you. So, I have one question. So, in respect to the pediatric patient, so what should be the target while dealing for PH, whether it is a normalization of pulmonary resistance or it's restoration of RVPA coupling?
Sorry, please, can you please repeat?
So, yes, while dealing with pulmonary artery hypertension in pediatric patients, so what should be the target? Is just normalization of pulmonary resistance or restoration of RVPA coupling?
See, the beauty with younger population, clearly, you would have seen, even if we label them as group 1 PH, a good portion of them may have just responded to, a thiamine, for example, or correction of some other, either nutrient deficiency or something which we really did not really prove on biochemical or other parameters. So it's really not a big deal to even, know what is their initial trajectories in the young age, less than 10 or even 12 years of age. It really comes up to once they cross, 14, 15 years, and once they start having, the progression of disease by conventional assessment, that is where the challenge would be. So, if the answer is, are we looking at hemodynamic parameters for improvement? No. What we really want to know is, if a patient comes in as a new, where do they stand in terms of their disease compared to what they say they felt it? And whether you do advanced imaging or cath, probably we don't do that in the first go. We would just make sure they come back for follow-up on proper therapy. So by default, our practice is really not to do advanced imaging or cath on the first go for any patient, unless they show compliance with medications and follow-up. Because, mainly for procedural risk, almost we avoid doing a right heart cath on the first go. So if they are a well-established patient from outside, they come in for proper follow-up, because doing, trying to understand the disease in a deeper way, yes, clearly it helps the clinician, but does it help the patient? Unless they come for follow-up, it doesn't really mean much. Right? They may come for second opinion. Yes, I don't see a value personally to do all the advanced tests and then give an opinion. If they do come for follow-up, yes, it helps me to understand how can them be managed better in terms of either, disease-modifying agent or whatever.
Thank you. Any question from?
What's the problem in whole exome genome sequencing? I think your Center for Pulmonary Hypertension, without knowing the genetic profiling of the patient, I think it should be a standard of care to do a genetic profiling. Each test will cost, right? Because, of course, the cost, patient is more important, because if you see the drugs and all those things, now there's a lot of data. If some gene is there, this drug will work or not. The genetic in some of the, a lot of data.
So by default, we do offer,
Yeah.
them to do, but we just don't have a subsidized way for genetic testing because it is still outsourced to outside laboratories. So a whole exome would cost about 19,000. So yes, if that cost can be absorbed, it's, they would definitely do that. Yes,
Yes, because we are doing it at 16,000, we have in-house facility
Yes, correct,
at
yeah.
Common India.
Yeah. Thank you.
Thank you, respected speaker and chairpersons. Kindly collect your mementos from the felicitation desk located outside. For the next session on surgical intervention in pulmonary thromboembolic disease, I would like to invite our chairpersons, Dr. Basha Khan sir, Director of Lung Transplant Unit, Narayana Health, Bengaluru, Dr. Rahul Chandola sir, Senior Cardiothoracic and Lung Transplant Surgeon, PSRI Hospital, New Delhi, and Dr. Amrish Kumar sir, Professor and Head of Department, Department of Vascular Surgery, King George's Medical University.
I would like to invite Dr. Julius. Julius is our lead transplant surgeon for heart, lung, and transplant. And with Dr. Devi Shetty, sir, and Dr. Julius, they have another special interest for PTE surgery, and we are proud to share with you what we have achieved during last 20 years and where we are standing in current practice in comparison to other transplant center. Let's listen from Dr. Julius. Thank you.
Thank you. Thank you for the introduction. And I thank the organizers for the opportunity to speak here. Shashi was asking who is the best specialist to deal with pulmonary hypertension. Is it pulmonologist? Is it now that there is more than one cardiac surgeon in the audience, I would say it is the cardiac surgeon who is best, because we are the only specialty who can cure it. At least some of them. Well, when we look at CTEF, we thought we are curing them, but now we don't think we are actually curing them. But they are symptom-free and they are well for many, many years to come. Okay? So, like it is customary to define what you're talking about, regardless of how many times it's been said before. To define CTEF, we know that it is a precapillary pulmonary hypertension that has been said extensively today, so I'm not going to go into the details of that and the thresholds of that. But what I want to impress upon you is that the CTEF is a consequence of incomplete resolution, because from the number of people who have acute PE, only about 5% are going to get CTEF. It is not a large number. It is not a problem of thrombosis, it is more of a problem of incomplete resolution, because most people will resolve their acute PEs. And this gets progressively organized into fibrotic tissue, and that causes the obstruction. So in order to make the diagnosis, we know the precapillary thresholds, and we also need to have an abnormal VQ scan with at least one segment which shows mismatch perfusion defects, and also the typical findings on CT or other imaging modalities. This has to be done after 3 months of supervised anticoagulation, which is important to distinguish between subacute PE and chronic or CTEF. We make our diagnosis and treatment planning on by using a multidisciplinary approach, which Dr. Basha usually heads. And I'm not going through the diagnostic modalities now, because subsequent talk by Dr. Bhagirath, he would show very nice moving images of various diagnostics, so I don't want to repeat that. Now, the main question we ask in the MDT is there pulmonary hypertension, and is CTEF the cause of the pulmonary hypertension? Clearly, if CTEF is not the cause of the pulmonary hypertension, by doing the operation, their PA pressures are not going to come down. If it is, and we do get caught from time to time with people who've got, say, in situ thrombus. They look very much like CTEF, but primarily they've got group 1 pH with some thrombosis in their PA. This used to happen to us more often many years ago, but now the incidence of these wrong diagnoses has come down with experience. In the other assessment, what we have to look for is if the disease is surgically accessible or not. And the million-dollar question is there distal pulmonary arteriopathy? This is something which is very, very difficult to assess with certainty. And we did have a question earlier with the ILD talk, that if you have thrombosis or CTEF with ILD, can we offer surgery? Now, if you look at the only absolute contraindication for PTE, it is parenchymal lung disease. So if your VQ scan does not show ventilation, you're not going to gain anything by opening the artery which supplies that area. So VQ scan, one way or the other, the gold standard is SPECT, but we now do a CT-based perfusion scan. The MDT, we try to choose what is the best modality for treatment, and sometimes we may have to do a hybrid approach. If you look at more proximal disease, it can be easily accessed by surgery. And as we go further distally, so as you go down to subsegmental level, it can be operated on, but not every center will take up pure subsegmental disease. And what works with the microvascular disease is medical therapy. We are not going to be able to directly address the microvascular disease. And there is a component of this disease which affects the vessels which are less than 500 microns in diameter. So that cannot be treated by anything other than medicines. We'll have more on BPA later, so I'm not going through that. Surgically speaking, you can classify this into various levels. Level 0 would mean that there is no disease, which means you have pulmonary hypertension and CTF is really not the cause. You may have something else which is causing the pulmonary hypertension. Level 1 would start in the main pulmonary arteries or the LPA, RPA, that kind of main branches. And if there is complete occlusion, one would call it 1C. It's usually seen on one side when it occurs. Level 2 would be the lobar arteries, and 3 would be segmental, and level 4 would be subsegmental arteries. I want to re-emphasize that this is a surgical classification. It is not imaging-based classification, but we try and do that on imaging to give us an idea of what kind of disease we are dealing with. These are surgical specimens based on the same classification. If you look at this level 4, there is disease that is starting only at the subsegmental level, which means when you open the pulmonary artery, it is going to look normal. There will be no disease at all. Based on imaging, you have to know where the disease is, and I'll come to that later. There are some favorable risk factors when you're taking a patient for surgery. Particularly in centers which are starting a program, it might be more sensible to take a lower risk group. So the important thing is the PVR should be less than 1,000, and above 1,200, it is not a contraindication, but the risk would be higher to have persistent pulmonary hypertension. So if somebody's got DVT and PE history, that would be good. And also, what we look for is if there is concordance of all the imaging modalities. If there is concordance, it would be a lower risk group. If there is no concordance, like if the CT is showing something, angio is showing something else, and also when the pulmonary pressure is disproportionately elevated to the amount of disease you see, then you would worry about it. We follow the San Diego technique. Generally, this is the technique which is followed in most centers, but there are other techniques also which are described. So this involves doing the operation on, we go on cardiopulmonary bypass and cool down the patient's temperature to about 18 or 17 degrees and stop the circulation. And this is done on total circulatory arrest, which usually lasts for 20 minutes on one side. Then we reperfuse for about 10 to 15 minutes. Then we do another TCA and do the other side. We do not use a cross clamp since 2018 or so. And you can put the incisions, I'll show you where the incisions are made. And first you have to remove all the intraluminal clots. That is only a step towards PTE. The real obstruction is the fibrosis or fibrotic layer which is adherent to the wall. That needs to be removed in order to, by removing the intraluminal clots, that is basically like an embolectomy. That is not going to solve the problem. You have to go in and remove the fibrotic tissue completely. As you saw in these specimens, you can see how it goes into the subsect. Even if it's level 1, it just means it starts there, but it still goes all the way to subsegmental arteries. And that has to be removed because the real obstruction is there. You will need a lot of monitoring during the operation. We have TE, have hemodynamic monitoring. We do ultrafiltration on everyone. You can see that this is the preoperative pressure, which is 38 in the PA mean pressure. You can see that the PA is distended and tense, RA is distended and tense, and we do an aortic cannulation. And another thing is almost all patients should have a right heart cath, but sometimes we are reluctant to do a right heart cath because there are clots in the veins and clots in the RA and all that. So we do an all-table cath at that time, because we are part of the registry, the international registry for CTEF. It is a worldwide registry, and 26 countries are participating in that. We cannot submit entries there without a cath, so we have to do a cath. And I personally believe every patient should have a cath. And we've had some difficulties with cath in these situations. That's why we do it on the table. Either we put the PA catheter just before surgery and then just take an LA pressure measurement. So this is the pulmonary artery being incised. This might interest only the two surgeons who are sitting on the dais. It may not make a lot of difference to many others. So anyway, this is the, okay, that's the aorta, and the SVC is moved this side, and that is where you would make the incision on the right pulmonary artery. And the incision is extended. Taken stay sutures, and then you can see this instrument is a specific suction aspirator, dissector, which is designed for this operation. So what is happening here is to try and develop the plane of dissection like this. See, you need to get this plane of dissection. Once you get into this plane, you just have to follow it distally, and that is the plane of endarterectomy. You have to sort of go all the way. The incision is only here. So from there, you have to go all the way down and remove these. And you don't put much traction on it. And remember, the PAs are very thin. It's very easy to injure it. And if you injure the PA, it's going to bleed quite badly. This is the left pulmonary artery incision, which goes from the main pulmonary artery into the left. You can see the PA catheter, which we temporarily withdraw. And how much ever suctions you use, because of the bronchopulmonary collaterals, you'll have a lot of return. That is the reason why we go on total circulatory arrest. And once you raise the plane, you have to follow it down. See the fibrous tissue? This is an angioscopic view. We don't use this for surgery, it's just for demo. So you have to remove the tissue like that. Sometimes you might find that there is injury to the pulmonary artery. This is a technique which we have developed, that we fill the pulmonary artery with water and ventilate hard. So if there is injury, you'll see bubbles coming out. So if there is air coming into the pulmonary artery, blood is going to go into the airway. It's very simple logic. These are some of our specimens. You can see how far distally you have to go in order to get the clearance. There are some specific complications which are there in this operation. One is intraoperative airway bleeding. I showed you how we look for it. And it can also happen from rupture of either from the rupture of the pulmonary artery or from aortopulmonary collaterals. So if we know for sure that it is not a ruptured pulmonary artery, we shift the patient from theater directly to the cath lab and embolize these collaterals. The next major complication is reperfusion edema, which can usually occur within 72 hours, but occasionally it can be there afterwards also. RV failure is something which we rarely see, but it can happen. The same thing, you would find the PA pressure to be low and the CVP to be very high. You would think that you did a very good operation when you look at the PA pressure, but that's because the RV is not generating any pressure. Persistent pH is one of the problems which we don't have a real solution for. And it is not clearly defined, but if your PVR at the end of the operation is more than 500, you could call it, that indicates poor prognosis on the longer term. So If you can't come off bypass, the only way is to go on ECMO, and then maybe 1 or 2 attempts at coming off ECMO in the next couple of days. Usually the results are pretty poor if you use ECMO in these. You may just have to bridge them to transplant. But that is much easier said than done. You may not be able to logistically do that in a short while. So this is the airway bleeding I showed you earlier. So if we have a bleed, we identify where the bleed is from and pack that segment off with Surgicel. And then that would stop the bleeding. We got this technique published in Annals in 2015. You can see once you pack, there is no air coming out. We use a bronchial blocker to isolate the lung that is bleeding. And if you're looking at subsegmental disease, as I told you before, when you open the PA, there will be nothing in it. There will be no clots, no thickening. It will look absolutely normal. So you have to raise a plane in the normal intima and then follow it down in order to remove all the tapering ends from that. There is also there is a lot of nomenclature changes which has happened in the recent past. Anyway, it is now CTE PD with or without pH. So in the set called CTED or CTE PD without pH, there is all features of the disease, but the pulmonary pressures are normal. Nobody is very clear what is to be done with them. If somebody is symptomatic, maybe there is a good reason to do it. And aggressively treating these patients have not stood the test of time to say that that will lead to pulmonary hypertension otherwise. So we don't really know much about the natural history. The guidelines are also kind of vague about you may offer them surgery or BPA in good centers. BPA, I think there's a whole talk coming up for that. And targeted medical therapy, well, we've had a whole day talking about therapy, but as far as CTEF is concerned, from a surgeon's point of view, I would say it's pretty useless. The treatment for CTEF is surgery, and surgery, and surgery. If the patient is inoperable for reasons like comorbidities or other reasons like inaccessibility, then riociguat might be of some use. Bridging therapy prior to pulmonary endarterectomy should not be offered because that can change the quality of the fibrous tissue which we deal with and it make it brittle, so it becomes harder to take that out. This is not published data, it is an observation made by Dr. Madani who has the largest series in the world at the moment. And the other indications is that if there is recurrent disease after surgery or BPA, and BPA can be considered in these patients if they are eligible. This is the statistics of our journey. We started off by, in 2004, I think out of the 2 cases we did, 1 died, so pretty bad mortality. And the last year we did about 77 cases and we had 1 death in that. So it is also shown that centers which do more than 50 cases per year would have a better outcome. So we have crossed 1,000 cases now, and now the last year's mortality was quite same as what you would find in the West. So in summary, CTEF is not really a rare disease. That's what we thought in the past. We do see, if we are doing 2 or 3 a week, it is really not a rare disease. So that is what kind of volume we have now. We do somewhere between 70 and 100 cases. This year we probably would do about 100. There is fibrotic material obstructing the main arteries, and there is a secondary microvasculopathy, which is something which we can't do much about. And the longer the disease has existed, the higher amount of microvasculopathy you will have. So it is important to offer surgery to these patients early, rather than 10 years of suffering this. We don't really know the entire mechanism how this clots become fibrotic tissue and in whom it will happen. As I've told earlier, only in about 5 to 7% the CTEF happens following a PE. And so now we say that CTEPH has an association with PE. It is not necessarily a consequence. You might even have a lot of patients who do not give any history of PE. So it is important a patient is referred early to a center. It has now become a class 1 indication, and it is important to have a MDT approach to that. And these centers which offer surgery should also be able to provide ECMO, should be able to provide balloon pulmonary angioplasty, and have experts like Dr. Basha who treats pulmonary hypertension otherwise. So currently our mortality rates are comparable with the major centers in Europe. There are only 2 centers in the world who does more than us. One is Papworth, one is San Diego. So we have also got to that level now. And thank you. If there's any questions, you can see the difference that happens immediately post-op. That is the peer pressure at induction. This is after the surgery. PVRI here is from 1,488, it's come down to 187. It will further reduce over the next couple of months. Thank you.
Excellent presentation, Dr. Julius. I have 2 questions. One is, your approach to cases with subsegmental or segmental, CTEPH. How do you approach these patients?
If it is purely subsegmental, as of now, we are trying to do BPA on them. We don't offer them surgery as the first choice. But on the other hand, you might find that one lung has got, level 1 disease, and the other lung has got subsegmental disease. Those we operate. Or maybe some lobe has got only very distal disease, and usually the lower lobe will have a lot of disease. That once you see that there is bilateral lower lobe disease with segmental or subsegmental disease in the upper lobe, we take them up for surgery and do surgically resect those lesions.
And the other thing is the technique that you showed there, for the bleeding PA.
Yeah.
Can you just rewind that? Just wanted to see that, what exactly is it? Just brief, 1 sentence. Was there something special that you're doing?
No, it's nothing. See, you just ventilate hard.
Okay.
Fill the PA with water or saline, and then ventilate hard.
And see the bubbles there.
And see, once you see bubbling, initially some bubble will come because it's empty.
Right.
So once you empty that, if there's a stream of bubbles coming, then you know there's an injury. So then you look around to see which vessel it is coming from. Find out as distal as you can as to which vessel and then plug it with Surgicel.
Sure. The other thing is you mentioned about this doing hypothermic arrest, twice, Do you rewarm,
No.
again after doing one lung?
We don't rewarm.
Okay.
So we cool down to 18.
And then you go on bypass again, and then...
and then once you arrest, at the end of 20 minutes, you have to reperfuse.
Right.
So you put the pump back on, wait for 10 minutes or 15 minutes, and then for the other side, so if you want to take more time on you can have a second arrest also for the same side. So if it is distal disease, usually you will not be able to take out everything in one arrest period. So you might have a second arrest in the same side, then you go to the other side and arrest again.
Right. Okay. So an area of a time period of perfusion in between there.
Yes.
Okay. Okay. What's your safe limit for circ arrest there?
20 minutes.
So you don't go beyond 20 minutes. Okay. And
So
you cool till
if at 20
26 or 18?
No, 18. If
18?
If at 20 minutes you are just finishing, we might just take another minute and finish it.
Right.
But again, if you know that this is not going to be one arrest, then we stop at 15.
Yeah.
And then do another arrest so that, at 15 we reperfuse. And then again, so we reperfuse for 10 minutes. And then we do another 15. And then reperfuse another 10 minutes.
Right. I get it. So any advantage of going below 26 degrees in circ arrest? Because 20 minutes you can easily
18.
do on 26 degrees also, isn't it?
One is Basically, it's for protection.
Yeah.
That's 20 minutes, 26 is probably not a good idea.
Generally, if you see, the aortic surgery, all the complex surgeries that we do, we don't go beyond 26 degrees, and easily we can go up to, half an hour on 26 degrees, circle rest.
No, anyway, in PT, it is not considered safe to do anything more than 20 minutes at a time. And some people go even lower than, there are people who go down to 15. And in spite of that, neurological problems are seen.
Yeah.
Particularly when you have multiple arrests. We have seen that anything over 60 minutes of arrest, they just have some neurological deficit immediate post-op. They tend to recover, but there was one patient I did in Chennai, I took 6 arrests in all. That patient had chorioathetosis for 6 months, and then it got better. But neurological problems do happen. And if you look at the list, we don't see so much neurological complications in our series because we are not doing 70, 80-year-olds much.
Yeah.
But when you're doing older people, you would probably have more problems with that.
Yeah, so thank you, Dr. Julius. It is indeed a quite complex disease. So CTEF, they don't come to us just with the diagnosis of CTEF. They have a lot of comorbidities at the same time. So around 20 to 30% will come with decompensation of their RV failure. So another 20-30% come with severe bleeding. Another 20-30% comes with underlying APLA or SLE, which is not diagnosed previously, and they are having thrombocytopenia, active lupus. So it takes a lot of time for us to prepare. He cannot go for a surgery if he's having platelets of 50,000 with active lupus. So then another fourth group challenge we see is they are having infections. Either they are having active fungal infection because you are having a low blood supply in that part of the lung, and this is a perfect source to get a fungal infection, active aspergillus and all those things, or active TB. So it's a complex disease. What I'm trying to say that you need a team to reach this level. Individually, it is very difficult to achieve those targets. Thank you.
Yeah, one last thing. I want to thank the organizers for providing this footstep. Otherwise, I wouldn't have been visible from the audience side.
Sorry, Dr. Julius, can you wait? Any questions from audience?
Step back on the podium.
Dr. Julius, how many patients you are finding the EVT, because what it is resembling something that post-rheumatic syndromes, which we see.
I'm sorry, I didn't get the question.
I'm saying that like we see the post-rheumatic syndromes,
Okay.
the DVTs, the number of them people coming with the mechanical blocks along with it. How many of these cases which you are operating with CTEF have this sort of a problem? Because to me, these two things, to an extent, look similar because this is the consequence or a sequence or sequelae, of thrombosis. Because we take the one disease.
Yeah, if you look at these people who have problems like DVT, they have acute PE. We never operate them for acute PE. We will, if they are crashing or something like that, we put them on ECMO and wait. Most of them will not require surgery, as the natural history of PE is resolution. But many people present with an acute PE in a background of CTEF. If we see that there is a component of chronic disease, then we operate without trying to take them off ECMO. Now, if you look at the leg-related problems on the patients we operate on, nearly 50% will have either history of DVT or some kind of venous incompetence or something like that. But we don't really deal with that. We don't use a filter. We use a filter only if there's a contraindication to anticoagulation, which is the recommendation now.
Standard.
So we don't use a filter at all. And if there is a thrombus in the IVC or RA, we take that out. As in IVC where it is accessible from the RA. But otherwise, we don't really go to the leg and do anything there.
If there are no any further questions, we would like to conclude the session. Thank you everyone for actively participating. Thank you.
Thank you, distinguished speaker and chairpersons. Kindly collect your mementos from the felicitation counter. Our next session, which is a remote session, will be on updates in diagnosis and updates on the diagnosis and treatment of chronic thromboembolic pulmonary hypertension. To chair this session, may I invite Dr. Ashok Yadav sir, retired senior pulmonologist, Balrampur Hospital, and Dr. Yash Javeri sir, Professor, Department of Radiodiagnosis, King George's Medical University. Welcome, sir.
Good afternoon, everyone. Welcome to this session. The speaker is Dr. Syed Rehan Qadri. Dr. Syed is at Mayo University Hospital in Ireland, consultant in respiratory medicine. He'll be giving an update on CTPH. We can start the talk.
Thank you for having me here, and I'm delighted to present today. I'm sorry that I wasn't able to come real time. This is the second time I've missed out on Lucknow. First time the Intermartinia football tournament between La Martiniere, Calcutta and Lucknow, where I had a sprain and hence couldn't come, and unfortunately couldn't take part. Hopefully one day I will come. So I am Rehan Qadri, and I have an interest in pulmonary hypertension, particularly chronic thromboembolic pulmonary hypertension. And I'd like to share my experience with you. And today's topic is updates in the diagnosis and treatment of chronic thromboembolic pulmonary hypertension without focusing much on the treatment, particularly surgery and balloon pulmonary angioplasty, because Dr. Punin has already spoken about PTE. And Dr. Bhagirath is going to speak about balloon pulmonary angioplasty. But I'll give you an overall summary and a bit of updates about where things are going. So we know that we've discussed about the classification of pulmonary hypertension, and you know about the 5 groups. And the 4th group, which we are talking about, is pulmonary hypertension associated with pulmonary artery obstruction. That is, one of them is chronic thromboembolic pulmonary hypertension. We know it's rare, but if you have pulmonary hypertension, this is the best one to have, because significant treatment options have evolved over the last 20 years and are available with excellent prognosis in selected cases. And as you know, there are 3 multimodality treatment options available. As Dr. Punin said, surgical therapy, that is pulmonary endarterectomy. So if someone is a candidate for surgery, that is the best outcome in significant proportion of cases. In the past, it was said it was a cure, but it's not a complete cure, but a significant proportion, almost 50% of the patients do very well, particularly mean pulmonary artery pressure coming below 25. Others also symptomatically improve, but it's not a complete cure, but really good results. And evolution of new treatment options, including balloon pulmonary angioplasty, which has come up particularly since 2014 and more so over 2018. So it's very new. It started in Japan and it's getting better. And medications, there were no medications for the treatment of CTEPH in the past, and now we have one drug which I'm going to discuss, and then a few more drugs have been shown to be working in RCTs, which we may use. So now, how do you define it? Somebody who has a right heart catheter and has a confirmed mean pulmonary artery pressure greater than 20, PVR greater than 2 Wood units, as well as a wedge of less than equal to 15. VQ scan confirming a major defect or a CTPA or an invasive pulmonary angiography showing significant vascular lesions. Only after 3 months of effective anticoagulation. So this is very important. So these patients should have at least had 3 months of treatment with anticoagulation, whether it's a DOAC or warfarin or low molecular weight heparin, whatever, depending on the person. After that, when these results show that the right heart catheter shows pulmonary hypertension and the imaging shows evidence of a defect, only then you can call it chronic thromboembolic pulmonary hypertension. If there is the other part where the person is symptomatic and the imaging shows but the mean pulmonary artery pressure is normal, then it would be called chronic thromboembolic pulmonary disease without pulmonary hypertension. Now, what is the incidence after a PE? We didn't know a lot, but it varied from 0.5% to 2%. So it's one of the largest studies recently done shows that it's about 2%. So 2% of the patients with acute PE in 2 years will develop pulmonary hypertension. But if you follow them up closely at 3 months and then keep on following people who are symptomatic, you will find, in this same study showed that you will find more cases and they would be less severe. So you will catch them early. So now the new guidelines or the new consensus statement post-PE follow-up is at 3 months, confirmed by ESC. Now the pathophysiology, I'm not going to go in much details, I'm just going to keep it simple. So you have DVT, from there you generally have an acute pulmonary embolism. There is obstruction. Generally it will resolve and people will be fine, but there is incomplete resolution and organization of the thrombus in the obstructed vessel. And what happens, you can see in the imaging in the forms of the wedges and the bands. And as a result of that, there is significant increase in collateral formation, and hence there is bronchopulmonary collaterals increase and the pressures increase in those distal vessels, and there is pulmonary vascular remodeling. Whereas on the other side, because blood cannot flow on this side, the remaining amount of blood, which is the entire cardiac output, flows into the pulmonary arteries, which are non-obstructive. Hence, increased flow, and as a result of that, there is pulmonary vascular remodeling. And hence, you have CTEPH. And finally, at some point, you will have right ventricular failure and death. Now, risk factors of CTEPH. So there are many risk factors that we know, well documented. Particularly history of having venous thromboembolism. We know almost 75% of patients with CTEPH have a known history of acute PE, but 25 don't, and there may be a family history as well. In terms of the thrombophilic disorders, we generally do not test almost any of them except the antiphospholipid syndrome. And why is it important? Because if it is triple positive, 3 antibodies are checked, and if all the 3 antibodies are positive, then the treatment in patients with CTEPH would be warfarin rather than a DOAC, which we generally give nowadays. You also have other associated conditions, so you need to keep in mind that patients who've had splenectomy or infected pacemaker or any inflammatory diseases, thyroid diseases, etc., have increased chance of having CTEPH. So when you're taking history, this information is very important. Now, what is the survival in CTEPH? So there was one data from the national audit in pulmonary hypertension in UK, and it clearly showed that having surgery is much better than not having surgery. Particularly, this includes people who are non-surgical disease distribution and people who've had surgical disease distribution but couldn't undergo surgery due to various reasons, including comorbidities. This is another study which shows it clearly divides people into 3 groups. That means people who had CTEPH who we've operated upon, the other who we've not operated upon but they are surgical, and the other is non-surgical. That means they are distal disease. So you can clearly see the people you've not operated upon due to whichever reasons have poor outcomes. Now, what are the clinical features? This is the main problem. The clinical features of CTEPH is very non-specific. In the study that I had performed, dyspnea, low extremity edema, and fatigue were the commonest symptoms. Almost 99% of the patient presented with dyspnea. Now, other symptoms are also there as chest pain, syncope, hemoptysis. Hemoptysis is a late presentation which we rarely see. Now, how would you diagnose this? What are the investigations that you would do? So we say that multimodality imaging techniques are used. So initially you do a perfusion imaging, VQ scan, or a new modality. Nowadays people can do MR angiograms, people can do Dept scans where they can get perfusion imaging. So you do one of them, and if you have a mismatch defect, major defect, then you do an echocardiogram. And an echocardiogram is a screening tool for pulmonary hypertension. If the echocardiogram shows intermediate or high probability, then you refer the patient to the PH center. And there they would do a CTPA. Very rarely they would do a digital subtraction angiography, only if it is not proximal or the CT scan quality is not good, and a right heart catheter. But nowadays, use of DSA, which is invasive pulmonary angiogram, has increased significantly in patients with distal disease who need a balloon pulmonary angioplasty. So it is more used over the last 8 years, particularly with the advent of balloon pulmonary angioplasty. But generally for patients who need surgery, a CTPA and a right heart catheter is enough, and the radiologist and the surgeons would be more than happy to consider. But if it is distal, then they go ahead doing the digital subtraction angiography. Once you confirm the CTEF, you consider treatment by the MDT, which I will come to you later. So this is some of the non-invasive multimodality imaging techniques. In A, you can see a perfusion scan, a part of the VQ scan, and you can see where the white arrows are. There is perfusion defects. In B, there are same patient, similar defects, but this is MR angiography. And this is a reconstructed image, and you can see the perfusion defects as well. In C, you can see some mosaic attenuation, the black arrows. And again, this is one of the features you will find in patients with CTEF. And in D, you can see a small obstructed vessel in the white arrow, and the black arrow is an infarct, which is an area of necrosis. Now, these are some of the other CTPA features. In A, you can see there is a blue arrow. You can clearly see there is an area of filling defect. In B, you can again see another area of small filling defect. In 3C, you can clearly see that the right ventricle is enlarged and the septum is shifting towards the left. And in D, you can clearly see that the ratio between the pulmonary artery trunk and the aorta pulmonary artery trunk is much larger, and there is calcification in the yellow, and in the blue line you can see the filling defect. And in E, you can see in the blue line again the same thing. The blue shows area of more perfusion, and the green arrow shows it's more dark area of less perfusion, and it looks like mosaic attenuation. And in F, again, you see a large pulmonary artery trunk, much larger than the aorta, and of course larger than 3 centimeters in size. These are some of the examples, and you can see some of them are subtle, some of them are obvious. Now, this is a pulmonary hypertension mimic. I'm just wondering how to start it. Okay, got it. So if you have a look, I was in Papworth, and they were doing a pulmonary endarterectomy surgery, and I was going through the scan, and this is what I found. This patient did not have a right heart catheter, and they could not diagnose CTEF in that perspective. This is a pulmonary artery sarcoma. This is one of the mimics of CTEF. The ideal treatment was if the biopsy was sent and it was correct, the appropriate chemotherapy if it was used, and the patient may do well. But otherwise, the outcome is generally very poor. Then the other investigations that is done, again, rarely, only, again, now it's a bit more common than since 2018 with the advent of balloon pulmonary angioplasty. You have the pulmonary angiograms. This could be done by the radiologist, or it can be done by the interventional cardiologist in the cath lab. And you have, again, the right side had 10 segments and the left side has 9 segments, exactly same as the segments of the lung. And you can see each of them. You initially do one of them, which you will show everything, and then you go at a segmental level and check, and based on that you will make your decision. Now, management strategy in CTEF. You've heard about the surgery, etc. I'm not going to go into details about that. Basically, patients are on mainstay of treatment is anticoagulation. Generally, it is warfarin is best, but because of the inconvenience, a significant proportion of patients take DOACs. The recommendation is that only if you're triple antibody positive for antiphospholipid syndrome, only then warfarin is a must. Otherwise, you can choose whichever you are happy with. Then you discuss at an MDT, and particularly in Papworth in the MDT, you will have the surgeon, you will have the physician, you will have the radiologists, you will have the BPA operators, you will have the coordinator and the nurses. They will all sit together and they will discuss, they will look at the history, they will look at the scans, right heart catheter results, and they will, initially the choice is pulmonary endarterectomy the choice. If great, yes, they will go ahead. And if it's a no, then the BPA operators will advise whether, based on the invasive pulmonary angiogram, whether BPA is an option, or just medications. In patients who already had pulmonary endarterectomy and they still have high pressures, for them they will just provide medications. And then in patients with both BPA, CTEF, whatever, when they've had surgery, they are long-term follow-up. If your pressures normalize in UK, not in other places, but in UK, they follow the patients up for up to 5 years and then discharge them. So this is more or less the thing, but the main thing is if the patient is for PEA, and as the treatment of choice, that will have the best effect, and that has the maximum amount of evidence. I'm not going to go into details about PEA because it has already been discussed. So what do you do? As per the guidelines, if it is proximal disease, you will do surgery. If it is a bit more distal, you will do balloon pulmonary angioplasty. And if it is microvascular, you will treat with medications. It's not that simple. As Dr. Punin said, that patients in India, patients in UK, and patients in California, if they were seen in the clinic and in the MDT, even if they had slight distal disease, they would have pulmonary endarterectomy with excellent outcomes. Whereas if the patient was in Vienna or the patient was in Japan, even if they had a bit of a proximal disease, including the lobar arteries, they would go for balloon pulmonary angioplasty, again with similar outcomes based on data. But in India, for example, if you have someone with proximal disease, it's absolutely pulmonary endarterectomy, no questions about it. We've got excellent skill sets amongst our surgeons in Narayana, and they have continuing to do a lot of cases similar to the ones in UCSD as well as in Cambridge. Now, what are the risk factors in patients? Before you do surgery, short-term mortality is mainly the hemodynamics, and long-term mortality is mainly patients' comorbidities. This is a big study done by the Papworth group, and it clearly shows that, and they used modeling techniques, and this is what they found. Now, I'm not going into the surgery, the different levels he must have spoken to. This is the most important slide we need to know. One thing we need to go out of this is this slide, that if you are a surgical candidate and you are fit for surgery and you are offered surgery, if you do not accept surgery, decline surgery, then you have a really significantly bad outcome as compared to patients who have undergone surgery. So it is absolutely must for us to be able to counsel our patients wherever they are to consider surgery and go to the surgical unit and have a discussion with the surgeons. This is a beautiful example of a dual energy CT scan which is done at Cambridge, and I know it is also done in Bangalore. And it clearly shows in A that where the red thing is on the right side, red arrow is that there is no flow of the dye there. And even lower on in the right, left side, left lower lobe, also you can see there's nothing there. Whereas when you look at it in B, 4B, you can clearly see now there is, after the pulmonary endarterectomy surgery, flow has improved both on the right upper lobe and the left lower lobe. Similarly, when you're doing a perfusion image mapping through the Dept scan where you are reconstructing the image, you can clearly see the red arrows, both of the places it's darker, so there is no perfusion. Whereas in 4D, you can clearly see the green arrows where there is significant improvement in perfusion where the green arrows are. So pulmonary endarterectomy is great. And this is another example at 3 months after pulmonary endarterectomy, how the right ventricle has significantly reduced in size and improved and as compared to the left ventricle. You can clearly see how it's improved. A is the one before surgery and 3 months after surgery. So it's a great procedure. It's been mastered by the centers which do it. There are only a few centers of excellence, but when they do it, the results are excellent. Balloon pulmonary angioplasty, I'm not going to go into detail about that because Dr. Bhagirath is going to speak in detail about that. It's a new procedure which has been practiced since 2005 in Japan, but actually came into being since the circulation paper in 2012, where it shows this alternative method works. And then since 2014, it has been adapted in Europe, particularly Vienna. And since 2016 to 18, the other European and the North American countries are using it. Again, you can clearly see the difference that how much there are two important studies which are RCTs which confirm that this is a great thing to do. One was in Japan and the other was in France. And they clearly showed there was a significant improvement in hemodynamics in patients who underwent this procedure. And the details of the procedure and the time frames after which, in which the patients are going to be followed up will be all discussed in detail by Dr. Bhagirath. It clearly shows this is a 6-month follow-up. I wouldn't go into this. Now this just show you an example of a patient who's got complete obstruction. And the next one I am going to show is once they've had the balloon pulmonary angioplasty on that side. So in expert hands, it does a great job, and but there are very few expert centers, and people are still learning the technique, and it will take a long time to get there. Now the medical therapy finally, which we have, the only medication which is licensed is riociguat, and it works via the nitric oxide pathway, and it acts as a pulmonary vasodilator. So the chest 1 and the chest 2 trials showed that it works, and not only it works, but it maintains the walk distance and the pulmonary hemodynamics for up to 2 years. And a recent trial, including the RACE trial, which said that in patients before they undergo balloon pulmonary angioplasty, if you reduce their pressures and then you do it, their complications are much lesser. There are other medications which we can potentially use is subcut treprostinil. Of course, it is not really licensed, but the RCTs have shown that it works. And in cases where patients are doing badly despite all the treatment, they are considered more used in more used in Vienna. Apart from that, we do use in UK and Ireland, we add macitentan. There is no evidence as yet. Studies are going on along with the riociguat to improve the pressures before undergoing balloon pulmonary angioplasty or surgery, and there are studies going on to see whether that will help, and we take it from there. So in summary, CTES is a rare complication following an acute pulmonary embolism. Less than 2% will have it at 2 years. It may occur in patients without prior history of acute PE. 25% will not have history of PE. Symptoms of CTEPH are non-specific in nature. As I said, the shortness of breath, leg edema, and tiredness or fatigue are the 3 commonest symptoms. Multimodality imaging techniques are used for making a diagnosis and determining treatment options in CTEPH. I mentioned the ones, the VQ scan. There is also something called the SPECT scan. You have the MR pulmonary angiogram. You have the DSA. So all these, and there are more coming up, area detector CT, and so on and so forth. They're all coming up. And importance of early diagnosis as potentially curable treatment option in the form of PEA surgery in selected cases. So how do you do early diagnosis in patients with, now that it's come up in the consensus statement? Follow up at 3 months to see if they are symptomatic. If they are symptomatic, you consider an echo, you do a walk test, and then you want to have another week you scan, and then you take it from there. So this is the conclusion and end of my presentation. Thank you.
Thank you, Dr. Syed, for a wonderful master class. Any questions from the house? Dr. Syed, I have a question. How does this balloon angioplasty fares? What are the results? Chances of recurrence?
So they've done, it depends on where you are doing it. For example, data, recent data, the CTEF registry data has shown that nearly 50% of the patients with balloon pulmonary angioplasty 6 months after that, when their right heart catheters were measured, have a mean pulmonary artery pressure of less than 25 millimeter of mercury, and it is comparable to pulmonary endarterectomy in terms of the hemodynamics, which is also around 50% of the patients have mean pulmonary artery pressure below 25 millimeter of mercury. And even their 5-year survival is comparable. There is no statistically significant difference between the two groups. Having said that, at this point of time in India, if you have a proximal disease or distalish disease, if the surgeons are happy to operate it, that's the best treatment. We haven't yet reached a stage where balloon pulmonary angioplasty would make a difference as compared to surgery in India or in majority of the European and North American countries.
Thank you. Thanks a lot. Thank you. We'll close this session. Thank you, Dr. Syed.
Welcome.
Thank you, respected speaker and distinguished chairpersons. We now move to the next session. To chair this session, may I invite Dr. Anand Gupta, Senior Consultant Pulmonologist, Balrampur Hospital, Dr. Sulekha Saxena, Additional Professor, Department of Critical Care Medicine, KGMU, and Dr. Amit Chaudhary, Associate Professor, Department of Vascular Surgery, KGMU. Welcome, chairpersons.
Recordings.
Now the next speaker is Dr. Bhagirath Raghuranam. Sir is a Senior Consultant Director, Heart Transplant Program, and sir is in Narayana Institute of Cardiac Sciences, Bangalore. So, next lecture.
Recording in progress. Record.
because of some technical glitches, we would not be able to continue with Dr. Bhagirath sir's lecture, and we'll move on to the next session. To chair this session, I have invited Dr. Sulekha ma'am, Dr. Anand sir, and Amit Chaudhary sir. I would also like to invite Dr. Yash Javeri sir, Senior Consultant and Critical Care Expert, Regency Hospital, Lucknow. Over to you, chairpersons.
I would like to call Dr. Dhruv Chaudhary, sir. Sir is a professor and head Department of Pulmonary and Critical Care Medicine in B.D. Sharma University of Health Sciences, Rohtak, Haryana. Over to you, sir. Welcome, sir.
Thank you.
I would like to take this moment to invite Dr. Avinash Agarwal, sir, Professor and Head, Department of Critical Care Medicine, KGMU. Welcome, sir.
I hope I am visible. Thank you. Good evening, everyone, and thank you, Ved, for inviting. And in fact, it was the way you invited, I could say no to you. And it's a great pleasure to have my teacher, Dr. Ravikant. He taught us in MBBS at Rohtak, and Dr. Rajendra Prasad, whom we have worked, and dear colleague and senior colleague and friend, Dr. Kandi. I was asked, in fact, sir, last 3 weeks have been very interesting, starting with an CTD, ILD, then pulmonary vasculitis, and now obviously coming up to pulmonary hypertension, and again, it's a hybrid which we commonly see in the intensive care units. In next 20 minutes, I will quickly try to cover it up, and in a way, it is also a revision and also a relook at it, our practices, how we are doing the things. Now, obviously, since morning you have been there, but as we talk about it, basics we always talk. So now by this time, the postgraduates, little bit who have stayed back, they understand that whenever we talk in terms of pulmonary artery pressure, we talk in terms of mean pressures. And by and large, the diagnostics, though echo can give an idea and a clue, but for that you need a right heart catheterization. And there is a term which in pulmonology we all are very used to, cor pulmonale. The cor pulmonale means the effect on the right heart by the lung, and in this you have a chronic cor pulmonale, acute cor pulmonale. Chronic cor pulmonale, all of us are commonly seeing it in patients of COPD and also other patients which you know today that the pulmonary vessels affected by the lung disease. That's what we look at it and its consequences. One of the very simple things why we are talking about it and why a question which was put by Dr. Julius was, who is the best to take care of it? I think the answer is somewhere in between. It is an MDT. And the reason why I'm saying so is, if you look at the simple anatomy, the right ventricle, the heart, the left ventricle, obviously the left side of circulation and the systemic circulation, all is in series. I think that is point number one. And secondly, obviously, there is a ventricular interdependence, and the nature has done a very wonderful thing that it has conserved the space and also ensured coordinated work, because what is the output of the right ventricle becomes the preload of left ventricle. That's how, in simplicity, if we talk in terms, that's what we see. So these pressures can go gradually rise or they can rise acutely, and when you rise acutely, that is what we look at it, and that's what is called as an acute cor pulmonale. And common description is a sudden embolus or embolizations, etc., which takes place in these patients. Or if person already having a pulmonary hypertension, of which PAH is one variety which you took it as a part one. But if there is a sudden deterioration, as we were doing in internal medicine, we used to see at that time, obviously now it has gone to cardiology to a very large extent, the crisis which we used to see in fellows, etc. They were all nothing else, but it used to be an acute deterioration, patients coming up to you with an obstruction. Similarly, when you start talking in terms of the ventricular functions, there is a difference in the right ventricle and the left ventricle, but three things remains the same: preload, contractility, and afterload. And interaction of these things decide the functionality of the left side, functionality of the right side. The left side took a lot of contribution and took a lot of attention, and rightly so, but people forgot the right ventricle, which was the poor cousin. But now they are realizing that this poor cousin is as important, if not more important. I think that's fundamental, which we need to know. And obviously, we have understood now pulmonary vascular biology much more than what we used to have it. And in this, it's a low pressure, low resistance circuit. That's what we look at it, the way the nature has done it. And obviously the rest pressure mean is 10 to 20, and PVR is 10 to 20% of systemic vascular resistance. That means this is the low pressure system, that's the right pressure system. So as long as you maintain the difference between them, the perfusion of the right ventricle will also take place. So what is happening is that there is a preload, there is a contractility, there is an afterload, but there has to be another energy source which comes through the blood supply. Left, all of us know what are the supplying. Right ventricle, obviously in the cardiology, when I remember as an MD, when we were doing it, any nitrate given to any coronary leading to hypotension, think in terms of right ventricle infarction, that used to be the golden rule and still continues to hold true. So that means there will be a differentials, and we have to ensure that the pressures of the right side continue to be low if it has to be effective. Otherwise, if there is a patent foramen ovale or other thing you will see commonly is in terms of right to left shuntings or other things takes place, or compromisation of left ventricle function takes place, as the right left ventricle can cause compromise of the right ventricle functions. And this is concept today is called as the right ventricle pulmonary artery coupling. Because what is happening is from the pressure which will come up from the contraction of the right ventricle, they generate the pressure that is going to push it into the pulmonary vascular system. And obviously, the flow will always be because of pressure differentials. And here, when they contract, they have to have more pressures, and only then the flow is going to take place. As the pressure increases, as the resistance increases, you are going to see more work has to be done. And simple thing, the people go to the gym and then they make their muscles. Similarly, you can see the left ventricle has to work against a more severe, more resistance. So they are more and have to supply a larger area. So that tends to be having a little more thick muscular bundle. On the left side, you will have, the nature has done beautifully, that you have either transverse or you have small superficial circumferential which are there, and that's where the concept of TAPSE has also come up, because when it contracts, it shifts it towards the base and the apex, and then along with it there's a dilatation and the flow takes place. But the concept remains the same: preload, contractility, afterload, and the afterload is decided by the PVR resistance. And there is a difference in terms of vasculature, because lung is the only organ which receives whole cardiac output. That part we have to do. So it has a lot of adaptability. And another thing, that's why we see it, the patients who are diabetics, and today we are also talking in terms of the concept of a diabetic vasculopathy in the lungs. They tend to be more disproportionately breathless. And we are seeing multiple these reports coming on histopathology. So this coupling has to be maintained, and this coupling will only maintain that if afterload exceeds the ability of the right ventricle, it will fail. It can fail gradually, it can adapt, and that leads to RVH. But if it occurs suddenly, or already there is a disease and suddenly there is an increase in pressure, it will fail. The consequence of this is going to be low cardiac output state. And also the backward thing in terms of congestion, and the next result will be, because of ventricular interdependence, it is going to create more trouble, and it is going to create a reduction in the preload of the left ventricle, and the end result will be that there is going to be decreased stroke volume, hypotension, and shock. So this is a crisis, is then acute elevation in PVR takes place, and it overwhelms the right ventricle dysfunction. And that is why you see sudden cardiovascular collapse, profound hypoxemia, acidosis, and if untreated, cardiac arrest. And it is nearly 1/3 of the people who get this sort of a problem, they die. That's the data which is there. And this is the pathophysiology when you start looking at it in terms of pulmonary hypertensive crisis in intensive care unit. But the lung diseases cause two things: hypoxemia and hypercarbia. As a student MBBS, we remember that hypercarbia and hypoxemia, both of them can lead to intense increase in it is just a paradoxical effect what you see then in the systemic circulation. When you are having a hypercarbia systemic circulation, you will have vasodilatation. Here it will lead to pulmonary vasoconstriction. Same thing we tend to see it with an hypoxemia. Those areas where the original flow, it tends to divert towards where you are having a normal ventilation perfusion matching. Therefore, it leads to pulmonary vasoconstriction. Mechanical ventilation increases the afterload, and that is what has been utilized by the team from Tata under Dr. Sheila of looking at the fluid resuscitation or fluid management by manipulating the tidal volume and thereby manipulating the afterload in the pulmonary circulation. You can have a sepsis SARS because that can act on the vasomotor component of it. And because the muscle is also a little different in the arterioles here. So why dear friend, you find up here is it is far more less responsive to vasodilators vis-a-vis systemic circulation. So you need to have a specific drugs which are acting on it. And obviously if somebody has an acidosis, hypoxemia, anemia, and other triggers like tachycardia, they also interfere. Here it also interferes. If you have a massive volume overload, which is going to cause a massive increase in preload, you will suddenly find that the right ventricle geometry got an alteration and persons may have challenges there leading on to acute pulmonary hypertensive crisis in the ICU. And it's a vicious circle. You have a hypoxemia, hypercapnia that leads to acidosis. That acidosis leads to increase in PVR and obviously pulmonary artery pressures. You will have a further worsening RV dysfunction, decreased cardiac output, coronary perfusion, and then that's what it leads to. As the pressure goes up, the differential between the systemic and the venous pressure, right side pressures goes down, and the right ventricle ischemia can occur because flow again depends to the right ventricle on the differentials of these two things. So it's a vicious circle which keeps up there. And the persons tend to tolerate it extremely poorly, and when this compensatory failure mechanisms takes place, and we have recently a medical legal case which was sent to us was nothing else but hypertensive crisis, and 3.5 liters of fluid was given, patient crashed, and now the case is in the courts in terms of negligence. So it is very important to understand these small subtleties which are happening in the setting of intensive care, and that's what you see it. On the one side, you will see in more physiological terms what happened to the end diastolic volume, end diastolic pressures. You can go through it, and then there occurs a right ventricle, left ventricle interaction. Because these things are fundamental which we need to know, because on the basis of that, clinical symptoms depend, A, and B, on the basis of this abnormal physiology, we decide what management we do it in the intensive care unit. So you have patients of pulmonary arterial hypertension, chronic CTAF is already there, congenital heart disease, and also connective tissue disease. All have been discussed, and the trigger again to revise is infection, perioperative deterioration, intubation leading on to positive pressure ventilation, and along with it you will see hypoxemia, acidosis. And you will see practically all of them are correctable causes, except that when you have a thrombosis, massive one, which leads to increased afterload. So primary management of it depends entirely on managing preload, managing afterload, and ensuring adequate contractility. That's how we work on it. And this is the RV dysfunction in the ICU. It's a simple on the causes and their mechanism. I will not go into the detail. Since morning, you have been listening to it, and part of it I've also talked. So if the residents are there, this is a snapshot. They can take it up, and if somebody asks you, you can give the answer to this. Clinical recognition is important. History examination is the key. Unfortunately, today, we look at the monitors, we don't look at the patients. I think it's very fundamental. Look at what is happening to the peripheries, what is happening to the pulse pressure, what is your on the Oscar, can you palpate P2, can you have a left parasternal lift, or can you auscultate loud second sound, and sometimes you can also auscultate splitting of the first sound. All these things are there on the bedside to see and look at it and see whether person is having any arrhythmias or not. Lab is just to prove whether there is any metabolic abnormalities are not there, or whether there is any damage to the lung, to the right heart is there or not, and then obviously pulmonary embolism and lactates are the consequence of acidosis in these cases. ECG, we commonly tend to see in these patients persistence of there is a right axis deviation can occur. You can have a right bundle branch block which may come up, and you may also see an evidence of right ventricle strain and classical description of S1, Q3, T3, which have been described with an embolism. But if there is a severe hypoxemia, there is a severe constriction, elevation can cause this. You do the imaging can actually tell you what you are dealing with. I will not go beyond that. And echocardiography and POCUS on the bedside in the intensive care unit have become one for us a very important tool. Dr. Vinash is sitting there, and that's how they talk about precision medicine and precision diagnosis. And it can tell you what has gone wrong with what. And we have seen during COVID, people getting thrombus and propagation of that under echocardiography. So that's your visual stethoscope which can actually tell you what is happening. And in these cases, I will not go into the details. We look at right ventricle size geometry, systolic function, and tricuspid annular plane systolic excursion is the key. Normally is around about 24 to 28, but if you find less than 18, it is abnormal. And RV pressure estimation, indirectly we do it through the TR jet. These are the ones you see, the D-shaped right ventricle, which we are seeing it up here in these cases, and that's very, very important. It tells you that the right ventricle pressures have gone up and they've encroached on the right ventricle. If you see this sort of a thing on the echocardiography, you are having a trouble. Same way we also see if person has a cardiac tamponade, you will have a free wall or RV diastolic dysfunction or diastolic collapse will be there. This is the most useful tool. I will not go beyond anything than this. IVC collapsibility we see every day. If you find collapsibility is not there, RV is dilated, please look at pulmonary artery, see thrombus. If it is not there, see what is the level, and then on the basis of that we decide. McConnell sign is something, I will not go beyond that. It's a free wall abnormalities which are there. RV free wall is akinetic, and that's how you tend to make a diagnosis of pulmonary embolism, though it is uncommon. But today we see it with RV infarction, or other RV overload states can also show it. Principles of management, I will take another 2 minutes. Reverse the precipitating cause, maintain systemic perfusion, I will not go beyond this. Optimize RV preload, reduction of afterload, improve RV contractility, and you preserve RV coronary perfusion, and you avoid RV ischemia and progressive dilatation. Preload optimization is the key. I've already talked about it. When pH-related RV failure, please avoid aggressive fluid. If you take that thing in mind, I think my job is done here. I won't go beyond that. You decongest the lungs. Then the reduction after load is the cornerstone of pH crisis. Try to find out metabolic factors, hypoxemia, hypercapnia, acidosis, high intrathoracic pressures, and embolism. Treat them. Inhaled vasodilators have some role here, but unless or until you treat the underlying condition which has caused it, that's why has not made too much of difference in terms of outcome in ARDS. Improve RV contractility. If your preload and afterload doesn't work, at that time, you need to look at RV contractility. Common again is noradrenaline. Levesomendin is off late, is not available, but that is one drug which has been found to be effective, which has an action like dobutamine, but without causing increased myocardial oxygen demand. I think that is something we need to do it. This is the preferred strategies. Norepinephrine, vasopressin, you add it up. You can use dobutamine, milorelin, but again, the Western world, if you see, there is a divide transatlantic. European papers do talk about levesomendin, whereas the American papers are not, but both are effective. So rhythm control, I will not go. This is, I think everybody knows, faster the rate, less is the perfusion. So I think we need to control that. Rescue, percutaneous, etc., all have been discussed by our friend Julius, as well as from the Ireland. So let's look at this case. 33-year-old female postpartum. She underwent cesarean section 4 days prior, presented to us with a shortness of breath, left-sided pleuritic chain 3 days. She had a vital, BP was maintained, but rest everything was abnormal in this particular case. And when we looked at this ECG, you will see persistence of S wave in L1 and V5, V6. Along with it, this is a classical example of S1, Q3, T3. And along with it, she has got a sudden onset right ventricle enlargement in terms of R waves in V1. And her X-ray was obviously artifact, but there was an increased CT ratio, and all parameters were suggesting towards pulmonary embolism. On POCUS, RARV was grossly dilated, and TAPSE was less than 17, that is 14 mm was there in this. IVC was dilated, and it was not collapsible. And when we looked at it, we found out she had a pulmonary embolism, which was there, and there was a large dilatation, which was there. So we did diagnose it as an acute pulmonary thromboembolism. We put it up into the new definition into you have C1, C2, C3, C4, and then we put it under C3 because BP was still there, RV was dysfunctioning, but it had not collapsed. So we worked with it. Fortunately, she responded to the treatment. As our friend said it earlier, that most of the thromboembolism, they dissolved over a period of time. It happened, and she did well. So my dear friend, this is the last slide. This is a summary of what you tend to see in patients in intensive care units who come to us with some other problem and land up with a significant RV dysfunction. So what is happening is we look at it in terms of acute RV failure. We try to find out, is there a treatable cause or not, whether there is a pulmonary embolism or RV infarct. So the dictum is for all patients who have got acute coronary, please do right-sided leads, which is very, very important. And if your patient on nitrate had an hypotension, think in terms of right ventricle infarction. That is where you will need more fluid. Other places you will not. And then treatment successful, monitor RV function. If you find excessive preload, is there an excessive afterload? If excessive preload there, stop giving more fluid. Use diuresis ultrafiltration. But if you have an excessive afterload, correct factors which have led, so you lead hypoxemia, hypercarbia, acidosis, needs correction. Perfusion is reduced. Again, try to create the reverse systemic hypotension by giving inotropes and try to reduce RV wall tension by pressors. Decrease RV contractility is there. Then again, you try to improve the myocyte functions and correctability, especially acidosis. And this is where milrinone as well as your levosimendan work. Resolve fine. If it doesn't, then probably you need to ask Dr. Julius for the help, or if there is a thrombus, probably mechanical thrombectomy. Thank you very much. Sorry, I was given 20 minutes. So I realized because of time they reduced to 15. So I took a couple of minutes and spoke fast.
Thank you very much, sir, for this wonderful lecture. Any questions from the audience? We can take one or two questions.
Pardon, sir?
What is the best way to diagnose pulmonary embolism? What is the MCQ answer?
MCQ answer, sir, to that is if somebody has come to you with a sudden onset breathlessness, in that case, and lung X-ray is normal, you do an alveolar arterial oxygen gradient. If it is high, think in terms of P. It's as simple as that.
In our time, it used to be CT.
Sir, CT is the diagnostic, but sometimes patients are sick, you can't send them. But gold standard for diagnosis today is actually CT.
The concept of how much away the CT has changed so dramatically that most of the modern ICU have the CT inbuilt.
नहीं है सर हमारे पास. So we have to send the patient to the ICUs, from the ICUs to the labs. But the answer is that what we say as a dictum is, anybody who comes to you has a sudden onset breathlessness, do on the bedside because there could be multiple causes. So what you simply do is we do two things, sir. First, we look at a blood gas and look at alveolar oxygen gradient. If it is normal, we look at usually young females, we go with it that probably it is some sort of a hyperventilation syndrome. On the other end, when this gap is high, then we go for straight away for the CT, ask for it then. So it is a sort of a triaging.
Actually, when Dr. Fang was the director, Memorial Sloan Kettering in New York, 60 operation theaters were changed to multi-investigation in the same OR, means CT, MR, radiotherapy, everything, one go. And that is because once the trauma patients came, Professor Paintenden used to say, what is the first accident, second accident, third accident? So in order to avoid the third accident, which is inside the hospital, the modern trauma reception area
is
has
inbuilt.
Everything.
Sir, I wish you would have been our Vice Chancellor. that probably would have done that. But nevertheless, I do agree today as a part of trauma protocol, everybody goes through the CT scan to pick it up. Because most of the high trauma disruptions, most of the time is where the junction is and other things you come to know. But in terms of medical emergencies, we have the great instrument called ultrasonography. But unfortunately, because of PNDT, the restrictions are so much that people are putting it, fortunately we have it, so that's how we practice, sir. And first doubt, go for CT.
For us in trauma, the basic investigation was pan-CT.
It still is,
CT, don't talk.
Same here, sir.
Right.
Same here, but for pulmonary embolism, first you have to do it.
For MBBS, the MCQ still in examination is CT.
It is, sir. Diagnostics wahi se hoga. Otherwise you won't be able to make a diagnosis. Contrast CT, sir, not plain CT. It has to be a contrast CT.
Yeah, MBBS.
So the only part we need to look up there is the kidneys functioning well.
A new word I heard today, which I understood gradually, POCUS, new word for me.
Point of care ultrasound, that's what we use, sir. And that I think has become the modern stethoscopes of most of the intensivists, and also in pulmonology, sir. this is something, we did one study and we found nearly, if you are well trained in it, out of 96% you are able to diagnose on the bedside with the blue protocol, and also if you put a rush protocol, practically cardiovascular emergency can be handled right there in the casualty itself with the ultrasound.
It is also in the ATLS protocol.
Pardon, sir?
It is also in ATLS protocol.
Yes, sir.
Basic minimum.
Yes, sir. So thank you so much, sir. Remember, it has taken me to 80s when you joined from Sher Kashmir to Rohtak to my MBBS class. Thank you so much.
Next is Rahul Chandola, sir. Close.
Thank you, respected Speaker and
Dhruv, sir,
distinguished Chairperson.
may I ask one question? So what should be the threshold for intubation in this PH crisis patients, and what is the difference between RV protective ventilation versus lung protective ventilation?
You see, again the question is whether it's a de novo first time coming up or person already has it. Suppose you have got an ILD and then along with it is there. Most of the ILD itself is a poor thing if you want to ventilate it. As far as the patients of pulmonary embolism is concerned, we avoid as far as possible, and most of the time providing other additional supports, because then the patients move up. If somebody has, like similarly, you have the congenital heart disease, the crisis is there. There also, most of the time you get away with medically managing these patients rather than putting them on ventilator. Now this challenge comes up when persons are already on the ventilator, like ARDS, where it is coming up because today emphasis on lung protective ventilation. You go low, you create hypercapnia, you permissive hypercapnia. So in those settings, you have to take care of, get out of the permissive hypercapnia, go with the eucapnic thing so that at least the factors which are responsible are taken care of. Now, therefore, when we are talking in terms of, these are the new jargons which is coming out as a spin-off of the ventilation associated complications, I still feel that you will go with an underlying condition, see to it that the right ventricle oxygenation is taken care of, metabolic factors is there. I still will go under those circumstances if there is no hypotension, primarily with, if there is no other cause, primarily with the lung protective ventilation. It's only when I see that hypotension is being caused as this thing, then probably I may have to reduce the pacing. I hope it answers your question.
Thank you, sir.
Thank you, respected Speaker. Thank you, Chairpersons. Kindly collect your mementos. For the next session, I would like to invite our distinguished Chairpersons, Dr. Sohail Siddiqui, sir, Professor, Department of Critical Care Medicine, King George's Medical University, Dr. S.N. Gupta, Senior Consultant and Director, Dr. Anurag Rai, sir, Additional Professor, Thoracic Surgery, KGMU, Dr. Anand Gupta, sir, Senior Chest Physician, Respiratory Medicine, Balrampur, Dr. S.N. Gupta, sir, Senior Consultant and Director of Sanjeevani Hospital, Lucknow. Welcome, Chairperson.
So good evening, everybody. Because we are running already short of time, so I'll request Dr. Rahul Chandola to come over to the dais and start his lecture. By that time, I can introduce him. He's a senior cardiothoracic and heart lung transplant surgeon from PSRI Hospital, New Delhi. He has a lot of expertise in the dealing with the acute complex heart surgeries, and he has a list of the achievements. But I'll request Dr. Chandra to start with his lecture.
Good evening, everybody. I'll just come straight to the point here. Thank you, Dr. Ved, for inviting me here, and their esteemed guests. Hi, sir. How are you, sir? Good to have you here. We have been trained for centuries. The doctors are trained this way. The allopathy has relied on episodic care. So by that, what we mean is, patients come to us in our clinic, in our hospital. We see the patients, and the patient goes home. Now, we all as doctors, we've practiced for decades, and have really honed our skills. The medicine also has evolved significantly. The results have become so good. We do phenomenal surgeries, phenomenal procedures, and we're really happy and proud that, we have done so good. Now, the patient goes home after discharge, and then, we literally lose touch with the patient, and that could be for a week, 10 days, 2 weeks, even in the medicine, we lose touch with the patient for 3 months altogether. Now, that is episodic care that we give. We judge a patient's care on those 10 to 15 minutes of time that we have devoted to the patient, and judge that against that 4,000 plus hours that he has spent at home, where you have not known anything about him. So, my topic revolves around this concept, which is called continuity of care. What that essentially is, you don't leave the patient, once he leaves the hospital. So health basically is not when the patient enters the doorsteps of the hospital, as traditionally has been seen. 95% of the health, in my opinion, stays out of the hospital, and that part nobody takes care of, So I'm going to talk about that. Now, why it is important for PAH patients or for any pulmonology patient, just touch that. So I already discussed that we're practicing snapshot medicine, PAH or COPD or transplants, the patients, their physiology changes continuously, So as I said, what we know about the patient is what we see him in the hospital or in the clinic, have no idea what's going on with him, while he's at home. Now, this slide shows that, what happens to the patients between the visits. So what will happen, typically a patient with COPD that you'll see in your clinic, or patient with PAH you'll see in your clinic or hospital, goes home. These patients may have exacerbation. A COPD patient is known to have exacerbations at home. That may happen in 2 months' time, 3 months' time, or, depending upon his physiology. Now, what will happen is, before the exacerbation, the physiology always changes at least 48 to 72 hours before the actual onset of symptoms, So if you can catch that physiology ahead of time, that is where the beauty lies, because then you can prevent all those exacerbations. You can prevent all those emergency hospitalizations if you can predict the onset of disease ahead of time. That's what the basics of predictive analytics is. And this is one segment which is taking a lot of attention everywhere in the world. Typically in that invisible period, patient will have changes in the SpO2, the activity will fall, arrhythmias may appear, patient's respiratory rate may change, his sleep disruption may happen, and the pulmonary function may decline, as he's at home. But what happens is, all of that gets undetected, and the patient then actually lands up in the hospital with worsened situation. So the medicine now is moving from episodes to continuity, and how that is possible is the help of the technology. Technology is enabling that. So there's a platform, we call that as continuity of care platform. Typically the name is iLive Connect. What exactly is that? There's a biosensor device, it's a FDA and CE clear device, and essentially comprises of a biosensor technology, which is a patented technology. Now, with that, the vital information, including 2-lead ECG, respiratory rate, saturation, temperature, sleep, activity, heart rate variability, all these important physiological parameters are captured in real time. While the patient goes home, he's at home, he's wearing that chest patch, it's a biosensor device there. And his entire physiology is captured in an iCloud platform. And from there, it goes to the command center, which has AI integrated in there. And also, there are physicians who are manning that command center 24/7. Now, what's happening is, imagine a patient at home, with COPD, you know, even before the exacerbation happens, you know, his respiratory rate will start to go up, his heart rate will start to go up at least, you know, by 10 to 15%, you know, at least 48 to 72 hours before. There will be sleep disruption, there will be decline in the activity, and also there will be decline in the heart rate variability that will happen typically 48 to 72 hours before a COPD patient will have an exacerbation. You know, similarly, the case is true for a patient with CHF who is at home. Typical exacerbation, you know, the symptoms may appear 48, 72 hours after the changes in the physiology. So that change in the physiology is captured with the help of that biosensor technology. And this is captured in the command center where doctors are watching over the change in physiology 24/7. Now the AI is integrated in such a fashion that, you know, it flags. So say, for example, there are 1,000 patients being monitored in one time, you know, and these are all COPD patients, patients with PAH, patients with CHF. They are at home, you know, and with the biosensor, simple chest patch, you know, all their vital information is coming to a command center there. And if there is a change in the physiology, there is a predictive analytics model which is incorporated there. It's the new, very new concept which is taking, which is generating a lot of interest everywhere, is predictive analytics, you know. So what that is I'll give you a typical example, you know, a patient with COPD, before exacerbation, as I said, his heart rate will start to go up at least 48, 72 hours before, you know, by at least 10 to 15%. His respiratory rate will start to go up by at least 10, 15%, 48, 72 hours before. There will be a disruption in the sleep many days before the actual exacerbation. His activity will start to go down. So it's not one change in the physiological parameter, it's the complete set, you know, which has been captured by the artificial intelligence, and that is taken as a predictive analytics, a computational model, you know, called predictive analytics, which then flags that to the doctor sitting in the command center that, you know, look, there is a patient with COPD or with PAH. We see some changes in the physiology, which is giving us an idea that probably this patient in the next 48, 72 hours is going to have an exacerbation, which can then take him, lead him to get to the emergency, you know. So the doctors act way ahead of time, you know. So you can start this patient on bronchodilator, you can go titrate his bronchodilator, maybe, you know, you can actively start steroids in this patient, you know. You can start the rehabilitation there, you know. And ultimately, episode of exacerbation can be prevented if it is acted upon in time. So that's the value of predictive analytics and the biosensor technology with continuity of care model. So this is the digital physiology layer. You know, the patient with connected devices, this could be wearables, a patch, a spirometer, and with that, the patient goes home. He is at home. All his information is coming to a secure iCloud platform where the AI is integrated, predictive analytics models are integrated, and ultimately the physicians are manning that command center. You know, they are being flagged that, you know, this patient is having a problem, act on it now. And the response time of the physician is less than 3 minutes, you know, so it could be middle of the night, 12 o'clock in the night, patient is having any change in the physiology. He could be having a shoot in blood pressure, maybe, you know, some arrhythmia, maybe, you know, he's having a rise in blood sugar, you know, dangerous hypoglycemia, or, you know, there could be any other change in the physiology which is being captured there. And the doctors then respond in real time, you know, and ensure that the patient is taken care of. So that's the concept of continuity of care. So the evidence has already started, you know. In 2019, there was a publication in Chest, you know, that gave the evidence that, you know, these patients with PAH with implantable hemodynamic monitoring, that allowed continuous remote PA pressure surveillance in advanced PAH, and that led to improved outcomes and better management of patients with PAH, you know. Similarly, 6-minute walk testing with the chest sensor, there has been considerable, work on this already. And now you'll see more and more papers coming up on these concepts. So the BH digital continuum is risk, the diagnosis, therapy, treatment response, advanced disease, and then upon the diagnosis of advanced disease, transplant. Traditional pathway is the patient feels worse, more cough, breathlessness, he calls the doctor, treatment starts, and admission happens, if late in the disease. Predictive pathway is different, That's continuous monitoring of the patient that leads to changes in the physiology being detected in time. Algorithm recognizes the trajectory of the patient while he's at home, and the clinical team is alerted ahead of time, and the patient is contacted, and the pulmonologist or the team intervenes well ahead of time. As a result, that worsening of the symptom that could have led him to the hospital can be avoided or prevented. So as I explained, what happens before an exacerbation. Typically, the heart rate, respiratory rate will go up, saturation will decline, activity will go down, sleep quality will go down, FEV1 would go down, and obviously, the rescue medication, the dose of steroids or dose of bronchodilators, rescue bronchodilators, that will go up along with the worsening of symptoms. All of that is captured using the predictive analytics well ahead of time. And that's where the future of medicine is. So this was another study in COPD patients, who were monitored at home. There were 110 patients who were monitored at home. And as you can see, the oxygen saturation tended to fall while pulse rate and respiratory rate rose in the days before exacerbation. They've not mentioned exactly how many days, but typically 48 to 72 hours before an exacerbation, these changes will happen that can be captured. So I've already explained this, how the predictive analytics model works, So, about the transplant, what happens is the operation lasts many hours, but the journey lasts a lifetime. And almost all of this happens outside the transplant center. Once we discharge the patient with transplant, he may have, episodes of rejection, infection, CLAD, BOS. There could be medication toxicity, there could be some arrhythmia, some renal dysfunction, and deconditioning, with time, which obviously he has left the hospital, and he is dealing with that, many of those things, on his own while he is at home. But the connected lung transplant patient will be the one who goes home with connected care. By that, what I mean is patient having transplant, having received the transplant, he goes home with a biosensor device. He goes home with a wearable. He goes home with a home spirometer, which is connected to the platform, to the continuity care platform. As a result, at home, his entire physiology is being captured in a command center, which is not the hospital, which is not inside the hospital. It is a dedicated command center manned by the doctors, but they are aware of patient physiology from second to second. It's not that they're not seeing the patient in episodes. It's a continuity of care. Now here, if there is a possible infection that is happening in this patient, or a possible acute rejection, or a possible graft dysfunction, this will be captured by the platform well ahead of time, and that's where the value of continuity of care in a transplanted patient is. So in a study, this was a study that came in way back in 1999. Imagine, this was the time when they figured this out, and then gradual work has been going on. Home spirometry identified BOS stage 1 approximately 276 to 341 days earlier than the clinical pulmonary function testing, So this is pretty significant. And you can see a real digital world home monitoring program combined Bluetooth spirometry, symptom reporting, automated alerts, and clinical dashboards with home and laboratory FEV1 correlating closely, and this is a recent study, in 2023. Now the studies are coming up more and more on continuity of care. So I've already explained that. So a patient with transplant goes home, he goes home with a biosensor device, a wristband, and a home spirometer. If there is a decline in FEV1 along with a decline in SpO2 or rise in respiratory rate or heart rate or rise in temperature, which also can be captured with the biosensor, or there is a decrease in activity along with sleep disruption, all of that can be captured. Even if there is a 5%, 10% change in any of these physiological parameters, the computational model will analyze that and will be able to predict, deterioration in the patient while he's at home. That's where the value of continuity of care is. So the clinical command center here is typically manned by the specialists. These are cardiologists or pulmonologists or the critical care specialists, who are there 24/7, and they're watching over patient's physiology in real time while the patient is at home. And if there's any change in the physiology or vitals, these doctors will respond in real time there. So,
Dr. Chandola?
Yeah, sure. I'm almost done. Just a minute of that. So this is how the command center typically is. Patient at home, he's with a wearable, with a biosensor patch there, and his entire physiology is being tracked. It's a wireless thing, nothing is wired. And entire physiology is tracked in the command center where the doctors are manned, the AI is integrated there, and which is flagging any abnormal vitals. As a result, the doctors are responding in real time there. With that, I'll just end one sentence before I end. So we know that the past in medicine was about treating the diseases. The present currently is how to prevent the disease. But the future will be how to predict the disease. And that's where the world is going. With that, I'll just end here. Thank you so much for patient listening.
Thank you. A nice presentation. I think we are running short of time, so we will conclude this session. Okay, thank you.
Thank you.
Thank you all.
Thank you so much, distinguished speaker and respected chairpersons. For the next session, I would like to invite our chairpersons. May I invite Dr. Anit Parihar, Professor and Head, Department of Radio Diagnosis, King George's Medical University. Dr. Siddharth Mishra, Associate Professor, Department of Radio Diagnosis, KGMU. Dr. Ansha, Assistant Professor, Hind Medical College, Lucknow.
So, I would like to welcome Dr. Zafar Niaz for his talk. And Dr. Zafar Niaz is professor in Department of Radio Diagnosis, SGPGI, and he is specialized in diagnostic pulmonary radiology, diagnostic neuroradiology, and CT-guided biopsy. He has more than 100 publications with the book. He has a book editor and 4 book chapters. So, over to you, Dr. Zafar, for your talk.
At the outset, I will thank the organizers for inviting me, and I'll be briefly talking about the role of imaging in pulmonary vascular diseases. So, coming to the modalities, the chest X-ray is mostly used as a screening tool, and of course, the minor details cannot be obtained, but still it is used to see the cardiac size and proximal pulmonary arteries and for screening of the lung. But CT pulmonary angiography has become the modality of choice, and it is being very commonly used. And we can reconstruct the images and we can generate a lot of 3D images. So nowadays for parenchymal as well as for vascular evaluation, in one go we can use this modality. And it can also rule out many causes of pulmonary hypertension. MRI is an emerging tool, and its resolution is not as good as CT, but for cardiac imaging and for real-time dynamic imaging, it's very useful modality. And DSA is mostly for therapeutic purposes and sometimes for complex cardiac malformation and for pressure gradient, but otherwise for diagnostic purpose, mostly we use CT scan, and DSA is mainly for therapeutic purpose. Nuclear study is a different department, but this technique is used in cases of pulmonary thromboembolism. Now, coming to the common pulmonary vascular disease, I'll be showing you cases. So, acute pulmonary thromboembolism, this is the most common situation which we encounter, and we can see filling defects in the pulmonary artery branches, and we can also see lung changes, but it may be there or may not be there, but filling defects we can demonstrate in the pulmonary arteries. And these filling defects, and with the help of now very good resolution of the CT scans, even we can see in very small branches, even segmental branches, also we can demonstrate the filling defects which are suggestive of pulmonary thromboembolism. Now coming to the pulmonary hypertension, of course, imaging cannot tell you the cause, but in some cases like ILDs and CTPH and in some idiopathic conditions, we can suggest the cause of pulmonary hypertension on CT scan. So coming to the chronic thromboembolic changes, we can see the dilated pulmonary arteries, we can see the adherent thrombi because much of the lumen is recanalized, but still we can see some adherent thrombi, and also in the lung we can see areas of mosaic attenuation. And other cases, like in this case, we can see completely thrombosed left pulmonary artery, and there is a small adherent thrombus in the main pulmonary artery. We can also see in this case some adherent thrombi and some linear strands in the pulmonary artery, and also similar changes in this case. So these findings, if we see, they suggest chronic changes of pulmonary thromboembolism. We can also see calcified thrombus. Now, coming to the primary pulmonary hypertension, generally we don't get any lung changes or any cardiac valvular disorder in these cases, but we can make out the dilated pulmonary artery and the right ventricular changes due to the pressure effects. So coming to some other entities which we, as a radiologist, we encounter, they are pulmonary artery aneurysms. Like in COVID epidemic, we saw some cases infected with fungal infection, and that led to the formation of, because of the weakening of the vessel wall, we could see pseudoaneurysm. So we have seen few cases in the COVID epidemic. This is another case of lung infection with hemoptysis, and we can see in the area of consolidation there is a small aneurysm from the pulmonary artery branch. These are also called as Rasmussen aneurysms. Now coming to the pulmonary AVMs, sometimes we can see bunch of vessels in the lung where there is direct continuation of pulmonary artery and veins. And these malformations can be large, or like in this case, or sometimes they can be very small, and you can, we have to see very carefully to diagnose this type of small tortuous malformations. Now, congenital lesions, you can see pulmonary hypertension in cases of patent ductus arteriosus. We can also have congenital anomalies like scimitar syndrome or anomalous pulmonary venous return. Some of the uncommon conditions I'll be showing after this one. So, in malignancies, you can have direct involvement of the pulmonary arteries, but this type of rare presentation, sometimes you can have tumor thrombi in the pulmonary arteries as well as in the pulmonary veins. Some tumors have tendency to invade vessels, and sometimes we can have tumor thrombi also. This is a case of Takayasu arteritis, which is very common, and mostly it involves arch vessels and the subclavian and the carotids. But in this case, we can see there is involvement of the pulmonary arteries also, and you can see that the right lower lobe pulmonary artery branches are not opacifying, and this was a case of Takayasu arteritis. Another condition which can sometimes involve the pulmonary arteries is the fibrosing mediastinitis, where you have soft tissue which is causing narrowing of the superior vena cava, narrowing of the right pulmonary artery, and venous collateral formation. This is a very unusual case. A similar case was shown in previous talk, where we had a soft tissue filling the right pulmonary artery, and there the diagnosis was told as sarcoma. But in this case also, this patient we followed up and we saw that this lesion was growing, and then we did a biopsy of this lesion, and this was proven to be a IgG4 disease, and in the follow-up we can see the lesion has regressed. Of course, it has caused obstruction or the blockage of the arteries, and there is some enlargement of the bronchial arteries also. So this was not a malignant case. This was a case of IgG4 disease. Almost we thought it is some kind of sarcoma which was growing. And sometimes we can also see small pulmonary arteries with hyperlucent lung in cases of Macular syndrome. So I'll conclude my talk with this. So basically nowadays most of the, for pulmonary vessels, mostly CT angiography is done. MRI we are not doing for pulmonary arteries, but we are doing for cardiac evaluation. And DSA is mostly for interventional and complex vascular malformations. Thank you very much.
Sir, you have shown a nice bunch of cases. So I have two questions, sir. So what is the role of cardiac MRI in pulmonary vascular diseases? And there is an entity known as pulmonary veno-occlusive disease, where giving the pulmonary arterial vasodilators may prove harmful to the patient.
Actually, cardiac MR is used mainly to see the status of your hypertrophy of the right ventricle, size of the right ventricle, and the deviation of the septum towards the left ventricle, bulging of the septum. So after offering some kind of treatment on follow-up, MRI can very well document the changes in the heart. So that way it can help, and of course for using even for velocities measurement also MRI can be used. So, but there are many indications. So in brief, this is a common one. And the second part, what you have asked, the pulmonary veno-occlusive disease. In pulmonary veno-occlusive disease, the problem is more on the venous side and at the very small venule level. So there are, of course, you will have the pulmonary hypertension, but in addition, you might see some ill-defined century assigner kind of nodule or some very subtle abnormality. So in a case of pulmonary hypertension, if you're seeing lot of ground glassing, a lot of tree bud kind of nodule, in those cases you can suspect pulmonary veno-occlusive disease. That is at a small level. There are also some conditions which involve at larger level. So at both level, but these are difficult to diagnose those. Thank you.
So if there is not another question, so we will conclude this session.
Thank you.
Thank you, respected speaker and distinguished chairpersons. For our next session, I would like to invite Dr. Pulkit Gupta, sir, Assistant Professor, Department of Respiratory Medicine, Ram Manohar Lohia Institute of Medical Sciences.
for the next session, I would like to invite Dr. Abhishek Tandon. He is consultant in the Department of Respiratory and Sleep Medicine at Medanta Lucknow Hospital. And his topic is and his topic of discussion will be biologics in obstructive airway disease.
Respected faculty, we'll just take a 1-minute break for sir to load his slides, and then we'll commence with the session.
Thank you, sir. Same here. 10 साल से MBBS में पढ़ा है मुझे पूरा करके लिख राइट सर कह रहे फंस गए वो नहीं आ रहे नहीं आ रहे अब वे दिखाएंगे आपको क्या हो रहा है
Respected dignitaries on the dais and off the dais, Professor Rajendra Prasad sir, Professor Ravi Kant sir, Dr. Darshan Bajaj, Dr. Jyoti, Dr. Anand Gupta sir. At the very onset, I would like to thank the organizers for giving me this opportunity to be present amongst all of you here today to deliberate on a very important topic, but at a very unusual place. The topic is biologicals in obstructive sleep apnea, and the venue is PH Summit. So at the very onset, I would like to give a disclaimer that this is a GSK-sponsored session. So you would be seeing a lot of advertisements of GSK and the brand name of GSK being propagated as well. So in the 10 minutes that have been given to me, I decided to cover a very pertinent question that comes in the mind of every individual who's been dealing with cases of severe eosinophilic asthma, and that is that we have two biologicals with us. One is mepolizumab and one is benralizumab. All our guidelines tell us that either can be used to treat patients of severe eosinophilic asthma who are oral corticosteroid dependent and are exacerbating frequently despite maximum inhalation therapy. Now, do we have any latest guidance, evidence, or data which can help us choose which biological to use, mepolizumab or benralizumab? So in the next 9 minutes, we are going to take you through the evidence that we have gotten very recently, which can help you choose which biological to use in which patient subtype. Now, this is a summary of the two biologicals that are available. If you look at this data, the only difference is that mepolizumab is indicated in eosinophilic asthma, HES and EGPA, whereas benralizumab is indicated only in severe eosinophilic asthma and EGPA. So benralizumab is not indicated in patients of HES, and the second is in the dose. mepolizumab is given at a dose of 100 milligram every month, whereas benralizumab is given at a dose of 30 milligrams every month for the first 3 doses, followed by every 2 months. Now this is a master chart comparing the efficacy that mepolizumab and benralizumab have shown over the years in the various RCTs that have been done. So if you look at the various absolute eosinophil counts, more than 150, more than 300, with the number of exacerbation history as being more than equal to 2 in the prior year or more than equal to 3 in the prior year, and the reduction in the exacerbations requiring hospitalizations and ER visits or the comparable OCS reduction from baseline, we see that mepolizumab and benralizumab fare equally well. So where do they differ, number one, and how to choose which biological to give? Now for this, GSK conducted an indirect treatment comparison of mepolizumab with benralizumab and the anti-interleukin 5 other treatment, that is reslizumab, in patients with severe eosinophilic asthma. Now this database was taken from Cochrane systematic reviews across 11 RCTs, which included placebo-controlled trials. The key endpoints were clinically significant asthma exacerbations, asthma control questionnaire, that is your disease severity, and the pre-bronchodilator FEV1. Now, if you look at this forest chart, you could see that mepolizumab reduced clinically significant exacerbations by 34 to 45% versus benralizumab across all the subgroups. That is, when patients has a baseline absolute eosinophil counts of more than 400, more than 300, more than 150, or even if we did an unadjusted comparison, mepolizumab fared much better as compared to benralizumab. Also, mepolizumab significantly reduced the rate of exacerbations requiring ED visits, hospitalizations as compared to benralizumab. Now, we'll have to take this data with a pinch of salt because this was analyzed by GSK and mepolizumab is marketed by GSK, but we do have data which tells us that mepolizumab is faring somewhat better than benralizumab as far as these patient-related or observer-related outcomes are concerned. Similarly, even asthma control was better with mepolizumab as compared to benralizumab across all eosinophilic severe asthma subgroups. So asthma control was significantly better with mepolizumab as seen with this forest chart. Now we have two other questions that we want to address. One is that whether we have any evidence which tells us that one biological fares better over the other as far as the OCS reduction is concerned. To answer this question, a retrospective single-center study was analyzed, and this study told us that when we looked at the asthma control, the quality of life, spirometry, exacerbation rate, daily OCS use, and exercise intolerance, mepolizumab fared better as compared to mepolizumab. In what indexes? There was significant OCS sparing and lung function improvement with mepolizumab over benralizumab, as can be clearly seen with these graphs out here. Now the second pertinent question was, now that we know that mepoli is better than benrali in reducing the exacerbations, is better than benrali in the OCS reduction, does mepolizumab also fare well as far as asthma control questionnaire is concerned or the quality of life of the patient is concerned? And if we look at the data sets out here, mepolizumab was definitely better in improving the ACQs than benralizumab as depicted over the data here. Now to conclude, I would just say that mepolizumab in the data that we just presented is faring much better than benralizumab across 4 key domains. Number 1, reduction in exacerbation. Number 2, quality of life. Number 3, spirometric improvement. And number 4, overall safety profile. So if till now we did not have an answer as to which biological to choose when targeting patients of severe eosinophilic asthma, I think this data here, though again I would say to be taken with a pinch of salt, does give us some guiding light. And also, via GSK, I would like to tell all of you that mepolizumab is the only biological approved across the 3 domains. That is severe eosinophilic asthma, EGPA, HES. Also, it has gotten an FDA approval for the treatment of eosinophilic predominant COPD. They have applied for the DGCI approval as well, which should be available somewhere by the end of this year. So that's been my time. Thank you so much for the patient listening.
Thank you, Dr. Abhishek. Any question from the house? So thank you, everyone. I would like to conclude the session here. Thank you.
डिस्क्लेमर में एक और वर्ड आपको कहना था विच वाज लेम है उनका, लेकिन मेरा इससे कोई फायदा नहीं। डिस्क्लेमर में असली बात वो
I will definitely sir take this feedback. अगर कभी भी अगला होगा तो ये
हमें मेरा इसमें मतलब
I did not take any honorarium from them to present.
Thank you so much, sir. Thank you so much, distinguished speakers and chairpersons. We will now take a few moments of break before we commence our inauguration ceremony.
इसका आपको याद है हम लोग इसोफिलाइटिस से काम करते हैं।
सर इसोफेजाइटिस को भी मैं पुलिस मार्क करूँगा।
हाँ वही मैं कह रहा हूँ इन गाय का ऑफिस नहीं आपकी जो स्टूडेंट हो गया पहले तो यही था।
आपको याद होगा
वो जो वाशिंगटन प्रोटोकॉल था ना कि बातचीत ईश्वर के अंदर कैसे करते हैं। वेरी वेल बहुत थैंक यू। बच्चे उनको ये कहें नहीं and your disclaimer was a very good exercise. I mean, it was a sensible, correct thing to do. हम लोग जो तो अक्सर लंच डिनर पे ये सब होते थे। हम लोग जब मीटिंग करते थे एसोसिएशन की तो लंच या डिनर में
All are requested to be seated. अभी थोड़ी देर बैठ जाइए और जो इनॉग्रल सेरेमनी है उसको अभी हम लोग स्टार्ट कर रहे हैं। So all are requested to be seated. जो बाहर से सबको अंदर करा लीजिए। ये डेस्क लगवा दीजिए, डेस्क लगवाइए। बुलाइए लोगों को, फटाफट डेस्क लगवाओ। हाँ पूरा तीनों को लगा दो। हाँ
कल सुबह इंटरव्यू है, कल संडे है ना। गवर्नर साहिबा तो उससे ही नहीं सुनता है, सब जगह उसमें जाती हैं वह तो बहुत मुँह पे बोलती है सब चीज़ें। तो पहले उनकी टीम सुना जाती है जो जाके नेस आजकल सब देखती है क्या क्या बोलती है, कहाँ गंदगी है, क्या कमी है, और उसकी टीम मुझे लग रहा है सोसाइटी बड़ी इंटॉलरेंट होती है। 2005 के में जब मैं मुख्य गवर्नर उस पर राजेश्वर राव थे, 20 दिन पहले बुलाया उसको तो 2 महीने पहले। हाँ आप 2 महीने हाँ बुलाया सर्विस करा 2 महीने पहले बुलाया। हाँ मुझे भी लग रहा था मुझे अप्रैल में ज्वाइन करना था। इंटरव्यू फिनिश इन फर्स्ट वीक ऑफ फरवरी सेकेंड आराम से काम करते अभी तो मेरा वो लगता है ना कि परसों इसका इनका खत्म हुआ और कल खत्म तो वो सब काफ़ी अच्छा है। They might have made up their mind in discuss politics. इसमें कौन है? संजीव मिश्रा, नारायण प्रसाद CBI, किशोर कांत, strange but true. वो है जो
ये क्या लगाना है? हाँ लगानी
जज होता है तो उसका सीनियर जज अब ये लगवा दो फटाफट कोई टेक्निकल गवर्नमेंट का गवर्नमेंट साइबर
मेरा अपलोड करा दो टॉक फोटो ले लो इतनी देर में क्या कर रही हैं
अभी पता
लगा लो
एक्सपर्ट होगा
कहाँ फोटो करा दो बस
वो एक्सपर्ट होगा हम लोग ये सही करता होता है ना दुनिया जानी हम लोग सर कैसे जानेंगे हम जानते हैं हमें कैसे जाने वो डिपार्टमेंट की कौन जानता था किसी जमाने में बड़ा मतलब लेकिन जानी हम लोग इसलिए कि वेरी प्रोएक्टिव
So currently we are running late, so we are skipping this session of vaccination, and this is sponsored, so pictures are needed for that. All right. Thank you. So now we are starting the inaugural ceremony.
सर्कुलेट हो उसी से हो मैं तो मेडिसिन जब रेफरेंस दिया था ना मेडिसिन के पीजी मुझसे वहाँ पढ़ने आ जाते थे हमने भाई हमारा काम ही है आ जाते थे सर बता दें कुछ और बता दें मेडिसिन के लिए अच्छा हमारे मेडिसिन के टीचर बहुत अच्छे थे मित्र था सीधी शोक चंद्रा मैं खन्ना साहब की तो लड़ाई रहती थी मेडिसिन वालों को मैंने एक रिवर्स किया कि मेडिसिन से नहीं लड़ना है किसी से नहीं लड़ना हमने तो किसी से नहीं लड़ना है हमारी कहती हमारे से किसी ने हमारे विभाग में कितनी लड़ाई होती थी इन्होंने देखा हुआ खन्ना अग्नोत्री की लड़ाई क्या होती हमने देखा हाँ उससे मेडिसिन थोड़ी लगा जैसे एन गुप्ता साहब हैड दैट विजन कि नए डिपार्टमेंट ऑन द कॉन्ट्रेरी नेफ्रो के हेड मिश्रा साहब सीजी अग्रवाल एंडोक्राइन इन्होंने कोई नया बनाने की कोशिश नहीं की जबकि दे आर वेरी पावरफुल नहीं मैं कह रहा हूँ पावरफुल का मतलब ही है ना पावरफुल का मतलब ऑल पावरफुल जो अनिल गुप्ता साहब की विजन थी हाँ उनका फ्यूचरिस्टिक बंदा हम तो उनको अपना बिल्कुल आइडियल वो मानते हैं गुरु मतलब एज अ प्रोग्रेसिव थॉट हाँ अदरवाइज भाई साइकियाट्री सब उन्होंने न्यूरोलॉजी कार्डियोलॉजी ही स्टार्टेड लेकिन थॉट शुरू किया बुलाया लोग वो सब तो चीज़ें हैं बिना नया करने से कोई पहचानेगा कभी घर आओ यार तुम तो हमारे बगल रहते हो कभी आओ तो सुना हाँ अच्छा बाहर से और जो हमारे साथ तुम्हारे चाचा थे इसी में नहीं रहे अब ना क्या नाम था उनका नाम हाँ यादव ना
Good evening, ladies and gentlemen. After an insightful day of scientific deliberations on pulmonary hypertension, we now come to the formal inauguration of the PH Summit 2026 Lucknow. This evening brings together some of the finest names in respiratory medicine, medical education and healthcare, and it is our privilege to welcome them. We would like to welcome our chief guest, Padma Shri Professor Ravi Kant, former Director, AIIMS Rishikesh, and former Vice Chancellor, KGMU, a distinguished academic leader with a long-standing association with medical education and healthcare. Welcome, sir. We would like to welcome our guest of honor, Professor Dr. Subhakar Kandi, sir, Professor and Head, Pulmonary Medicine, Kamineni Institute of Medical Sciences and Research Center, Hyderabad, a dedicated clinician and academician contributing to the growth of pulmonary medicine. Welcome, sir. We would like to welcome Dr. Basha J. Khan, Senior Consultant and Director of the Lung Transplant Program at Narayana Health, Bengaluru. With his expertise in pulmonary medicine, critical care, and lung transplantation, he has made significant contributions to the field of advanced respiratory care. Welcome, sir. We would now like to welcome Professor Dr. Rajendra Prasad, sir, Padma Shri Awardee, Director, Medical Education, Eras Lucknow Medical College and Hospital, an accomplished pulmonologist and academician with a long and distinguished contribution to respiratory medicine. And last but not the least, we would like to welcome Professor Dr. Ved Prakash, Organizing Secretary, PH Summit 2026, whose efforts have brought together this scientific program and this distinguished gathering. Welcome, sir. We welcome all the distinguished dignitaries on the dais. We begin with a simple gesture that represents growth, continuity, and nurturing, the presentation of saplings. May I request Professor Dr. Ved Prakash to felicitate our dignitaries with saplings, beginning with Padma Shri Dr. Professor Ravi Kant, sir. Professor Subhakar Kandi, sir. Dr. Basha Khan. Padma Shri Professor Dr. Rajendra Prasad, sir. We now move to the ceremonial lighting of the lamp, the timeless symbol of knowledge. We would like to request Dr. Arif, sir, Assistant Professor, Department of Pulmonary and Critical Care Medicine, KGMU, to felicitate Dr. Ved Prakash, sir, with a sapling. We now move to the ceremonial lighting of the lamp, the timeless symbol of knowledge, wisdom, and a new beginning. May I request our distinguished dignitaries to kindly join us for the lighting of the lamp. And now, as we begin this academic journey, let us seek the blessings of knowledge and wisdom through the Saraswati Vandana.
कुंदेन्दु तुषार हार धवला या शुभ्र वस्त्रावृता या वीणावर दंड मंडित करा या श्वेत पद्मासना या ब्रह्माच्युत शंकरा सरस्वती भगवती निशेष जाण्या पहा शुक्लां ब्रह्म विचार सार परमा आद्या जगद्व्यापिनी वीणा पुस्तक धारिणीं भयदा जाड्याधकारा पहा.
Thank you. To formally welcome our distinguished guests and delegates, I invite our organizing chairman, Padma Shri Professor Dr. Rajendra Prasad, to deliver the welcome address. Sir, over to you.
So, good evening. Sitting on the dais, Professor Ravi Kant, who is also Padma Shri awardee and has been the former Vice Chancellor of this medical university. More than this, I know him as one of my very pet junior. He used to call me, whenever he used to call me, even till today, Chief, because he was the junior resident and I was chief resident in the different departments. That speaks what was the cohesion between the PG students in those days. I still remember Ravi Kant. Then my good friend Dr. Kandi Sahab, Dr. Sahab and Dr. Ved, and many people sitting in front of me. मैं हिंदी में बोल लूँ, सब तो समझते हैं हिंदी. शायद आज मैं सबसे खुश हूँ. क्यों खुश हूँ वो बताना चाहता हूँ. कई रीजंस हैं. मैं आपको ले जा रहा हूँ 2005 में, जब मैं पल्मोनरी मेडिसिन का हेड था. उसी टाइम ये नाम भी बदला था पल्मोनरी मेडिसिन का. उसके बाद एक हरि गौतम साहब, लेट हरि गौतम, he is no more now, he came to KGMC as a vice chancellor. And उनकी आदत थी वो हर विभाग से रात को 7 बजे के बाद अपने डिपार्टमेंट का वो प्रेजेंट करवाते थे. तो मैंने जब प्रेजेंट किया और रात के 9 बजे होंगे, तो हमने प्रेजेंट किया सब क्या है. तो उन्होंने पूछा तेरा ड्रीम क्या है. That was his question. So मैंने कहा सर मेरा ड्रीम तो यही है कि DM का कोर्स शुरू हो जाए. अभी तो हम लोग MD कर रहे हैं, कंट्री के नोन हैं. मेरा ड्रीम ये है कि पल्मोनरी और क्रिटिकल केयर मेडिसिन और एडवांसमेंट हो जाए. दो वी हैव चेंज द नेम ऑफ पल्मोनरी मेडिसिन in KGMC in 2005 itself. और मेरा ड्रीम और है कि हमारा इंस्टीट्यूट आगे बढ़े और हम पल्मोनरी मेडिसिन के उस एक्सटेंट तक जाएं कि लंग ट्रांसप्लांट के बारे में हम लोग हार्ड सोचने लगे. दैट वाज माय. सो वो यही मैंने उनको ड्रीम बताया था. जब तो मैं देख रहा हूँ my 2 students, I think Dr. Suryakant is not here today, but then Suryakant and Dr. Ved, they are really carrying that torch. Especially I would like to talk about Professor Ved Prakash. Professor Ved Prakash, तब तो हम कि भी naturally he is doing wonderful. मुझे याद है 2003 में I was international governor of American College of Chest Physicians for 6 years. I used to visit every year USA, And one of my visit, one of my friend, he took to his clinic in New York, which was known as pulmonary hypertension clinic. That was another something I learned from there. Before that, I was in Japan for about 3 months in the WHO fellowship. I learned a lot because whatever pulmonary medicine you see, because of that my visit. I have told many occasions to you, वो chest department ऐसा chest institute ऐसा था. They say it is a better than Brampton, and it was better than Brampton. उसमें lung cancer के 2 विभाग थे. Believe me, it was a chest institute, and they were small cell and non-small cell के 2 विभाग. Still, I don't see in a country any of the chest institute have such type of department. So, what I'm trying to say, if you see, अगर आप देखोगे तभी आप चेंज कर पाओगे. मैं हमेशा कहता हूँ लोगों को, कूप मंडूक मत बनो. See what is happening in the world, and then you will have some idea. एक मेरे खुशी का कारण और है रविकांत जी. इन्होंने मुझे इस सैपलिंग की प्रथा KGMC में बहुत पहले शुरू हुई. कई बार मैंने अपने भाषणों में कहा, लगता है इनको याद है, सुन लिया, सैपलिंग भाई तुलसी जी का पत्ता दिया करो. You know, this leaf is a very, very important, has a lot of immunomodulators, so many properties. Let me confess. मेरे घर में तुलसी के पेड़ हैं, और सुबह जब मैं उठता हूँ तो 10 पत्ते तोड़ के लाता हूँ और फ्रेश मैं रोज खाता हूँ. तो आज उन्होंने जो मुझे दिया, वो मुझे, इसको मैं ले जाऊँगा अपने घर, जरूर ले जाऊँगा, और उन पेड़ पौधों में इसको भी लगाऊँगा. That's why I said today is my happiest day. And when he asked me, sir, we are doing something in pulmonary hypertension, named as Pulmonary Hypertension Summit, I was literally a very happy person. ये जो मेरे दिमाग में जो ड्रीम्स थे वो ये लोग पूरा कर रहे हैं. मैं ज़्यादा समय नहीं लूँगा. With these few words, I welcome you all sitting on the dais, of the dais, and wish this conference a grand success. Thank you very much.
Thank you, sir, for those words. May I now invite Professor Subhakar Kandi, Professor and Head, Pulmonary Medicine, Kamineni Institute, to address the gathering.
Chief guest of today's evening function, Professor Ravikant, Padma Shri Professor Ravikant sir, the former Vice Chancellor of KGMU. One more Padma Shri, Dr. Rajendra Prasad, my friend Dr. Ved Prakash, and other dignitaries on the dais, and the faculty and the postgraduates. It is indeed a privilege and pleasure for Indian Chest Society to be a part of this Pulmonary Hypertension Summit. I think, as Dr. Rajendra Prasad has already told, that we go to ACCP conference, most of the times we together also attended the ACCP conferences. And if you go to the stalls, the exhibit stalls, a lot of drugs like Ilioprast, all those drugs are there. Unfortunately, none of the drug is available in India. Those are the days. And in fact, I did my post-graduation before 95. At that time, that's the only drug I told is the only calcium channel blocker to treat pulmonary hypertension. And at that time, the pulmonary hypertension is the most neglected disease, and even though the incidence is much more common, unfortunately, we thought that it is a cripple. Once pulmonary hypertension is there, it's going to die with carpulmonale, and ultimately, the only available solution is oxygen. Now, there is a tremendous development in the recent past in the understanding of the pathogenesis and diagnosis and various management molecules, the pulmonary hypertension. I think there's a need for addressing this issue. I think taking this into consideration, I think Dr. Ved Prakash has wonderfully organized this Pulmonary Hypertension Summit. I think it is only a trailer for the lung transplant program which is going to take. Probably that maybe with this in mind, you might have started this Pulmonary Hypertension Summit. I thought actually when Ved Prakash calls, he won't give us a scope to say no. So actually I have a meeting today also in Hyderabad, but for some other reason, and also I will announce that also for that reason. So I have to be here. Seeing his capacity to organize the events, I have been here before one more event which he has organized us. When was that? IPCON. When was it? Which was the month? February, I think. Yeah, almost in February and August, almost he's doing regularly these events. When I enter, this may be a small scale event, but I'm seeing the pharma booths there. I think it's looking like a national conference. Of course, by seeing the faculty, he has involved the renowned faculty, including the international faculty. Knowing these capabilities, when he has submitted a bid for a national NAPCON to organize in Lucknow, I thought even though there are 3 other bidders, I thought there is no other substitute to consider. But as a procedure, we have to go through the governing body meetings and scoring the systems. You know, we have 20 governing body members. 18 of the 20 governing body members have voted for Lucknow to be the choice for as a NAPCON venue. And that too, if you see the scoring, I think I don't want to name the other centers which have bid for this. Most of them got 95% votes to the Ved Prakash. I think I take this opportunity to congratulate Dr. Ved Prakash and of course Chairman Dr. Rajendra Prasad sir with their guidance and with all your support. I think always it's like a family. You work here, that is more of a family atmosphere I see. Darshan is there. You don't leave Darshan. Darshan is going to be a big asset for you. and you can use him for cultural program also, not only academic programs. So I think I have no doubt this going to, so far the NAPCON Hyderabad created history. I hope Ved Prakash will surpass that history and definitely create a wonders. And it's going to be a memorable event in 2027. And with blessings of Ayodhya Rama, I think definitely the event is going to be a wonderful success. In fact, I was asked to speak on Group 1 pulmonary hypertension because most of the topic already is my previous speaker. Then I thought my urge to teach has not ended. That's why I brought a quiz. I conducted a 15 questions quiz. I thought I have set a line above 80% only will be considered for the thing. I must congratulate all the residents here, faculty or senior resident. Everybody casts that 80%. That shows the knowledge and wisdom today the deliberations, how they have concentrated and heard every slide. Unless you go through every slide, you can't answer those questions. So I think 2 people, because I can't give everyone, those 2 people got 100 out of 100. And they, as I announced, they will get a free NAPCON registration for Jaipur. And of course, I request Ved Prakash to give them free NAPCON registration for Lucknow also, 2027 also. So let me read out those names. It's my pleasure to read out those names. Dr. Harshita Kulasteshta. Harshita. Who is there? Come. Harshita, is there here? Harshita. Harshita Kulasteshta is here? Okay. Not here. I think. Okay, TK. Yeah. I don't know that they are aware that those results will be announced. And the second is Dr. Bharat Verma. I don't know. He's here, Bharat Verma? If any of his friends is there, just call them, these two people. Just I want to see them, at least before I leave tomorrow. I want to see them tomorrow. I want their pictures. I want to post on the Indian Chess Society website those pictures. They are the winners. In fact, we conducted a quiz last week. There also we have given pre-NAPCON registrations to encourage young postgraduates. In fact, the ICS is also keen on encouraging the postgraduates who are presenting the papers for all papers which were selected for award at NAPCON Jaipur. We are giving not only free registration, travel and stay also. We want to provide this. This is a commitment from the Indian Chess Society, not getting the funds from the industry. You have to spend in the right way. So I'm very much blessed to attend this meeting today. I'm very much happy. And now I think Ved should start his batting from today and spread this message and see that, of course, I am there always with you, and entire ICS governing body team will be there. You call me any number of times, I will come to Lucknow to help you. Even any number of even in the conference also before 3 days, 4 days also, if you ask me, I will come and stay, because we have an experience of hosting the national events. Of course, you have a better experience. I think 2 experience is better. So we clubbed experience. The NAPCON 2027 Lucknow is going to be a milestone in the history of Indian Chess Society. And unfortunately, because of some events, Sir Ravikant sir, there are some disputes are going on in Indian Chess Society. 2 factions are there. And Ved Prakash has told, with a lot of emphasis, with all the emphasis at his command, sir, in NAPCON 2027, there will be only one NAPCON, there will not be any NAPCON. It really has a lot of it. So I think that will also give it an impetus to get more number of delegates. I'm assuring you, Lucknow, I will get 25 international faculty for you. They will all come on their own expenditure. You not spend anything. I am giving you 25 international. Only just give local hospitality and show them Ayodhya also. Yeah. So with this, I thank for giving me the opportunity, and thanks once again to Veda Prakash for making me a part of this wonderful event. Thank you.
Thank you, sir, for those kind words. We would now like to invite Dr. Basha Khan, sir, Director of Lung Transplant Unit, Narayana Health, Bengaluru, to grace the podium with his few thoughts.
Namaskar. Maybe I will try to speak in Hindi and English. Let's see. Mera career is not as vast as compared to senior dignitaries who are sitting here. I finished my MD in 2003 from Ahmedabad, and I was the first student of Dr. R.N. Solanki. So when I finished, the only thing which was available in pulmonary medicine department or TB and chest was you have to use a bronchoscope, you have to clean it, and with eyepiece. And 4 people will hold the patient, there's no sedation and nothing, you can't monitor pulse ox and all. So after finishing that, I realized, what shall I do? So at that time, I can see that critical care started evolving. And only place in the country where you could do simultaneously pulmonary medicine and critical care medicine was at Delhi Apollo. So I became the registrar of Rajesh Chawla and R.K. Mani. And there I got the first time experience of ICU and all those things, and I continued my pulmonary medicine. And I witnessed that how the kidney transplant and liver transplant was happening at Apollo. So that was gave me some more impetus that I had a dream that I would like to do something in our country also. So in 2007, Dr. Mani suggested that, as sir also says, that you should move out. And he motivated me to go out and see what is happening in other part of the country and the world. So it gave me an opportunity. I attended ERS, and there I got a job offer at Riyadh. Riyadh was the King Faisal, and it was their main tertiary care center, and they used to do lung transplant there. So that was my journey, how it started, and I got my experience for lung transplant in Riyadh. And as sir pointed out, there I could see they were a little bit more ahead in pulmonary medicine. We used to have different clinics for sleep, critical care, you have clinics for transplant, you have ILD clinic and pulmonary hypertension. So there I got the experience of how to deal these individual problems. And when you grow in your path, besides pulmonology, always try to get 2 or 3 more things extra. So I got pulled towards pulmonary hypertension and transplant. Then I went to Toronto for 2 years, and that is considered Mecca. I was the second student at Toronto. First one is Dr. Ramnathan, and now we have a lot of students. I am the second one, and 2017 I finished my training, and I was still not sure what shall I do. Shall I move back to King Faisal or I come back? So always you need a good leader and inspiratory model. So I submit my CV to a couple of places, but I was a bit hesitant because corporate is a bit difficult. So Dr. Devi Shetty called me directly at 4 a.m. Indian time. When I looked at it, it is 4 a.m. in India, and he says that, what is your vision and all? I said, I'm doing this, and I would like to come back to the country and start transplant program. And we had a discussion about 10-15 minutes. So Dr. Devi Shetty will finish these important things between 4 a.m. and 5 a.m. So this is the way he works. So we had a talk, and he said that, why don't you come and meet us? So I came, and I had a whole half day, and he said that, I want to create something, a model which is similar to Pepworth model, where we bring heart, lung in the same unit, and we start transplant, we start ECMO program and pulmonary hypertension. And one of his dream projects besides transplant was doing how to improve the CTEF program. So I joined Narayana, and we did first successful transplant in 2019. A gentleman at age of 67. He was a bit educated. Even he took opinion from Western world. They said that 67 is too far. So he got first heart-lung transplant at age of 67. Now he's 75. He's fully independent and leading a near normal life. No admission for last 6 years. So this is the way we have developed our lung transplant program. Another important gentleman who has molded my career is Dr. George Cherian, if anyone is from cardiology. So he was the first cardiologist of the country from CMC Vellore. So he was practicing till post-COVID, and CTEF was his brainchild. So he handed over the baton to me in 2022 that it is becoming difficult, and he passed away 2 years back. But he was quite active till age of 86 and all. So now we are becoming, we are proud to say that we see around 250 CTEF patients. I have a database of PH patients, more than 100. And we are reasonably doing okay in heart-lung transplant. So what I'm trying to share is, if you have a vision, you have a leader on top of you who can support you, then there's no ending. And the current generation is so lucky, like I have to go to different places, so to get exposed to ICU, to transplant, to ECMO, to pulmonary hypertension, while the current era of doctors, those who are getting trained with us, they have all the exposure in their training program. So you are lucky, and should be, you should utilize this opportunity and take the healthcare to the next level. Thank you very much.
Thank you, sir. We would like to take this opportunity to welcome Professor Suryakant sir, Professor and Head, Department of Respiratory Medicine, KGMU, and co-organizing chairman of PH Summit, whose work in clinical care, teaching, and research has been an integral part of the department's continuing journey. Sir, we would like to invite you on the podium to speak a few words.
Very good evening to all of you, and really I want to congratulate Dr. Ved Prakash, who has been our teacher. I think 2 teachers are here on the dais, and 2 mentors are here on the dais. 2 mentors means Dr. Rajendra Prasad and Dr. Ravi Kant. And it will be a great honor and privilege for all of us that both are Padam Shri awardees. So have a grand round of applause for a dais which is not having 1 Padam Shri but 2 Padam Shri awardees, and both are mentor of myself and Dr. Ved Prakash. And we have a 1 elder brother here on the dais, that is the dynamic, vibrant, I would say national and international leader of chess fraternity, Dr. Sudhakar Kandi, who is the man behind the architect of Indian Chess Society, propagation, I would say everything. You just think of any activity of Indian Chess Society and you will find men behind the scene, or sometimes men in front of the scene, in front of the curtain. That is Dr. Kandi. And yes, all the delegates from outside, my some colleagues and dear students. The pulmonary hypertension, once upon a time, was considered as a rarest lung disease. I still remember around 20 years back, when there was usually a press conference on the day that is called World Rare Disease, and when we used to discuss 2 diseases, idiopathic pulmonary fibrosis and pulmonary hypertension. The days have gone. Because at that time, the awareness of the medical fraternity, awareness in the society was not there for these 2 diseases, and that's why they were considered as rarest lung disease or rare lung diseases. But now the days have gone, and I think Dr. Ved has rightly chosen the topic of this subject, the CME, and I think the focused basically not only for the pulmonologist but for cardiologist, the physicians, and even the physiologist, everyone. I used to say in a very lighter note to the cardiologist. Any cardiologist here? No one? Ved? Kal to the press conference mein? Okay. So to my cardiologist friend, I used to say in lighter mode that, dear Dr. Cardiologist, you are not cardiologist, you are hemicardiologist. They said, why? Because right-sided heart belongs to us. We are responsible for failing your right-sided heart disease, right heart. Because chronic respiratory diseases ultimately leading to the right heart failure, ultimately congestive heart failure. And even the pulmonary hypertension is being diagnosed earlier than the cardiologist, because cardiologists now they are directly calling the patient and rather jumping from the parachute directly into the cath lab. And we are still in the era of taking proper history, doing physical examination. We are the display of Dr. Rajendra Prasad, so we are following still that teaching. And that's why shortness of breath is there without any apparent cause. Think of pulmonary hypertension. If you have ruled out the all important causes, common causes of shortness of breath, then of course think of pulmonary hypertension. So this teaching of course tells you a lot for this early diagnosis of pulmonary hypertension. And now a newer research has come, and everybody knows that there are 5 groups of pulmonary hypertension, and third group is basically due to chronic respiratory diseases. So at least 1/5 of cases are being treated by us. So thank you, Dr. Ved, for this wonderful organization, and keep on. Dr. Ved is very, I would say, is a kind of showman, and I'm lucky that I am his founder head of department, courtesy due to Ravi Kant sir. When this department was created, Ravi Kant sir trusted upon me, and he gave me the charge of this department. And from 16 to 19, I was the founder head of Department of Pulmonary and Critical Care. And then later on, I handed over to the competent, dynamic, vibrant Dr. Ved, who is continuing the legacy of not only Dr. Rajam Shah, Dr. Surikant, but even the national and international legacy. Thank you and all the best, Ved. Thank you.
Thank you, respected sir. We now proceed with the presentation of mementos to our distinguished dignitaries as a token of our gratitude for their presence. May I request Dr. Ved Prakash sir to kindly proceed with the memento presentation. We would like to present a token of our appreciation to Dr. Ravi Kant sir. I would request sir to present with a token of our deepest respect to Dr. Subhakar Kandi sir. We would like, sir, to felicitate Dr. Suryakant, sir, with the token of our appreciation. We would now request, sir, to felicitate Dr. Suryakant, sir, with the token of our appreciation. We would now like to request, sir, to felicitate Dr. Basha, sir, with a token of our deepest gratitude. We would now like, sir, to felicitate Dr. Rajendra Prasad, sir, teacher of teachers, with the token of our deepest appreciation and gratitude. And now, we would request our esteemed dignitaries to felicitate Dr. Ved Prakash, sir, with a token of our appreciation and love. Thank you, respected dignitaries. And now we come to the concluding address of this inaugural ceremony. We would now invite Padma Shri Professor Dr. Ravikant Sir, Chief Guest, PH Summit, former Director, AIMS Rishikesh, and former Vice Chancellor, KGMU, to share his thoughts with us. Welcome, sir.
Very distinguished Padma Shri Professor Rajendra Prasad ji, once a chief, always a chief, not only organizing chairman, but I would say he has molded and mended SAFI and then Patel Chess Institute, and I have seen him really going out of way to do beautiful things. Very distinguished Professor Dr. Suryakant, co-organizing chairman, and a scholarly person who often writes multiple books, very active and very positive in nature. Professor Dr. Subhakar Kandi, who is one of the key person in pulmonary, respiratory, chest area in all over India. We welcome you and we are delighted that you are with us. Dr. Fayaz, who is a radiology professor, and what a beautiful lecture we saw today. Very instructive, very constructive. And one of the most dynamic person I have seen in my life, who have contributed in a very positive and measured way. Both things are important, constructive, positive, measured way. Professor Dr. Ved Prakash, who is not only organizing secretary, but I would say a leading light now in the country as to how the future should be. And that's how things go on. Recently, I was in a big mall, two of them, Costco as well as Sam's, and I was seeing where most of the people are buying, what they're buying. What they're buying is a ring. It's called Aura ring, O-R-R-A. And this app gives to a sensor app in your phone, it gives you all the data. It was somewhere between $400 to $500 US, and became almost fashionable for many to wear that ring, which has nothing relation with either astrological or relation. No, it is just Aura ring everyone is using. Then when I was seeing the football match in World Cup, I learned one more thing. There was a great article on why these top 5 footballers and also the bottom 70 are wearing a bra. And that was very concerning to me as to what they are trying to say. So there was a sensor here in the back. So if you see the coach of all the top clubs, the coach is seeing the tactic as on the game. The assistant coach is working only on video and the tactics, but there was a third person sitting there. If you focus clearly, he was only on computer. So out of all team, 11 of them are playing. This sensor will tell you who should be given rest now. Take out, come back later. Who is tired that he will not perform anymore. So all hemodynamic, physiological, respiratory, cardiology, muscle, every data fed by this. So that bra concept of wearing a thing looked very, very interesting to me, that this is the way future our diagnostic will be, that before doing a CTA or before doing anything else, color Doppler, we will come to know what exactly is happening in the body. Then the third thing I saw, one of my friend, he was using a chip all the time. It is just like AirTag of Apple. They use it here and give them not only constant insulin and blood sugar level, but they also give you much more advanced data as to what is happening to you. The fourth one was the patch, which I see that many were using, and it was just transmitting a sensor all the time on the app. And what Dr. Chandola was speaking was really mesmerizing, that there will be, we can 15 minutes before in the active World Cup football game between top two leaders, we can identify who is now not going to give benefit to your team. We can know. So he should be out, even if it is a top footballer like Messi. So when Messi is off the field, that is decided less by, I would say, the game trend, but also by what is happening there in the data field. So a lot of computer gamut going on into that. So what does it tell us? What does it tell us? That future will be much more non-invasive, but I would say exhaustive data workup of what we can see. We started learning color Doppler in 1987. We were given a color Doppler, a very big color Doppler, Aloka, in a surgery department, and all of us used to seeing abdominal, laparoscopic, vascular, all things ourselves. We will not say, so it is a learning process, and gradually became quite vast, started to know where is the fluid, what is happening, what is not happening, where is the clot, and we could see very easily things. Now with these sensors coming in a very big way, that you can see whether the samosa did more harm to your blood sugar or the jalebi, and they can be a diagnostic data that this eat and that is the volume. And therefore the food nowadays we divide into what is the glucose ascendancy level. So if a simple food like tarbooj and kharbuja, now they give a very shoot up of sugar, although it is supposed to be very benign fruit. But when you see the data, you find, oh, things are changing dramatically. So what is important is, why this meeting is so important, that we need to constantly work up on what is happening in the world. Like when Abhishek Tandon was speaking about the monoclonal antibody in eosinophilic lung, I think that was very interesting from a concept point of view, that yes, we can change even that. Whereas earlier we used to say, eosinophil is high, so give him some anti-worm drug. That was all people used to do, I would say, in 1972 or 73. That was the treatment. He is having asthma, eosinophil is high, give him anti-worm drug, and that is all. And then we learned Loeffler syndrome and so on and so forth, and gradually we went into deep of it, and we learned about mast cell, and then mast cell broken theory and mast cell stabilization syndrome. But end point is, today is a world where you have to again follow the Socrates. And what Socrates said, I really like this sentence very much. One of the topmost philosophers of Greek era, he is just saying, the only thing I know, that I know nothing. And this concept of humility, of desire to learn, of desire to adapt, of desire to flexibility, that is what the future will be. And therefore, when my grandsons and other, when they come to me, I say, the key thing what will make you different is your curiosity factor and not what is your knowledge factor. Because knowledge factor now is in the Google uncle. You can get the data quickly. But curiosity factor is, therefore future jobs will be those who are curious, who can design the software of AI. They will be required instead of those who are using the AI, they'll be out of the job. Who design the AI, they will be in the job. That is what I see the future will be. So the future is curiosity. Future is thinking what is not there. And similarly, when we were managing trauma in Saudi Arabia, we saw the patient and suddenly we find ultrasound then and there on the reception area. CT, then and there on the reception area, MRI, then and there reception area. It doesn't matter how many CT are. When I was working in Maulana Azad Medical College for more than 20 years, we had 4 CT and 3 MRI in the campus. So there were not a few, there were a lot of them. Anywhere you go, you'll get it. And if you want something to be done in 5 minutes, it will be done. That was something like a prompt. But yes, because there are 400 patients in a single unit to see in a day, so otherwise there is a list. But if you want something, it will be done quickly, within 5 minutes. There will be no confusion about that. So the future lies in curiosity. Future lies in saying, I don't know. Can the resident say this word? I don't know. Can the faculty say this word? I don't know. Can the head of department say, I don't know? It's very difficult for head of department to say, I don't know. Because that ego clashes with the Socrates. Right? And that is what Socrates will say. That is what I say. Having worked almost 15 years abroad, out of country, when I came here, my desire was that KGMU should mimic one of the best universities in the world. It should not simply be one of the universities. It should be top 5, top 3, top 2, and we worked on that. So first constructive agenda, which we brought in Executive Council, it has 45 points to bring what is not there. ACLS, PALS, ATLS, BLS, everything. So even your clerk and driver should do BLS. Now, in future, when we did the BLS exam time and again, there were no doctors as the examiner in future. Even today, most of the places, ACLS, this doctors are not required for examination. For OSCE, doctors are not required for examination. Anyone can do once it is constructively decided. OSCE is one of the most difficult things to design so that you can test the student's strength seriously. Because answer is, if you answer by here, this is MCQ, even if it is there in the OSCE, like specimen, etc., they are there from here. What you do by hand is OSCE. It's very simple. So classification is so simple, and therefore designing is so difficult. So I hope the pathway which is shown by Professor Ved Prakash in developing newer points in established and newer diseases, and very, I would say, generously patronized by our Honorable Vice Chancellor, Professor Sonia Nityanand, and Professor Behera, who has been one of the kindest person and the best person I have known in my life so far. And here, a constant encouragement by Professor Rajendra Prasad and Professor Surikant, and nationally governed by Professor Dr. Subhakar Kandi and Professor Dr. Dhruv Chaudhary. And here, in addition, we have specialists coming like Dr. Rahul Chandola and Dr. Fayaz from Radiology Department. I think that is what a combination is required. I congratulate Ved for doing such a fantastic job, and it is really a privilege to be here again in Alma Mater and thinking about the moment HOD says, I don't know. That is the day of improvement of that department. Thank you.
Thank you, sir, for those wonderful words. To formally conclude this ceremony, I invite Professor Ved Prakash, sir, Organizing Secretary, PH Summit 2026, to deliver the vote of thanks.
थैंक यू डॉक्टर हर्षिता। काम भी कई सारे मेरे पास रहते थे सर, मुझे कहते थे कि तुम जाओ करो, और मुझे याद है कि 450 करोड़ का बजट होता था एनुअल केजीएमयू के लिए, और 3 साल बाद जब सर ने छोड़ा तो 850 करोड़ का एनुअल बजट करके छोड़ा था। तो अगर इन आंकड़ों को आप देखेंगे तो आपको ये लगेगा कि किस तरह से गुणात्मक वृद्धि की बात हम लोग सुना करते थे कि दिन दूना रात चौगुनी तरक्की होती है कभी, तो शायद ये वही वक्त था 2014 से लेकर 17 का कि जब केजीएमयू ने दिन दूना रात चौगुना तरक्की का जो एक मार्ग प्रशस्त किया और आज KGMU इस लीडरशिप पोजीशन में आया। नहीं तो मुझे पता है कि PGI के वहाँ पे जब ट्रॉमा सेंटर का चार्ज दिया गया KGMU को कि PGI वाज अनेबल टू रन दैट ट्रॉमा सेंटर बिकॉज ऑफ सम रीजंस, तो KGMU को सरकार ने कहा कि अब आप चला सकते हैं क्या? तो सर ने 1 मिनट भी नहीं लगाया, उन्होंने कहा कि बिल्कुल चला देंगे, कोई दिक्कत नहीं। तो जब चार्ज दिया गया तो वहाँ पे हम लोगों की मीटिंग हो रही थी, तो एक बहुत बड़ा डिफरेंस था संजय गांधी PGI और KGMU के स्टेटस में, बहुत बड़ा डिफरेंस था। मुझे आज भी याद है कि सर के जूनियर हुआ करते थे डायरेक्टर साहब वहाँ पे, लेकिन उन्होंने एक वर्ड कहा था कि संजय गांधी PGI एक बड़े भाई की भूमिका निभाता रहेगा अनवरत रूप से KGMU के लिए। और जब सर लौट रहे थे तो मुझसे सर ने कहा कि ये बताओ कि विभाग कितने हैं हमारे यहाँ? कि हमने कहा सर अब तो 70 हो गए, 75 हो गए, 80 हो जाएंगे, 84 हो जाएंगे। बोले PGI पे कितने हैं? मैंने कहा अभी तो 18 डिपार्टमेंट हैं। कि बोले बड़ा भाई कैसे हो रहा है इसमें, छोटा भाई बड़ा भाई का कैसा ये? तो मैंने कहा सर ये अभी इवॉल्व हो रही हैं चीज़ें क्योंकि PGI को जिस वजह से बनाया गया था एक दूसरे मैंडेट के साथ था, और PGI में दूसरी जो एक कंपैरिजन हम लोग करते थे कि पर बेड जो खर्चा है, जो सरकार जो ग्रांट देती है, वो पर बेड हमारे पास 4,500 बेड हैं KGMU में, PGI में 1,000 बेड हुआ करते थे, लेकिन 4,500 बिस्तरों पे जो पैसा मिलता था ग्रांट सरकार से, उससे ज़्यादा पैसा 1,000 बेड पे वहाँ मिलता था। अभी भी मिलता है सर। और इसके बावजूद PGI का जो PGI का जो स्ट्रक्चर है, PGI का जो आप देखेंगे कि जो पेशेंट से जो पैसा लेने का उनका जो स्ट्रक्चर है वो कॉरपोरेट के बराबर है। अगर किसी ने वहाँ पे इलाज कराया हो तो लोग जानते होंगे कि जब हम लोग ये डिपार्टमेंट बनाने का जो एक सपना था राजेंद्र प्रसाद सर और सूर्यकांत सर ने जब देखा था, तो उस समय भी मुझे ये बड़ा कष्ट था PGI में कि हमें जो पैसे वाला मरीज होता था उसी को हम लोग भर्ती करते थे। इमरजेंसी में पेशेंट लेने जाते थे, अगर कोई नौजवान है, पैसा नहीं है, बच सकता है, लेकिन उसको वेंटिलेटर नहीं मिलता था। कोई नहीं बच सकता है, बुजुर्ग हैं 80 साल के, लेकिन पैसे वाले हैं तो उनको वेंटिलेटर मिलता था। ये वहाँ की रियलिटी थी। डॉक्टर अनंत मेरे बैचमेट हैं, वहाँ पे थे, वहाँ पे लगातार रोजाना हम लोग इन चीज़ों से 2-4 होते थे और बड़ी पीड़ा होती थी कि जान बचाने में जहाँ जिनकी हम जान बचा सकते हैं उसकी नहीं बचा पा रहे हैं, उसे नहीं दे रहे हैं, और जिससे नहीं देना चाहिए उसको हम लोग वेंटिलेटर दे रहे हैं। तो ये एक सवाल था और एक स्टेटस की बात थी कि किस तरह से एम्स की बराबर तनख्वाहें KGMU को मिले। आप KGMU में काम ज़्यादा होता है सर, इस बात से प्रसाद सर और सूर्यकांत सर भी इस बात को मानेंगे कि KGMU के जो डॉक्टर्स हैं ज़्यादा मेहनत करते हैं, ज़्यादा पेशेंट देखते हैं, ज़्यादा थ्रेट में रहते हैं, ज़्यादा सभी जितने भी एफर्ट्स करने हों, चाहे एक सोशली इंटरेक्ट करना हो, चाहे आउटरीच प्रोग्राम्स में हो, KGMU के ज़्यादा कंट्रीब्यूशन थे। लेकिन 2M दर्जे की सैलरी मिल रही थी यहाँ पे। हम लोग कितना भी बड़े हो जाते, लेकिन बड़े भाई तो नहीं बन पाते अगर उनकी सैलरी ज़्यादा रहती और हमारी कम रहती। तो बराबरी का रिश्ता तो तय करने के लिए जो एफर्ट किए गए वो सर के द्वारा मुझे पता है किस तरह से कितनी लड़ाई लड़ी गई इसको लेकर के। और एक बात बहुत खास थी उस समय कि जितने भी फैकल्टी, जितने भी HODs थे, सब लोग बिल्कुल ऐसी लीडरशिप में थे, सब लोग बिल्कुल इतनी बड़ी टीम लेके चलते थे कि जब सर को ये मीटिंग करनी थी सरकार में तो 12 HOD उसमें दौड़ रहे थे जाकर के कि हम लोगों को मीटिंग करानी है। इस तरह के एफर्ट्स मुझे लगता है कि कभी ऐसे देखने को नहीं मिले कि कितनी बड़ी टीम हो सकती है एडमिनिस्ट्रेशन में, कितनी बड़े एफर्ट हो सकते हैं, कितने लोगों के एफर्ट हो सकते हैं। तो मुझे लगता है कि असली लीडरशिप हम लोगों ने अगर सीखने का अवसर मिला तो सर रविकांत सर के साथ ही हम लोगों को काम करके मिला कि कितनी बड़ी टीम को उन्होंने लीड किया है, कितने लोगों को यहाँ पे उस लीडरशिप को दिया है मौका। मुझे याद है कि सर कहते थे कि सुबह 7:30 बजे बैठ जाते थे ऑफिस में, 7:30 से 12 बजे तक। मैं कहता था कभी कि सर एक इश्यू डिस्कस करना है। बोले कि क्या है? मैंने कहा ये। बोले देखो फायर फाइटिंग वाला काम 12 बजे के बाद आना तुम, अगर तुम्हें कोई फ्यूचरिस्टिक बात हो तो आ जाओ। उन्होंने तय कर दिया था कि 7:30 से 12 बजे तक अगर कोई आएगा तो फ्यूचरिस्टिक कोई प्लान लेकर के आएगा, वो डिस्कशन होगा, ये स्लॉट रहता था। और 12 बजे के बाद ही कोई ये रोजमर्रा की फायर फाइटिंग, ये 12 बजे के बाद 12 से 6 बजे 7 बजे तक बैठना होता था, वो बैठते थे। लेकिन इसके लिए समय निकालते थे। मैंने देखा है सर को काम करते हुए कि 7:30 बजे से लेकर के शाम के 7-7:30 बजे तक काम करते हुए सर को लगातार देखा अनवरत रूप से।
अगले दिन सुबह 4 बजे से सर के मेल आने लगे
और 4 बजे से मेल। तो सब लोगों को लगता था कि ये हो कैसे रहा है, कैसे चल रहा है ये काम। मतलब कोई एआई तो उस समय था नहीं चलन में कि पता चल रहा है कि एआई को लगा दिया रात में कि तुम मेल डालते रहना। तो सर के लगातार रात से फिर मेल चालू हो जाए। और अखबार की जो कटिंग होती थी सर, आपको याद होगा कि जब अखबार सुबह 5-6 बजे जिस डिपार्टमेंट का छपा है कहीं, अगर कोई एडवर्स है उसका तुरंत फोटो और सीधे उसके व्हाट्सएप पे कि इसमें करेक्टिव मेजर कैसे लिया जा सकता है। इसलिए नहीं कि थ्रेटन करना है या कैसे कर दिया तुमने, क्यों हो गया, ये सवाल बाद में। पहले करेक्टिव मेजर्स हैं कि कैसे इसको ठीक किया जाए, कि इसका जवाब भी देना होगा कि कल को फॉलोअप की खबर क्या जाएगी, इसको आप बताइए कि क्या करेक्टिव मेजर्स हुए, वो तत्काल लेना। ये सब चीज़ों को मुझे लगता है कि हम लोगों ने जितना विटनेस उस समय किया, और एक छोटे भाई से लेकर के जेमिनी कॉन्टिनेंटल में आपने एक प्रोग्राम कराया था, वहाँ के हेड उसमें थे। पीजीआई वालों ने क्वेश्चन किया कि सर अखबार की खबर पढ़ी हमने कि केजीएमयू 50 वेंटिलेशन किया, सरकार की नज़रों में कि जो हमारा कैंसर संस्थान था, अगर एक कार्यकाल और मिल गया होता तो मुझे लगता है कि वो सेकंड कैंपस बन जाता। सर आप मानते हैं इस बात को? नहीं सूर्यकांत सर, अभी तक जो लड़खड़ाहट के साथ खड़ा हो रहा है, गिर रहा है, खड़ा हो रहा है, गिर रहा है, खड़ा हो रहा है, गिर रहा है, ये नहीं होता शायद। और मुझे लगता है कि जो एक यूनिवर्सिटी और बनी है, एफिलिएटिंग यूनिवर्सिटी, वो पूरा कैंपस आज केजीएमयू का कैंपस होता। केजीएमयू अकेली एफिलिएटिंग भी होती और हॉस्पिटल भी होती। ये भरोसा हम लोग जरूर उस समय करते थे। और जहाँ से निकल जाते थे उस समय मुझे याद है कि सर जब ट्रॉमा सेंटर से होकर के गाड़ियाँ लेकर के पूरा, क्योंकि 10-12 एचओडी चलते थे साथ में, 10-12 गाड़ियाँ उनकी हो जाती थी, तो हम सब लोग पूरा प्रशासन, तो केजीएमयू जब मूव करता था तो 20-25 व्हीकल हो जाते थे, तो बिल्कुल एक कन्वॉय की तरह से चलते थे। और जो कन्वॉय वहाँ से निकल करके जो एक मात्र शिशु जो अभी हॉस्पिटल है, जो आपके शहीद पथ वाला, जब वहाँ से निकल करके वहाँ गए आपके कैंसर संस्थान की तरफ, वहाँ की तैयारियाँ चल रही थी उसको इनॉग्रेट कराने के लिए, तो वहाँ से किसी ने खबर कर दी कि केजीएमयू वालों का काफिला उस मात्र और शिशु वाला जो हॉस्पिटल है उस पर होके निकला है। अब इनकी नज़र यहाँ पड़ गई, अब लग रहा है केजीएमयू इसको भी एक्वायर करने वाला है। तो वहाँ के लोग मुख्यमंत्री जी के पास पहुँच गए कि ये हमें दे दीजिए आप, जिसे कोई नहीं चलाना चाह रहा था। उन्हें कहा कि कुछ तो हम भी ले लें, हम भी चलाएं। एग्रीमेंट तैयार हो रहा था, वहाँ से सरकार ने सोच लिया कि इन्हीं को दे देते हैं, कोई नहीं चल रहा है। तो केजीएमयू एक ऐसा भरोसा बन गया था कि जो बीमारू है या जो बंद पड़े संस्थान है या ऐसी जगह है जो यूटिलाइज नहीं हो पा रही, उसको कैसे यूटिलाइज किया जाए, उस दिशा में अगर कोई भरोसा किसी संस्थान का था तो सरकार को, राजभवन को, उसी केजीएमयू पे था, जिस केजीएमयू ने एक धीरे धीरे उड़ान भरना शुरू किया था, एक टेक ऑफ किया था। लेकिन ये हम लोग, मैं तो कहूँगा, सर भी कहेंगे कि एक दुर्भाग्य की तरह रहा कि अगर इस लीडरशिप को शायद और मौका मिलता एक, तो आज का केजीएमयू कहीं और केजीएमयू होता। आज जो हम लोग बात कर रहे हैं कि लंग ट्रांसप्लांटेशन की, उसको लेकर के हम लोग कई साल से लगातार 2018 में सर मैंने विजिट किया जो ह्यूस्टन का सेंटर, सैन एंटोनियो का सेंटर, 2011 में मैंने विजिट किया क्लीवलैंड क्लिनिक लंग ट्रांसप्लांट के लिए। हमारे रिश्तेदार का वहाँ पे 8 करोड़ में लंग ट्रांसप्लांट हुआ एक का। 2 करोड़ रुपया मुख्यमंत्री जी ने दिया अभी, और हैदराबाद में किम्स में भेजा उस लड़की को, लेकिन पूरा पैसा खर्च हो गया आईसीयू में एक्मो पे, लेकिन ट्रांसप्लांट नहीं हो सका। इस दर्द को लेकर के जब हम लोग पीजीआई से निकले तो उसको उड़ान देने का काम, उसको आगे बढ़ाने का काम प्रोफेसर रविकांत सर की लीडरशिप में, प्रोफेसर राजेंद्र प्रसाद सर के मार्गदर्शन में और सूर्यकांत सर और हम सब टीम ने मिलकर के उसको एक सच्चाई बनाने का काम किया। ये विभाग आज जो आपके बीच में है, ये विभाग उसी प्रयास के उसमें है। और मैंने सर से कहा था, सूर्यकांत सर से, कि सर ये जो हम लोग एडमिट कर रहे हैं, यहाँ पे गरीब को वेंटिलेटर नहीं मिल रहा है पीजीआई में। केजीएमयू में ये वेंटिलेटर क्या हम दे सकते हैं गरीब को? आपको खुशी होगी आज जान करके, हमारी पूरी टीम बैठी है, पीजीआई से भी हमारे यहाँ पे फैकल्टी हैं 2। आज विभाग का जो सक्सेस रेट है 85%। 85% पेशेंट्स को हम लोग आउटकम के साथ हैं। 7% पे हमारा वेब का है सर, अप टू 14% अमेरिका के हॉस्पिटल्स में वेब का रेट है। वेंटिलेटर एसोसिएट निमोनिया को हम लोगों ने कंटेन किया है 7% पे, लगातार 3 साल से 7%, 8%, 9% इसी पे रुका हुआ है वेब। अगर आज हम लोग लंग ट्रांसप्लांट की बात कर पा रहे हैं तो शायद इसको कंटेन करके, और ये अगर संभव हुआ तो इसलिए हुआ कि उस डेफिनेशन को बदलने का काम हम लोगों ने किया कि वेंटिलेटर उसी को मिलेगा जिसकी जान बच सकती है, जो साल्वेजेबल है उसको वेंटिलेटर मिलेगा। हम लोग इसको एक डंपिंग यार्ड या ग्रेव यार्ड नहीं बना सकते, क्योंकि बहुत पैसा सरकार का भी लगा है, बड़ा संसाधन है, बड़ी टीम है, उसको सस्टेन करने के लिए बहुत खर्चा हो रहा है। आज मैं अपने दिल की बातें थोड़ा सा ज़्यादा बोल रहा हूँ, क्योंकि आज ये मौका है कि आज ऐसी लीडरशिप, ऐसी शख्सियत हम लोगों के बीच में सभी लोग हैं, और इसलिए मैं ये दिल की बातें कर पा रहा हूँ कि अगर वो समय न होता, अगर ये मौका न होता, तो शायद आज हम भी नहीं होते, ये विभाग भी नहीं होते। आज ये नए नए जितने विभाग बन गए, जितनी सीटें केजीएमयू को मिल गई, और अब शायद जो बड़े भाई बनते थे तो वो थोड़ा सा घबराते हैं बड़ा भाई कहने में अपने आप को, तो मुझे लगता है कि ये मौका भी ना आता। और आज अगर हम देख पा रहे हैं कि अगर ये गरीब को वेंटिलेटर मिल सकता है, तो जो 8 करोड़ में हमारे रिश्तेदार थे उनका जो फेफड़ा प्रत्यारोपण हुआ अमेरिका में, तो क्या वो गरीब को पहुंच सकता है क्या? तो मुझे लगता है कि हम यहाँ तक आ गए हैं घिसटते घिसटते कि वेंटिलेटर एक गरीब को पहुंचा सके हैं, तो शायद एक गरीब का फेफड़ा प्रत्यारोपण भी एक जिस दिन हो जाएगा तो मुझे लगेगा कि हम लोगों का काम काफ़ी हद तक पूरा हो गया है। और इस टीम को आप आशीर्वाद दीजिए, पूरे जो डिग्निटरीज हैं सब आशीर्वाद दें हमारी टीम को कि हम लोग इस काम में सब लोग मिलकर के सफल हो सकें। और मैं अपनी टीम का भी आह्वान करता हूं कि हमारी टीम, आप एक ऐसी टीम का हिस्सा होंगे कि जो ऐसी लीडरशिप को खड़ा करेगी कि जो एक गरीब के दुख और दर्द को अपना दुख दर्द समझते हुए उसकी दवा कर सकेगी। इस तरह के प्रयास के साथ मैं प्रोफेसर रविकांत सर को बहुत बहुत धन्यवाद देता हूं, जो अमेरिका से आए हैं सीधे। सर का पर्पस दूसरा भी था, राजभवन में किसी एक यूनिवर्सिटी का सर्च कमेटी है शायद, उसकी भी कल मीटिंग है। एक पर्पस वो था, और सर रात में लैंड हुए दिल्ली और सीधे यहाँ पर। और कैसा सौभाग्य है कि आज का इज्जत बचाने का काम जो प्रोग्राम का हुआ वो भी सर के हाथों ही हो गया, क्योंकि कुछ लोग व्यस्त हो गए और कुछ लोग एक मुश्किल में फंस गए जो नहीं पहुंच पाए मौसम की मार की वजह से, तो उसका भी इज्जत बचाने का काम हुआ। तो इसलिए हुआ। और राजेंद्र प्रसाद सर तो बहुत लकी हैं, हम लोगों के लिए फादर फिगर हैं, हमेशा ही वो तैयार रहते हैं। कोई भी प्रोग्राम हो, कितना भी हम लोग परेशान करें, वो कभी परेशान होते ही नहीं हैं हम लोगों से। 29 साल हो गया मुझे देखते ही देखते, लेकिन आज भी वो ऐसे ही हैं। और इसका राज वो बार बार बीच में बता देते हैं कि अगर आप सीखते रहोगे, सिखाते रहोगे तो यंग बने रहोगे। तो एक हम लोग कहा करते थे कि फ्लाइंग चेस्ट फिजिशियन, कि एक पैर उनका जहाज में रहता है, तो शायद वो अभी भी कंटिन्यू कर रहे हैं, इतना ट्रेवल करते हैं कि जितने भी डिग्निटरीज होंगे उन्हें लखनऊ में मुलाकात नहीं होगी, लेकिन कहीं ना कहीं मुलाकात जरूर ही होगी कि पिछले हफ्ते कहीं हैदराबाद में हो जाएगी, उससे पहले कहीं एमपी में हो जाएगी, इसके बाद कहीं गोरखपुर में हो जाएगी, किसी से आप पूछ लीजिए, सबके साथ मिले होंगे। लखनऊ में भले ही नहीं मिल पाते हैं, लेकिन बाहर जरूर मिल लेते हैं, क्योंकि हर मीटिंग में उनका होना होता है। और जब पद्मश्री की घोषणा हुई तो सर बहुत भावुक हो गए, और एक लाइफ टाइम अचीवमेंट की बात होती है। चेस्ट के फील्ड में 3 सिर्फ पद्मश्री, एक हमारे बेहरा साहब जो सबसे पहले जिनको मिला, इसके बाद गुलेरिया साहब, बड़े संस्थान के लोग हैं, बड़े लोग हैं, लेकिन केजीएमयू को भी इस एलिट क्लास में जोड़ने का काम आपने किया है सर। मैं आपको बहुत बहुत धन्यवाद देता हूं इसके लिए कि हमारे बीच में हमेशा, हमारी टीम को हमेशा आपने मार्गदर्शन दिया है, आगे बढ़ाने का काम किया है। प्रोफेसर सूर्यकांत सर, जब हम लोग रेजिडेंट होते थे, राजेंद्र प्रसाद सर हेड होते थे, तो हमारी हिम्मत नहीं होती थी कि हेड साहब के कमरे की तरफ चली भी जाएं, दिख भी जाएं कहीं दूर से कि हेड साहब का कमरा है, उधर हम लोगों को दिखना भी बढ़ जाता है। चीफ साहब ने ऐसा टेरर बता दिया था पहले ही कि उधर दिख न जाना बिल्कुल, तो हमारी हिम्मत होती थी। तो नंबर दो पे थे प्रोफेसर सूर्यकांत सर, और उन्होंने एक आउटरीच से लेकर के, एक मुझे याद है पहली जब क्लास हम लोगों की हुई थी, जब हम लोगों ने ज्वाइन किया था, सर कहते हैं कि एक थोड़ा सा अंडरमाइन करके इस एमडी रेस्पिरेटरी को देखा जाता था उस समय, और सर ने हम थोड़ा सा हौसला बढ़ाने का काम किया। पहली मीटिंग में ही उन्होंने कहा कि आप लोगों ने चूज किया है रेस्पिरेटरी मेडिसिन को, दिस इज नॉट ए स्पेशलिटी, रादर ए सुपर स्पेशलिटी। अब आप एक सुपर स्पेशलिटी का हिस्सा हैं, तो सर मेरे को वो वर्ड आज तक आपके याद हैं। शायद उन वर्ड्स को हम लोगों ने आत्मसात करने का काम किया कि आज इस विधा की जो इज्जत है, ये सम्मान है, वो कहीं ना कहीं एक सेंटर स्टेज पे आता हुआ दिखाई दे रहा है। और वो इसीलिए है कि शायद हम लोग एक गरीब के दुख दर्द में शामिल होने के लिए कोशिश कर रहे हैं। और वाइस चांसलर केजीएमयू का बनना एक बड़े प्राइड की बात होती है। राजेंद्र प्रसाद सर का भी नाम आ चुका है, मुझे लगता है एक बार तो हमने पढ़ा था सर, 2 बार आया, एक बार आपका, 2 बार केजीएमयू के वाइस चांसलर बनने की रेस में राजेंद्र प्रसाद सर रह चुके। और आपको खुशी होगी, हम लोगों को बड़ा इसमें प्राउड फील होता है कि ऐसा स्ट्रांग जो कैंडिडेचर है हमारे सूर्यकांत सर, लगातार कंजिक्यूटिवली 3 बार उन्होंने अपनी काबिलियत, अपने जो बायोडाटा है उसके दम पे, कोई काट नहीं सका, उनको काटने की बहुत कोशिश हुई, लेकिन 3 बार वो सेलेक्ट हुए हैं, 3 बार इंटरव्यू में गए। मुझे लगता है सर ये 3री बार का होगा आपका, फिर से होगा। हम लोगों को ये प्राउड फील होता है कि क्या चेस्ट के लोग भी कॉम्पीट कर सकते हैं वहाँ पे। हम लोग, मुझे याद है राजेंद्र प्रसाद सर भी इस बात को कहते हैं कि टीबी विभाग था और कई लोग सर को और भी कुछ मिल रहा था, लेकिन टीबी ले लिया उन्होंने डिपार्टमेंट। तो बाद में सब लोगों ने बहुत गालियाँ सुनाई उनको कि कहाँ चले गए वहाँ पे। तो एक डिक्टम बना रखा था लोगों ने, क्या बताते थे कि एक बैक्टीरिया है, क्या 4 दवाई,
1 बैक्टीरिया 2 फेफड़ा 3 दवाई।
हाँ, 1 बैक्टीरिया 2 फेफड़ा 3 दवाई, इतना हम लोगों का करिकुलम होता था पहले लोगों की नज़र में। और मुझे लगता है कि धीरे धीरे हमारे जो डोमेन जो छूटे हुए थे, वो डोमेन कहीं ना कहीं फिर से एक लीडरशिप पोजीशन में आ रहे हैं। और इस रास्ते को दिखाने के लिए हम लोगों के टॉर्च बियरर की भूमिका में रहे प्रोफेसर सूर्यकांत सर हमेशा ही, और उन्होंने इतने बेहतरीन तरीके से हम लोगों को एक सोशल पार्ट भी पढ़ाया। वो ले जाते थे हम लोगों को बहुत गांव तक, जहाँ पे कैंप लगाते थे, जा करके फ्री कैंप चलते थे। हर संडे सैटरडे को हम लोगों का बुकिंग रहता था कि रेजिडेंट को चलना है, 2 रेजिडेंट 3 रेजिडेंट को चलना है। तो ये रास्ता दिखाने का काम भी आपने किया कि किस तरह से हम लोग यहाँ से निकल करके उन लोगों के बीच में, जो लोग ये भी नहीं सोचते कि इतने बड़े संस्थान में जा करके डॉक्टर से मिल लेंगे, और जब हम लोग जाते थे वहाँ पे तो उनको ऐसा ही फील होता था कि कैसे कहीं से किसी दूसरे ग्रह के लोग आ गए हमारे बीच में। ऐसी ऐसी मलिन बस्तियों में, ऐसे ऐसे गांव दूर दराज के क्षेत्रों में सर ने हम लोगों को इंट्रोड्यूस किया। उस विचार को इनकलकेट करने का काम किया कि किस तरह से जो लोग दूर हैं, मेन स्ट्रीम से बाहर हैं, उनको किस तरह से मुख्य धारा के में लाने का जो प्रयास है, किस तरह से उनके दुख दर्द में शामिल होने का प्रयास है, वो लोग हम लोग कर सकते हैं। इसके लिए मैं सर आपको बहुत बहुत धन्यवाद देता हूँ। हमेशा ही हमारे गाइड, हमारे टॉर्च बियरर की तरह से आपका स्नेह हमेशा रहा है। और जब भी ये विभाग बना तब इस विभाग का जो प्रस्ताव था वो भी आपने दिया। उस प्रस्ताव को रविकांत सर ने आगे बढ़ाया, सरकार में भेजा, ये विभाग बना और सूर्यकांत सर को एक फाउंडर HOD का जो यहाँ का भार था, उसके साथ साथ ये भार भी उन्होंने दोनों चलाए। ऐसे हमारे सर हमारे बीच में हमेशा ही हम लोगों के लिए तत्पर हैं। मैं बहुत बहुत धन्यवाद देता हूं सर आपको। जब हम लोग आगे की बात करने लगे और अमेरिका और वहाँ घूम घूम करके हम लोग थक गए और बहुत सारा किराया खर्च हो गया और यहाँ से कोई सपोर्ट मिला नहीं, तो हम लोग 2 बार तो पर्सनली होया एक अमेरिका, अपना पैसा लगा के, यहाँ से पैसा मिला नहीं। तो हमने सोचा कि यहाँ देश में हम लोग पहले अपने जो हमारा टैलेंट है उसी को खोजें। तो इसकी खोज में हम लोग पहुँच गए नारायणा। बादशाह जलाल खान साहब का एक पेशेंट हमारा था जो हमने भेजा वहाँ पे ट्रांसप्लांट के लिए। आपको खुशी होगी ये जान करके कि जो 8 करोड़ में एक रिश्तेदार का हमारे हुआ था, आज नारायणा हेल्थ केयर बेंगलुरु 15 लाख के पैकेज में लंग ट्रांसप्लांट कर रहा है। एफोर्डेबल बनाने का काम जितना देवी शेट्टी साहब के कंट्रीब्यूशंस हैं, नारायणा हेल्थ के जितने कंट्रीब्यूशंस हैं, मुझे नहीं लगता कि प्राइवेट में या कॉरपोरेट में किसी भी हॉस्पिटल ने वो काम किया होगा। मैं तो कहता हूं कि वो हेल्थ केयर के टाटा हैं। अगर उन्होंने इतना काम किया है, 15 लाख। और सर आप मुझे आपने बताया था कि एक ऑटो ड्राइवर का आपने लंग ट्रांसप्लांट किया है, अभी जिंदा है? 3-4 ऐसे लोग जो कुछ नहीं दे सकते। एक ऑटो ड्राइवर क्या दे सकता है? सिर्फ दुआएं दे सकता है, मुझे लगता है। और जैसा सूर्यकांत सर भी कहा करते थे कि दुआओं में बड़ी ताकत होती है। गरीब की दुआ अगर मिलेगी तो ये दुआएं बहुत काम आएंगी, आप लोगों को अभी महसूस नहीं होगा। तो मुझे लगता है कि नारायणा हेल्थ केयर अगर दिन दूनी रात चौगुनी कर रहा है और एक लोगों के दिल में जगह बना रहा है, तो शायद इसी वजह से है कि जो उन्होंने वो काम करके दिखाया है कि गरीब का फेफड़ा प्रत्यारोपण जो हम यहाँ पे सोच रहे हैं वो साउथ में उन्होंने काम करके दिखाया। इसके लिए मैं बहुत बहुत धन्यवाद देता हूँ कि आपने इस प्रोग्राम को लगातार सपोर्ट किया है। बादशाह जलाल खान, उनकी टीम, पुन्नेन सर जो कि सर्जन हैं वो भी आए, उनकी बड़ी टीम रही है, डॉक्टर भागीरथ, उनको भी बहुत बहुत धन्यवाद देता हूँ। जितने भी स्पीकर्स हमारे रहे उन सभी को धन्यवाद देता हूँ। हमारे जो ऐसी भूमिका में रहे हैं डॉक्टर डी बेहरा सर, क्योंकि हम लोग मानते हैं कि अगर गंगा का गौमुख कहीं पे है तो पल्मोनरी मेडिसिन में DM का गौमुख अगर कहें तो वो यहीं पे है, जो चंडीगढ़ में है। सबसे पहला DM प्रोग्राम स्टार्ट किया। ऐसे हमारे सर जिन्होंने लगातार उत्तर प्रदेश का पहला जब प्रोग्राम स्टार्ट करना था तो उन्होंने बहुत हम लोगों को एनकरेज किया लगातार, वो भी हमारे बीच में थे, हर प्रोग्राम में हमारे आ जाते हैं, तो उनको मैं बहुत बहुत धन्यवाद देता हूँ। डॉक्टर ध्रुव चौधरी सर, डॉक्टर आलोकनाथ जो साइंटिफिक चेयर हमारे प्रोग्राम के, को साइंटिफिक चेयर नारायणा से डॉक्टर वासा खान हैं। मैं सभी को धन्यवाद देना चाहता हूं। हमारे बीच में और भी स्पीकर्स हैं, डॉक्टर टंडन यहाँ पे हैं हमारे बीच में, अभिषेक, डॉक्टर दर्शन बजाज जो बहुत ही एनकरेजिंग हैं और बहुत ही अच्छी तरह से हमारे सभी प्रोग्राम्स में शामिल होते हैं और बहुत सारे प्रोग्राम्स ऑर्गेनाइज कर रहे हैं लगातार। और मुझे लगता है कि सूर्यकांत सर अगर डिपार्टमेंट से कोई और वाइब्रेंट फिगर आगे निकल के आ रहे हैं तो उसमें डॉक्टर दर्शन, और दर्शन जब भी हम लोग एग्ज़ाम लेने कहीं भी जाते हैं, मुंबई में DM का एग्ज़ाम लेने गए तो वहाँ सबसे पहले पूछा कि वो आपके यहाँ पे जो डॉक्टर हैं वो, मैंने कहा दर्शन, कि हाँ दर्शन नाम है उनका, डांस करते हैं, डांस। तो कोई भी वजह हो, KCH ने कम से कम आगे बढ़कर के एक लीडरशिप रोल निभाने की कोशिश की है। और मैं तो कहता हूँ, इनसे भी मैं कह रहा था कि राजेंद्र प्रसाद सर और सूर्यकांत सर के बाद अगर किसी को जान गए सबसे ज़्यादा देश में लोग, तो दर्शन को जान गए। तो ऐसे डॉक्टर दर्शन प्रोफेसर हैं हमारे बीच में। अभी हमारे डॉक्टर अशोक यादव साहब, उनको सभी लोग जानते हैं, बहुत ही बड़ी शख्सियत रहे हैं, यहाँ के रेजिडेंट एसोसिएशन के प्रेसिडेंट रहे, पीएमएस एसोसिएशन के प्रेसिडेंट रहे हैं। बड़े बदलाव उन्होंने करवाए हैं सरकार से और बड़ा सम्मान दिलवाने का काम किया। और मेरी टीम, जितने भी हमारे साथी हैं, क्योंकि सर कहते थे, राजेंद्र प्रसाद सर, कि भाई मैं तो कुर्सी डाल के बैठा हूँ आराम से, सब लोग मुझे पूछ रहे हैं आके कि भाई इतना बड़ा प्रोग्राम हो रहा है, आप आराम से बैठे हैं। तो सर कहते थे कि भाई अब हमने दे दिया, सबको डिप्यूट कर दिया और सब लोग अपना देख रहे हैं। तो ऐसा ही अब धीरे धीरे मेरे साथ भी होने लगा है सर, कि जो आपने हम लोगों को सिखाया था वो टीम अब आगे बढ़ रही है और सब लोग जितने हैं, अब मैं भी ऐसे ही मैं बैठा हुआ दिखाई दे आऊँगा आपको कि बैठा हुआ, टेंशन कम हो गई है। तो ऐसी हमारी टीम, जिसमें डॉक्टर सचिन हैं, डॉक्टर आरिफ, डॉक्टर अनुराग, डॉक्टर ऋचा, डॉक्टर यश, दीपक शर्मा और शुभ्रा नहीं है बीच में। शुभ्रा भी जितना कोशिश कर सकती है, उसे गोल्ड मेडल इस बार मिला है सर, लेकिन उसका पैर में चोट लगी तो वो ज़्यादा एक्टिवली नहीं आ पाई है। उनको भी बहुत धन्यवाद देता हूँ। हमारे एसआर सभी, डॉक्टर हर्षिता स्पेशली बहुत ही डायनेमिक हैं, बहुत मेहनत कर रहे हैं ये लोग, पूरी टीम, सीनियर रेजिडेंट्स, जूनियर रेजिडेंट्स और स्टाफ, नर्सिंग ऑफिसर्स, सभी लोग, टेक्नीशियंस, विभाग के जो हमारे सबसे ज़्यादा जिन लोगों को हम लोग सबसे ज़्यादा डांट खाने वाला जिन्हें कहें, इस तरह के हमारे राजन यादव, ऐसे हमारे जो गोस्वामी जी हैं, उनको भी धन्यवाद देता हूँ। और भी हमारे ऑफिस के जो बैक स्टाफ हैं, सभी को धन्यवाद देता हूँ। मंजू, आपने बहुत सही याद दिला दिया सर, नहीं तो पता नहीं घर पे जाके क्या होता। मंजू सामने विराजमान है, तो मुझे लगा, मैं इधर ध्यान ही नहीं गया, आपने बचा लिया सर। अब जितना भी हम लोग यहाँ पे रहते हैं एक्स्ट्रा, तो आप जानते हैं, प्रसाद सर भी इस बात को कहते थे, मैडम आती थी जब, कि भाई जो भी फ्लाइंग चेस्ट फिजिशियन अगर बने हैं तो इन्हीं की वजह से, क्योंकि ये फ्लाइंग में रहते हैं तो पीछे बच्चों को कौन देखे, तो उनको मैडम देखती थी। तो ऐसा ही काम मंजू कर रही हैं, बच्चों की पेरेंट टीचिंग, पीटीएम हो या कब एग्ज़ाम है, बीच में पूछ लेती हैं, तो आपको पता है कि एग्ज़ाम कब है बच्चों का? मैं कहा मुझे नहीं पता है भाई, कब है तुम बता दो कब है, कि कब है तब है, पीटीएम कब हो गई मुझे पता ही नहीं रहता है। तो ऐसा जो जितना भी घर का जो समस्याएं हैं, झगड़े हैं, झगड़ा कम हो गया, क्योंकि जब उम्मीदें कम हो जाती हैं तो झगड़ा भी कम हो जाता है। उन्हें पता है कि ये शायद इसी काम के लिए हैं, यही काम करेंगे, तो मुझे लिबरेट कर दिया है काफ़ी हद तक। तो इस लिबरेट करने के लिए मैं मंजू को बहुत बहुत धन्यवाद देता हूँ कि उन्होंने घर को कम से कम उस तरह से संभाल लिया, बच्चों को देख लिया है पूरा। इसके अतिरिक्त जो फैकल्टी हैं हमारे, डॉक्टर सीफार के सत्येंद्र, जिन्होंने हमारे साथ बहुत सारा काम किया, डॉक्टर अंजना, जो काफ़ी रिसर्च हम लोगों की पब्लिश हुई हैं, बड़े इम्पैक्ट के फैक्टर्स में हैं उनकी रिसर्च, और तमाम लोग, और साथ ही साथ जो ये हो पा रहा है, क्योंकि हमारे फार्मा इंडस्ट्री हमारी ज़रूरत है, जैसे उनका काम हमारे बिना नहीं चलता है, तो हमारा काम भी उनके बिना चलता नहीं है। ऐसे हमारे एमएसडी, सिप्ला, एमएसएन, ल्यूपिन, ग्लेनमार्क, फाइजर, सभी को मैं धन्यवाद देता हूं कि उन्होंने इसमें पार्टिसिपेट किया, हमारे प्रोग्राम को सफल बनाने के लिए उन्होंने प्रयास किया, हम लोगों पे भरोसा रखा। और अभी एक लाइटर नोट पे ये बात हो रही थी कि हमारे बोले ये प्रोग्राम ऐसा है कि यहाँ पे इंडस्ट्री वाले लोगों को बड़ा सम्मान मिलता है, ये लोग कह रहे थे कई सारे अभी, तो मैं इसीलिए कह रहा था कि उनके बिना काम चलना नहीं है हम लोगों का। एक में हमने अगर पैसा ले लिया और उनकी ढंग से खातिरदारी नहीं हुई, खाना वाना नहीं खिलाया, तो अगले वाले में वो फिर फ़ोन बंद कर लेते हैं। हम लोग पीछे घूमते रहते हैं कि कहाँ हैं भाई सिप्ला वाले, कि पता चले सर वो अभी गए हैं, अभी आएंगे। और आते हैं तब जब प्रोग्राम निकल जाता है बोले हमें पता ही नहीं चला, लेट हो गए सर। तो इसलिए हम लोग उनको बढ़िया खातिरदारी करते हैं यहाँ पे। पिछले प्रोग्राम में सर हमारी फैकल्टी ने वो ये हिसाब लेकर के आए थे जो हमारा प्रोग्राम कराया था सरदार जी, कि बोले सर इतने 4.5 लाख की दारू। मैंने कहा भाई कैसे, हमारे तो 10-12 फैकल्टी थे, बाकी तो कोई थे इकाई कौन में। बोले 50,000 की उन्होंने लिए सर और 4 लाख की इंडस्ट्री वालों ने लिए। तो इसलिए कुछ आप लोग वसूली भी अच्छी कर लेते हैं। कुछ लोग ऐसे हैं कि कई सारे कम कंट्रीब्यूशन है लेकिन चलता है। हमने कहा भाई चलने दो, इन्हीं का शो है, यही करेंगे। तो मैं आप सबको धन्यवाद देता हूं कि आप लोग लगातार हम लोग भरोसा करते हैं, हैंड होल्डिंग करते हैं, इन प्रोग्राम्स को सफल बनाने के लिए लगातार आपकी कोशिश रहती है। इसके अलावा इंदर मोहन जी, जिनको अभी पिछला 17 लाख उनका बकाया हमारे ऊपर है, फिर भी प्रोग्राम हो रहा है, क्रेडिट पे चल रहा है पूरा। और जो टिकट्स कराते हैं यस हॉलीडेज़, वो भी हम लोगों को 3 लाख रुपए बकाया है उनका हमारे ऊपर, लेकिन काम चल रहा है। ऐसे ही हमारे ये हैं जो लाइट साउंड वाले, ये राजेंद्र प्रसाद सर के शिष्य हैं और कपूर साहब, और इन्होंने पिछले 2 प्रोग्राम का पैसा ही लेने नहीं आए हैं। ये इन्होंने कहीं से सुन लिया होगा कि पैसा वहाँ है नहीं, लेकिन अभी ये प्रोग्राम फिर से आ गए करने। कल मुझे पता चला कि ये प्रोग्राम करने आ गए। मैंने कहा इनको तो बुलाया नहीं था, तो असिस्टेंट प्रोफेसर बोले हमने बुला लिया था। मैंने कहा तुम्हारे कहने से आगे पैसा मिला नहीं। तो ऐसे कपूर साहब को भी धन्यवाद देता हूँ। जितने भी हमारे विभाग के सब, जिनको मैं रह गया हो किसी का नाम, उन सबको धन्यवाद देता हूँ। जो KCH है रेस्पिरेटरी मेडिसिन, उसके सभी रेजिडेंट, सभी फैकल्टी, सभी को धन्यवाद देता हूँ। RML के डिपार्टमेंट से सभी को धन्यवाद देता हूँ। PGI के डिपार्टमेंट से सबको, अभी मैक्स, मेदांता, अपोलो, बाकी सभी जितने भी मेडिकल संस्थान हैं, वहाँ से जितने भी फैकल्टी ने पार्टिसिपेट किया है, रेजिडेंट्स ने पार्टिसिपेट किया है, बलरामपुर सिविल हॉस्पिटल से जिन्होंने किया, जो छूट गए हों उनसे माफ़ी भी चाहता हूँ, और सभी को मैं बहुत बहुत धन्यवाद देता हूँ। बहुत बहुत धन्यवाद।
Thank you, sir. May I request everyone to kindly rise for the national anthem.
उनको बुलाना है, 2 बच्चे जो हैं आगे आगे आ जाइए, आप लोग आगे आ जाइए। यहाँ पे बुके लेके आ जाओ भाई, ये सैपलिंग लेके आ जाइए, एक आ जाओ, अपना इंट्रोडक्शन दे दो इस पे आके। भाई कमाल हो गया कि जिन्होंने जीता है अवार्ड, बताइए अपना इंट्रोडक्शन दे।
Myself, Dr. Bharat Verma, DNB resident, Civil Hospital, Hazratganj.
Dr. Harshita Gulshrestha, DNB resident, Civil Hospital.
आप लोग इकट्ठे बैठे देगा दोनों, अलग अलग थे?
थोड़ा दूर।
100% अचीव किया है आप लोगों ने। आइए सर, आगे आ जाओ आप। इनको मिलता है गिफ्ट हैम्पर। गिफ्ट हैम्पर ये नहीं है, गिफ्ट हैम्पर इनका है कि जो आने वाली नेटकॉन है जयपुर, उसमें इनका रजिस्ट्रेशन, इनका ट्रेवल, इनका स्टे सब है ना सर? एवरीथिंग इज स्पॉन्सर्ड बाय इंडियन अरे हो गया, तुमने कह दिया सब खरीद मिलेगा, ये सब खरीद मिलेगा। डॉक्टर भारत और डॉक्टर हर्षिता और हमारी व्यस्तता है, लेकिन वो काम में नहीं लगी है कि हमने क्वेश्चन देखा ही नहीं, मिला ही नहीं।
मैं वहाँ तक किसी जमाने में इंस्पेक्टर बन के गया।
बहुत अच्छा काम करके आए सर आप। क्या आपने काम करके आए सर? वो
वहाँ की DNB डिरेक्टराइज हो गई, दोबारा वहाँ पर उसको रिस्पॉन्स कराया है।
और आप लोग मेहनत करिए। DNB के कई हमारे रेजिडेंट्स हैं जिन्होंने DF किया, इसलिए अब यहाँ रुकना नहीं।
ये बच्चे काफी मेहनत कर रहे हैं सर।
आप लोगों ने MBBS कहाँ
ये सिर्फ ही मेरे PGI होता है। अरे वहाँ पे ग्रुप कराए थे। आइए
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब